Isn't I good? Yeah, I'm fine. What do you mean? Happy faces. AI. Huawei. Yeah, so yeah. Talk now. There you go.
I introduce you to us.
Just want to.
Vai meu to presidente.
That's good. Have you met our guest speaker?
Professional one. Can I do that?
I can sit. I can sit here. Okay.
Yeah, yeah. But they also want to.
How are we supposed to?
Okay.
There's no way you won't.
It's now they're letting people in without. Exactly.
And I went to Mandela.
I don't know this guy, and I'm supposed to. Bio, bio. Oh, but the long one is Prof. Ains. Yo, at the conference, I was like, I must go drink some water and come back and read. And then he said, no, stop now. See. And the one that,
1,000 word that gave you. I don't know.
that was
They-
Des.
Oh,
From Blue Sky Zimkit.
I'm seeing faces I haven't met.
Vice chairperson of the association.
okay.
Yes.
Our
Yeah.
video. Mo's coming. I'm gonna have you in a tracksuit next time. Thank you.
That's the president, Professor Mabeng. They're intense and they're very young. I mean, I know.
Yeah.
That's great.
Oh, so they can see us online.
They sing us.
Support so when he called, I was like, I know. Oh, you've met with Rupin, yes. President.
How are you, Prof?
Finally.
Good, good.
Thanks.
Many times.
Will, how are
So
you doing?
stretching people in person.
No, we'll find time and
Find a
date.
corner for myself.
Oh, Malays, Malay. But yesterday, what I like about her, she puts on, and she works like, sometimes she works like she's an administrator. All of that. But when I you work, remember, I used to describe you as what's the name is the term I was using for you, about the person who likes black accent. And also being a platform, because it's one thing to say that, but providing them a platform to grow. And then it's when I'm the power of money.
Wenze umbuka wayephayana ngo-1980.
Let's take a look. Oh, understand?
Listen, I had found a reason to shout at you. I had found a reason.
Ingxaki nje izinto ezininzi apha. Hey, but you know about the other guy who was gone. No, but I mean the guy was like. So you really, I should have done bad. Yeah, but I think I'm happy. I think I'm happy. But I feel bad.
Good morning, everyone. Apologies for the late start. Unfortunately, we didn't realize there would be a bottleneck with security out in front. But I'm sure that we will be able to catch up as we go along in terms of time. Before we start our official program, I'm going to call Mr. Gene Zhang, the CEO of Huawei, who will welcome us to this podium, which they've sponsored for today's event. Mr. Zhang.
Thank you. Dear Professor Mafantiso, Mabangi, and leaderships, esteemed guests, healthcare professionals, thought leaders, and industry pioneers, good morning. It is a true honor for me to welcome you all to this highly anticipated healthcare roundtable focused on artificial intelligence. I would like to express my heartfelt gratitude to Sama for allowing us to host this year's roundtable, as well as thank you to BISEX for this opportunity to showcase what we do in the healthcare industry. At Huawei, we have always believed that technology should serve as an enabler to drive progress, and nowhere is this more evident than in the healthcare industry. The possibilities we now have with AI in healthcare are not just exciting, they are transformative. Today, we are here to discuss how AI can revolutionize the way we deliver healthcare, improve patient outcomes, and overcome some of the most pressing challenges in the industry. As the CEO of Huawei South Africa Enterprise Business, I'm proud to be part of this journey and to witness the incredible potential of AI in healthcare unfolding before our eyes. We know that the global healthcare landscape faces many challenges. Again, aging populations, an increasing burden of chronic diseases, and the need for more efficient, accessible, and cost-effective healthcare services. And that's where AI can make the significant impact. It allow us to analyze vast amounts of data quickly, predict health trends, and make more informed decisions that benefit both patients and healthcare providers. At Huawei, we've always been committed to innovation. For over 30 years, we've been at the forefront of digital transformation, helping industries across the world embrace the power of technology to enhance their operations. The health industry is no exception. Whether it's through smart hospital solutions, AI-enhanced diagnostic tools, or health data management platforms, Huawei's cutting-edge technology is helping to drive more efficient, precise, and timely healthcare services. We are harnessing the power of cloud computing, big data, and AI to create smarter, more connected healthcare environment. One example that we are particularly excited about is our collaboration with hospitals to develop AI-driven imaging solutions. These solutions are already improving early, early detection of diseases such as cancer and heart disease by enhancing the accuracy and speed of medicine imaging analysis. We believe these advancements are just the beginning of the AI's potential in healthcare. However, no single company, no single technology can solve these challenges alone. It will take collaborative approach between healthcare providers, technology innovators, policy makers, and of course, patients. As we explore the full potential of AI in healthcare, we must keep in mind the ethical considerations, the regulatory frameworks, and the privacy concerns that are so crucial in this sensitive field. Once again, thank you for joining us today. We are excited to be part of this important conversation, and I look forward to the fruitful discussions that will take place throughout this roundtable. Let's continue to innovate, collaborate, and pave the way to bring digital to every person, home, and organization for the fully uh, connected, intelligent world. Thank you. Thank you very much.
Thank you so much for that warm welcome, CEO of Huawei. And once again, good morning, everyone. Um, I'm Ames Dai, Vice Chair of the South African Medical Association and Chair of the Education, Science and Technology Committee of the association, whose special project is AI in healthcare, hence this round table. So before we begin, I'm just going to quickly go through some housekeeping. Please ensure your mobile phones are on silent. Restrooms are on either side of the lifts. In case of emergency or fire, the exits are down the stairs and through the main entrance doors. Refreshments will be served during tea break and lunch will follow later in the program. We are going to encourage active engagement. So at the opportunities for discussion and engagement, please make the most of it. For those that require CPD points, please don't forget to sign in and out each day. There's a CPD Health Professions Council register for attendance, and that's on the registration table in the foyer. And please don't forget to visit the exhibitor stands, which are through the door on your right-hand side. So with the housekeeping taken care of, it's now my great pleasure to introduce Dr. Mvuyisi Mzukwa, who's the chairman of the South African Medical Association Board. He's a family practitioner and has been practicing in private practice in Durban for more than 10 years. He obtained his medical degree and diploma in occupational health from the University of KwaZulu-Natal, and he's currently studying towards a Master's of Science in Diabetes at Warwick University in Ireland. He's a medical ethics committee member, a socio-medical affairs member, and a review committee member of the World Medical Association. He's also served on the World Medical Association Council. He serves as a board member at the Foundation for Professional Development. Dr. Mzukwa, over to you.
Thank you, Program Director. The President of the Association, Prof. Mabenge, the Vice Chair of the Association, Prof. Dai, the CEO of the Association, and also I would like to recognize the CEO of Huawei, and also Prof. Pillay, who's coming from the US as well. It was my introduction, Mvuisi Mzukwa. I would like to say good morning to you, ladies and gentlemen. It is my great honor and privilege to welcome you all this morning to this pivotal roundtable discussion. It is hosted by this SA Medical Association, which aims to explore the transformative role of artificial intelligence, machine learning, and technology, specifically in South Africa's healthcare system. To our esteemed medical professionals, the policymakers, AI experts, academia, government, and media representatives, and all distinguished guests, thank you for joining us. Today's discussions and conversations are a critical step for the future of healthcare in our nation. My role has been made simply easy this morning, just to welcome you all and allow for our experts to lead discussions of the day. Tomorrow we'll be joined by the Honorable Minister of Education, Science and Innovation, Professor Blade Nzimande, who will provide us with insights and government's plan on AI. In a country as diverse and dynamic as South Africa, our healthcare system faces unique challenges and very different to other nations. This is an important element for us to factor in as we deliberate on these discussions. From rural healthcare disparities to resource constraints, particularly in our public health system, the need for innovative solutions has never been greater. Today, we stand at a junction of opportunity and responsibility, as advancement in AI offers us tools that can revolutionize patient care, enhance operational efficiency with our health systems, and address deep-seated inequities that we face as a country. The purpose of this roundtable is not merely to envision possibilities, but to identify actionable solutions towards the ethical and equitable integration of AI in our healthcare system. To achieve this, our discussions will revolve around these critical areas, amongst others. We begin by assessing where we stand. While strides have been made in telemedicine, data analytics, and digital record systems, the question remains, are we harnessing AI's potential to its fullest? What lessons can we draw from both global advancements and local innovations to ensure that we are not left behind as the country? South Africa faces pressing healthcare issues, we all know, including the high burden of both communicable and non-communicable diseases, shortages of staff, healthcare professionals, poor infrastructure, and failing health system, and disparities in access to care. AI can be a powerful ally in tackling these challenges, whether through early diagnosis of disease, predictive analytics to manage outbreaks, or optimizing resource allocation. However, we must explore these technologies and we need to benefit all the sectors of society, from urban centers to our most remote communities. As we deliberate on these topics over the next 2 days, let us remain anchored in the values that define our nation. Ubuntu, the belief in a shared humanity, and a commitment to equity. AI should not deepen divides, but rather bridge the gaps, ensuring that every South African, regardless of the circumstances or backgrounds, benefits from this technological advancement in healthcare. And as healthcare professionals, our goal is to bring firsthand the insights into patient needs, preserve our profession, and ultimately provide solutions for the health of the nation. So in closing, I would like to encourage each of you to engage openly, share your expertise generously, and challenge us, all of us, to think boldly and disruptively, yet responsibly. Together we can chart a course that ensures AI and innovation not only meets the needs of today, but anticipates and addresses the challenges of tomorrow. I would like to thank you, and I look forward to the insights and solutions that will emerge from our discussions. Let us make these 2 days our visionary engagement, collaboration, and progress. Enkosi. Thank you. I thought I was going to escape this, but I'm asked to introduce the CEO of the association. Just a minute. As we all know, Dr. Mzulungile Nodigida, Mzu, is the SAMA Chief Executive Officer, and Dr. Nodigida is a dedicated and accomplished medical doctor who attained his undergraduate medical degree from the University of Villa Clara in Cuba. It is complemented by a diploma in obstetrics from the Colleges of Medicine of South Africa. He possesses a Master of Business Administration from Rhodes University and an Executive Master's in Public Health, EMPH, from Peking University, Beijing in China. He is proficient in corporate governance, financial markets, and adept in leadership roles within the medical associations and healthcare administration. With that, colleagues, I would like you to allow me to welcome Dr. Nodigida to come to the stage.
We all have speeches here that I must find mine quickly. Good morning, everyone. As have been introduced, I'm Dr. Mzulungile Nodigida, and I'm the Chief Executive Officer of the South African Medical Association. So let me take this opportunity to greet the President of the Association, the Chairperson of the Association, the Vice Chair of the Association, the CEO of Huawei, Prof. Ruben Pillay, distinguished guests, colleagues, thought leaders in healthcare and in AI. It is both a privilege and a pleasure to welcome you to this roundtable where we will come together and explore some of the most or maybe one of the most transformative uh, topics in modern healthcare, and that is artificial intelligence. Um, just to go off script for once and share something personal that maybe few of you know about me. So my first love was not medicine when I was in high school. So I knew straight after matric that I would go and study BSc in information systems. And I knew where I wanted to go and study that. But because of the times, I actually didn't do well in my African, so, and that counted against my application in that university I wanted to go to. So then because I did fairly well in high school, so I then got the scholarship to study medicine. So I am a bit, I'm both excited that it looks like today my two worlds are actually coming together. And I also want to thank whoever decided on the building blocks of healthcare from a WHO point of view, that information systems was then added as part of those key building blocks, which is one of the things that we're driving as a medical association as a vehicle towards universal health coverage, because finance is just but one of the building blocks. There are 6 of them. So that's something that you might not know about me, but I thought maybe I should share it today. So today we begin a journey to understand how responsible use of AI can promote innovation, address long-standing challenges, and reimagine healthcare delivery for the benefit of both urban and rural settings, because we've got both in South Africa. We've got urban, we've got rural settings. So today our key address is titled Responsible Use of AI Fostering Innovation in Healthcare, will set the stage for the day by highlighting the ethical frameworks and strategic opportunities that accompany AI integration into healthcare. Following this, we'll delve into the current state of AI and technology in healthcare, examining its existing applications in South Africa and beyond, with an insight case study to illustrate its real-world impact. So just recently, as the South African Medical Association, we participated in a webinar organized by the WMA, which is the World Medical Association. There's a study that they've conducted among medical associations across the globe. And one of the key findings there, which will be interesting to find out in South Africa and in the African region, is that 72% of all medical associations that were surveyed by the WMA, they believe that the benefits of AI integration in healthcare actually outweighs the risks that AI might replace doctors. So there's hope even from professionals. I mean, there's been this narrative that doctors are fearful of AI, but that survey, 72% of them say actually the benefits outweigh the risk. So as we move through the day, our discussions will touch on a broad spectrum of critical issues, bridging the gap in rural and underserved areas through AI and enabling solutions, addressing one of South Africa's most pressing healthcare challenges. So I know we have partners here today. We've got Discovery, we've got GEMS, we've got almost everybody here. And for me, I think the most important thing is to start as the profession and as leaders within the health sector, is to start thinking almost centralizing whatever thought processes and solutions we have towards the health of the nation. Because if we start thinking like that and we bridge the gap between the rich and the poor, the urban people and the rural settings, we then start to solve the problems that the health system is facing. I know some of the applications are already being used in the private sector, but how do we make How do we take those expertise, and make sure that we integrate them into the public health system? So without wasting time, I think I should be thanking everyone, especially our sponsors, for hosting us here today. And I think, to my fellow CEO of Huawei, this is just the beginning, and we will then be able to take this forward. I'm not sure about an annual AI conference, Prof. Ames, but these are things that we should explore. And thank you very much for hosting us, and thank you very much for joining us today. I hope you'll enjoy the next 2 days. Thank you very much. Oh, I've got another role. Oh, I forgot. Okay. All right. So it looks like if you speak, you must then introduce. I didn't know this, Chairperson. You didn't warn me. So if you speak, you then have a responsibility to introduce the next speaker. So it is an honor and pleasure for me to introduce to you, colleagues, Prof. Ruben Pillay, who I met some time ago. I think I was a student in some Caribbean island somewhere. But Dr. Ruben Pillay is a globally recognized expert in healthcare innovation and a pioneer in leveraging artificial intelligence to revolutionize the future of healthcare. With a unique blend of clinical expertise, academic rigor, and entrepreneurial insights, Dr. Pillay has dedicated his career to advancing transformative solutions that enhance patient outcomes, optimize healthcare delivery, and promote sustainability. As a professor, author, and a healthcare executive, Dr. Pillay has spearheaded numerous initiatives in the intersection of medicine and technology, including AI-driven care models and digital health strategies. He's the author of groundbreaking books, including, I hope one of them you will find somewhere, Now to Next, The Future of Healthcare and AI, and is it the Quintuple Aim, Revolutionizing Healthcare for Better Outcomes, which explore the roles of technology and reshaping global health systems. Dr. Pillay's work bridges innovation and equity and ensures that technological advancements are accessible and impactful across diverse populations. I think that's critical. His visionary approach positions him as a leading voice in the conversations about how AI can address healthcare challenges while upholding foundational principles of patient care. Today, Dr. Pillay will share his insights on the transformative potential of AI in healthcare and the ethical imperative to harness these technologies responsibly to build a sustainable, equitable, and an innovative future for all, not for some, for all. So thank you very much. I give you Prof. Ruben Pillay, ladies and gentlemen.
Thank you so much, Mzu. I really appreciate this. It's always fantastic, when you are invited to keynote a conference that's hosted by somebody that you've mentored and coached for God knows 20 odd years. So I'm really proud of you. You did a fantastic job. Yeah, I'm really thrilled to be here. One, because I get to come home, and two, that I traveled the world talking about how to leverage technology and artificial intelligence, amongst others. And I always wondered when I would be coming to South Africa to talk about artificial intelligence and technology. So I think it's time, yes. And I'm really glad that Sama has taken the lead to kind of kick off the conversation, because we really are at a unique time. Never before have we been in this position where we can solve the challenges facing us in health and healthcare. Now, I've been around, some of you have too, for decades. And we have the same conversation year in and year out in terms of how do we address these issues of cost, quality, and access. And I can tell you, if we do not leverage artificial intelligence and digital technology we will still continue to have these conversations moving forward. So what I'm going to do today is take you on somewhat of a journey to show you how technology has this opportunity to radically reframe our definition of healthcare, our definition of who a healthcare provider should be, our definition of what's the truth in healthcare. Should we question the current scientific method that we use? Should we question how we remunerate and pay for healthcare? Should we question what are the appropriate models to deliver care? Are these models actually achieving the purpose that they should? And the answer to pretty much all of those is no. Okay, and that's reflected in the outcomes that we see today. Nothing short of a revolutionary approach to transformation is going to address these challenges. I always love to open my presentations with a quote by George Bernard Shaw. I hope you can see it from where you are, but I'll read it. The reasonable man or woman adapts himself to the world. The unreasonable one persists in trying to adapt the world to himself or herself. Therefore, all progress depends on the unreasonable man or woman. Let that sink in. And I think as you engage yourself in discourse today and tomorrow, ask yourself, am I proposing reasonable suggestions? Because if that's the case, then we're not going to address the challenges that we are facing. We really need a radical rethink. And I think that's the purpose of occasions like this, where you have an opportunity to, exercise your creativity, exercise your innovative capability, and hopefully your entrepreneurial spirit. And what I'm hoping is just to sow the seed that will allow you to have those discussions. Now, a lot of my work is framed as medical futurism. It sounds sexy, but it's somewhat scientific based. There's two laws you have to kind of remember, two laws that we use to help us map the future. One is the law of exponentiality, and this obviously comes from the chip industry, where capacity and capability doubles every year. And you can see the difference between exponentiality and linearity. Okay, as humans, we think linearly, but technology improves at an exponential pace. And what you really have to remember is, once you digitize technology, the possibilities become endless. The most important outcome is democratization, meaning we can make access to something, we can make that accessible to every single individual. We demonetize, it becomes free. And we dematerialize, things become small. So the outcome of exponentiality are kind of three critical things that healthcare needs: access, cost, and commoditization. So we have to pursue and persevere, with this concept of digitization, okay? And we're really fortunate that there's very little that we aren't able to digitize today. As you can see from this graphic, the outcome of exponentiality is things become smaller, better, cheaper, and faster. You can look at what a 5 megabyte hard drive looked like in '56 and a 2 nanobyte chip today. Okay, that's exponentiality for you. Okay, now to give you a tangible example, your telephone has been on an exponential pathway. You could see initially, it was linear and the progress was pretty slow. We hit the bend of the curve around about, the early 2000s, when telephone technology converged with connectivity and internet, and we had the smartphone. Okay. Well, the smartphone is on an exponential pathway as well. Remember, things become democratized, they become demonetized, and they dematerialize. Okay? So what's the next step? How many of you have the latest smartphones in your pockets? Yeah, a couple of you. That's iPhone 16. What if I tell you that's outdated already? Okay, so you're actually sitting with technology that's outdated because exponentiality kind of gives us the pathway to this.
Sorry, this is my wife. I'm gonna have to get this. Hello? Hey, Beth.
Okay, that's your new smartphone. Okay, that's the concept of dematerialization and democratization. Okay, now dematerialization also means that, you know, things disappear. Okay, you know, medical technology and medical devices pretty much don't exist anymore. You could use a 30-second video on your smartphone to do a pretty comprehensive clinical assessment that requires no medical technology or no medical devices. Okay, that's another example of exponentiality. The real power of exponentiality, by the way, is when two exponential technologies converge, when they clash. Okay, this is an example of 3D printing clashing with stem cell technology. And what you get is the ability to 3D print organs. Okay, this is a real example, by the way, of 3D printing of corneas. This is Newcastle University. It takes about 6 minutes to 3D print a cornea. Okay, and you could see the potential that this convergence holds for the future of healthcare. That we are actually going to be a position, and by the way, already are, to start 3D printing a host of organs, kidneys, hearts, etc., etc. Okay, so that's the whole concept of exponentiality. So just remember that. Okay, when you digitize something, it becomes smaller, cheaper, and faster. It becomes commoditized, and we can put that in the hand of the consumer. That's the outcome. The other law you have to remember is what's called Amara's law. Okay, Amara's law says that, you know, generally in the beginning of technology, we tend to overestimate the outcome and impact, but in the long run, we underestimate it. Okay, so when smartphones were first released, we overestimated it as phone technology. Okay, we really raved about the new phone, but we underestimated the impact on society. Okay, the smartphone has radically changed your life in every single aspect. Okay, we never factored that in. Now, this is really important because this is where we are with AI today. We're in this time where we're overestimating the potential for AI, especially in the field of medicine, but we're underestimating the long-term impact. I can tell you, AI is going to transform society like humanity has never experienced before. So you really have to brace yourself for the potential of AI. Bear in mind, as humans, we have never ever coexisted with something that's more intelligent than us. Never. We're about a decade away from that. What does that mean for us as humans? What does that mean for our sustainability? Okay, so that's what Amara's law says. We tend to overestimate in the beginning, underestimate that. And that kind of underestimation is really important because we have to start, you know, having a robust discussion about AI, not just in medicine or in different industries, but what is the impact of AI going to be on us, you know, as human beings in society in general? So really good questions to answer. You know, for decades, healthcare has always been innovative. You know, you can argue we are one of the most innovative industries and sectors there is from a technology point of view. Now, we've never been short of innovation, never. Okay? And, you know, all you have to do is look at the patents filed and FDA clearances and CE clearances. What we struggle with doing is translating the technology to outcomes. How is it possible that in pretty much every other industry, when you introduce technology, productivity goes up. In other words, access to the product or services goes up and prices come down. The reason that all of you drove to work today in your own car, that every single one of you has a smart device, some of you have 2 or 3, the only reason you're able to do that is because those industries were able to translate their technology into productivity. Healthcare, by the way, is unique in the sense that whenever we introduce technology, access goes down and prices go up. How do you explain that? Okay, and we will never address that issue with our current way of doing things. We really have to rethink every single thing that we do, because the reality is the data and the outcome seems to suggest that the trajectory that we're on, and we have been for decades, is not working. So when you gather as groups like you do, you should gather to discuss how do we rethink, not how do we incrementally improve. Okay? Because I think we've passed that stage of incrementalism. And one of the big reasons that we fail to do this in healthcare, because we are really bad at unlearning. Now, I'll tell you, progress does not come from learning. If you've always thought that progress comes from learning, you're wrong. Progress comes from learning conditional upon you unlearning. Okay? If you don't unlearn, you cannot capitalize on innovation and technology. You know? And in medicine and in healthcare, we are particularly bad at unlearning. And that's one of the key constraints in terms of why we're not able to execute. I think this African proverb sums up what I'm talking about. A cat that dreams of becoming a lion must lose its appetite for rats. That's the kind of question you're going to have to answer after day 2. How do we lose our appetite for rats if we want to become lions? That's easier said than done, but it's a pretty compelling question. Okay, so very quickly, I'm not sure what your background is in AI, but I'll spend 2 or 3 minutes kind of taking you through this. By the way, it's not a new concept. It's been around about 70 years. It's been through a few winters. But, for the very first time, we had this kind of perfect collision of computing power, of the existence of algorithms and digital information to actually, drive the development of artificial intelligence, okay? Let's do a quick test. Which one is real and which is AI generated? Guess. Well, not guess. Who says, so that's your right and this is your left. Okay, let's take it. Who says you're right? Hands up. You guys are not committing. Who says the left? Okay, so the right is real or AI? Real. Okay, you got that right. For those of you who guessed yeah, you got that wrong. So less than half the room got it right. Another one, which is real, left or right? And now you see the problem. As humans, you can't make the difference out, and you're very judgmental when it comes to technology. Okay, so yeah. Okay, so this is real. Anyway, it's a pretty good test here. Okay, so why do we need AI in healthcare? The reality is we have tons and tons of data, but very little insight. Okay, that's one of the big issues we face. If you look at the amount of data we produce at an individual level, we aren't able to translate that into insight. I'm a practicing physician. Do you know how much of actual data that we use in clinical decision making? Any guesses? How much of data do you use at the point of care to make decisions? Any clinicians in the room? There should be a lot of you. Take a guess. It's easy. It's between 0 and 100. Okay, how much of data do you use in clinical decision making? How much? 3%. Okay, that's this profession of ours that claims to be based on science. We don't bring to bear any of that science in care delivery. But one of that is our processing capability, which is one of the advantages that AI brings. Okay, so you're going to hear terms about like artificial intelligence, machine learning, deep learning, and now kind of generative AI with ChatGPT, etc. Okay, so put very simply, AI is just a broad field of study. It's this field of study where we try and understand how machines can think like humans. That's what it is. Okay. Machine learning is actually where we train the machines to figure out patterns. Okay, so this is machine learning. We take data or we label them. That's an owl, that's a squirrel, that's a fox. We feed the system, okay, and with time, the system's able to tell us this is an owl, fox, and squirrel. Okay, this is machine learning, not rocket science. Okay, simple. It's the same thing. You could take an X-ray image and you could label the image, and essentially you train the system, okay, and the outcome will be what you've trained it for. Okay, so ultimately you then put in unlabeled data, and the machine is able to say, well, this is a nodule or not. Okay, so this is machine learning, pretty simple. The other is, well, as you can see, it's not that easy. You can also confuse machine learning models as well. So it takes a long time to get this right. Okay. Now this is deep learning. Okay, you get deep learning. Now deep learning operates like pretty much like us. This is how our brain works, by the way. And if you didn't know how your brain works, this is it. You got a whole lot of neurons, and these neurons are actually, your senses. They're getting input, and what your brain does is it's weighting the input. Okay, so if I look at a cat, I can see a cat, I can maybe smell it, I can maybe feel it, and I'm kind of taking that in, and my brain is very quickly calculating the probability that this is a cat and not a lion. So it's going back to my previous experience, and it's allocating weights or scores or probabilities. Okay, and that's this whole concept of deep learning. Okay, it's the same thing. Now, this is how deep learning works. It's exactly the same way. You feed a computer an image or something, it's going to try and find the patterns, and eventually what it's doing is it's allocating probabilities until it gets to the answer. Okay, in my case, the cat. In this case, maybe the interpretation of an image. Okay, so once again, deep learning is not that complicated as well. Now, generative AI is a part of deep learning. Okay, it's the same concept. Okay, so you type something into ChatGPT. How does it actually give you an answer? It's the same concept because it's deep learning. It's calculating the probability of what the next word would be. So essentially, if you got there, the cat likes to sleep in the, it's the same thing. So it's calculating probabilities of the next word, and you could see the probability scores. Box is the answer. Okay, so AI 101, not very complicated. This is pretty much all you need to know at your level, unless you want to go and do a degree in AI. Okay, you could see over the years, well, not over the years, over the last 4 or 5 years, AI has increased significantly. Okay, it is improving pretty much on a day-to-day basis. I showed you the graph of exponentiality that shows that technology doubles every year. AI doubles every 6 months. Okay, and what makes AI particularly powerful is we're using AI to develop AI tools to help develop AI. So it's this kind of real virtuous cycle that's driving the development at a rapid rate. Now you can see the human baseline, that's not going to change. It's never ever going to change, okay? But you can already see in some modalities that AI is already superseding humans, especially in image classification. And this is why you see some of the most progressive disciplines in medicine are disciplines that require image classification, radiology, pathology, dermatology, okay? Now, there's a lot of out there about hallucination and about truthfulness of AI. That is somewhat of an issue, but you can see just in the last 2 or 3 years, the factuality or truthfulness of AI has improved tremendously. Now, I wish I could say that for us, but at least, AI is on the right trajectory. Okay, so that's a kind of quick AI 101. The real impact of AI is going to allow us to practice what I call intelligence-based medicine. And now this may be counterintuitive. We don't practice medicine as a science. We practice it as an art. If a physician sees, 10 physicians sees a patient, they're most likely going to give you 10 different approaches to diagnosis and treatment. How much of a science is that? We don't use all the data there is out there to make decisions. When you consult with a patient, you're not bringing up their genetic profile. You're not bringing up data from their census or environmental data. You're not pulling any behavioral data. The only information you use in clinical decision making is the information the patient is giving you. So much for the science. Okay, so AI is going to radically change that. Okay, now this is what happens when we practice the way we do. Quality is a major issue. Look at this. This is just the USA, by the way. Diagnostic errors linked to 800,000 deaths a year. Now, just to make that more tangible to you, that's the equivalent of 5 fully loaded jumbo jets crashing every day and nobody surviving. How safe is healthcare for you? Okay, and you can go into the WHO website and pull out 2.5 million deaths globally linked to unsafe care, more than 7 million incorrect diagnoses. What is the medication error rate? It's 12%. So we're getting it wrong 1 in 10 times. Okay, and AI can address this. Okay, it really can give us a lot of opportunities to solve these quality challenges that we face. This is an example of image classification, for medication error, okay, where the AI is able to help ensuring that medication errors are reduced. Okay, we can use computer vision to prevent, amongst other things, falls in hospitals. Okay, which is very, very prevalent today, despite all the interventions that we attempt. We're also using AI to improve efficiency. This is computer vision to optimize clinical workflows. Okay, we don't invest any time and energy in workflow design, which we should. Okay, we're also using AI, by the way, to start capturing notes. Ambient AI is the biggest growth area in medicine today. This is where the deployment is the highest. Essentially, this is a solution called Mediscribe that's developed in-house at UAB. It's a phone-based app. You switch the phone on. The phone captures the conversation between physician and patient. And essentially what it does is it generates the note after that. Okay, so you don't have to write any notes. It'll actually convert this into a SOAP note or whatever kind of format that you really want, and you have choices. You can send this to your EMR if you have one. You can save it. There's the note, by the way. There's the plan, etc. Okay, so Mediscribe will be coming to South Africa soon at a princely sum of $10 per physician per month. Okay, now this is really important in South Africa because if you look at litigation, what are a lot of the kind of drivers of litigation? Poor note-taking. It's not that physicians are negligent or nurses are negligent. They're just not able to document, for whatever reason. And a solution like Mediscribe actually mitigates that. Okay, it actually takes the notes, captures everything for you, and generates the note. We're also using AI to improve the patient experience in hospitals. Okay, this is already deployed, where we can actually personalize people's experience in hospital the way Disney personalizes your visit when you visit them, or a cruise ship does that as well. Okay, so lots of potential, in addressing these quality issues. AI also has this uncanny ability to practice deep medicine, to see patterns that we can't see as humans. Okay, now look at this chest x-ray. Indicates that you may have type 2 diabetes, coronary calcium score is that, and cardiac risk from a chest x-ray. Okay, human physicians don't have the capability to do that. And by the way, this solution is already available. So a basic chest X-ray, when you couple that with AI, now becomes a transformative screening tool, okay? It also, and you can see the host of examples of this. You can diagnose Parkinson's from breathing. You can look at patterns in the tongue and get to a diagnosis. RESP app was one of the ones that came out during COVID, can differentiate between COPD and asthma, amongst others. You know, using facial temperature for early diagnosis of metabolic diseases, you can diagnose genetic conditions, et cetera, et cetera, et cetera. Okay, that's deep medicine, this ability to see patterns that the human eye can't see. Okay. The other thing that AI does is it allows us to practice what I call kind of swarm thinking or collective thinking in healthcare. Now, the most cited publication ever is this. I want to encourage you to pull this up sometime, why most published research findings are false. So we're an evidence-based profession. You know, we're strong proponents of the scientific method. I want you to question that as well. But the reality is, a lot of what we think is science-based is not really science-based, okay? Now, this article, essentially, the take-home point from this is that simulations show that for most study designs and settings, it is more likely for a research claim to be false than true. Now, you guys, a lot of you here are academics. You publish prolifically. Some are host journals, okay? Now, the next time you receive a submission, take a look at it. The statistical findings are always correlation and association. That's not science, okay? Causation is science. Most popular studies out there are based on correlation and association. And frankly, if you have data sets big enough, you'll always find correlations and associations. So we can't claim that something is based on true science if the research is actually flawed. Okay, what AI does, it converts all of these individual articles into meta-analyses and then goes out and brings every single piece of evidence that's reflective of this patient to bear in care. Okay, this is the Watson example from IBM, not necessarily the best, but essentially, instantaneously, Watson aggregates every single publication, every single clinical trial, every single patient that's similar to your patient, and then essentially gives you a probability that this patient has diagnosis X and the best treatment is Y. Okay, that's the power of AI. It's collective intelligence. We can now suddenly use 100% of data and not 3%. Okay, pretty powerful. That's going to enable. We can see already a lot of disciplines where AI is already outperforming humans. Dermatology is one, radiology is another. Okay, to me, one of the most powerful use cases for AI is in drug discovery. You know, we practice today what I call imprecision medicine. You know, one of the biggest, and I say this to you as a physician, one of the biggest frauds medicine has committed is the concept of an average patient. Think about it. Who here is an average patient? Yet the whole profession is built on the concept of an average patient. The whole drug industry is built on the concept of an average patient. There is no such thing as an average patient. For the very first time using AI, we can start treating patients as individuals, and we should. Okay? This is a stat that flawed me, and this is in Nature. Of the 10 most prescribed drugs in the USA, only works for 10% of the population that uses it. Okay? That's the science of medicine. It's pretty scary, and you'll recognize some of this. Nexium, some of you may be taking this. Crestor, Remicade, Cymbalta, these are common drugs, but only work for 10% of the people who use it. Because it's prescribed based on the concept that every one of you is just average. Okay? You're not. So AI is going to propel us to this personalized and precision-based approach, especially in drug discovery, where we can start discovering drugs for you based on your genetic profile, your phenomic profile, your environmental profile, and your behavioral profile. And we can do that rapidly and at scale. Okay? So AI is really going to usher in true personalized medicine and move us away from this fraudulent practice of the average patient. Okay, so let's pivot somewhat to what I think are going to be some of the key vectors that are going to shape the future of healthcare. So these are kind of, discussions that I think you should be having as part of this unreasonableness that medicine needs, okay? One is prosumerization, okay? So when you talk about unreasonable, you shouldn't talk about how to incrementally improve care delivery in hospital. That's reasonable. Unreasonable is how do we deliver care without physicians and without hospitals, okay? That's the conversation you need to have. And that's the concept of prosumerization. And I coined the term to describe the ability of patients to produce their own care, okay? Patients who produce their own care are not patients, they're not consumers, they're prosumers. Okay? And we can do this now with technology coupled with artificial intelligence. And remember, exponentiality enables us to commoditize medical, not just medical knowledge, but medical solutions as well. This is Bina.ai, is one of the leading companies, and it uses the same technology of the phone. Okay, 30-second video, FDA approved, by the way, CE approved, and does a full clinical assessment. Okay, no need to see a general practitioner or primary care practitioner. Okay, we're moving away from devices to deviceless. You remember exponentiality, dematerialization, stuff disappears. We're now using sensor technology in people's rooms, and essentially the sensors capture all the information. And there's a lot of work out there in terms of how to use laser and how to use radar to actually capture vital signs, okay? Using radar technology, we can measure blood pressure of an individual from 50 miles away. That's pretty powerful, okay? And hopefully we can bring that to bear. This is old now, the fact that, you can actually do your own ECG at home. This device, retails in the US, you can buy it on Amazon, you can buy it in Walmart, I think it's about $40. Now, this is a single lead ECG, okay? The clinicians here would say, well, what's, not really valuable. You're right, but it's pretty powerful in picking up cardiac arrhythmias, which is one of the leading predictors of stroke. But when you couple a single lead ECG with AI, you can actually have the same kind of veracity as a 12-lead EKG. Okay? So suddenly AI takes a low-fidelity device and makes it a high-fidelity device. Okay? And that improves access. TytoCare, I know, is in South Africa. This is a Israeli company. Essentially, this solution elevates moms to become primary care practitioners. Okay? They walks you through the clinical assessment and uses AI to help you get the diagnosis. Okay? Skin Vision is one of several dermatology solutions. This is FDA approved, CE approved. Download the app, aim, shoot, upload, diagnosis in a matter of seconds. Okay? And it's pretty powerful if you have some nagging dermatological issues and can't get appointments. Every one of you in this room sometimes is going to need an eye test. Try getting an appointment with an optometrist and leaving with a hefty bill. You don't anymore. You can actually do your own optometric evaluations at home using technology like IQ. Okay? So you may say, Ruben, where the heck do you expect me to get a solution like this from? Okay, the answer is simple. You go to Amazon where you get everything else, and this is $30. So that's 600 Rand. Okay? And you can become your own in-home optometrist. Even any dentists in the room? No dentists. Okay, even dentistry is not immune to this. This is a little device that you attach to a smartphone and it allows you to do a full kind of dental assessment and evaluation. This is pretty new. It's an X-ray that's commoditized. You can now do X-rays at home. Okay, Novell Cam has just been FDA approved. This is a portable X-ray machine that can allow patients to do that. And bear in mind, the power of this is coupled to the AI image I showed you earlier on. That one, with simple X-rays coupled with AI, you can see much more than the human eye can see. And when you start commoditizing technology like this, it dramatically changes healthcare. iCalQ is the world's leading kind of diagnostic company. This is a device you attach to your smartphone. You don't need to go and see a pathologist. Okay, you can do a whole lot of blood tests and sputum tests at home. When you couple that with a solution like Doc.ai, it does the interpretation for you. Okay, so any pathologists in the room, you should be a bit nervous. Okay, you may say, well, Ruben, for some things we really have to go in. And I say, not really, okay? You can actually have a pill cam. This is a Medtronic device. Essentially, minimal bowel prep, you swallow that, and it essentially uses artificial intelligence to diagnose polyps and can now actually tell the difference between benign and potentially malignant, okay? What's your next question, Ruben? Where the hell do I get a pill cam? Okay, and what would my answer be? Go to? Yeah, absolutely. Go to eBay, and for $99.99, you could get a colonoscopy done, DIY. And there's, this is what entrepreneurship is all about. There's a used one here as well. So, okay. One of the commonest hospital-based procedures is a gastroscopy. This is really interesting. 80% find no disease. They're pretty invasive, requires a lot of resources. In the US, it costs about $1,500 minimum. A lot of environmental waste, several visits to the doctor, and a lot of health process. So it's a resource-intensive diagnostic with very little outcome, okay? And we do this all the time. But we don't really have to. There's the equivalent of it's called a pill bot. Essentially, you skip breakfast in the morning, you take 2 glasses of water, you swallow the pill bot, it's 10 minutes and you get instantaneous results. DIY gastroscopies. Okay, this is prosumerization for you. What's your next question? Ruben? What's the question? Yeah, what's the price? Exactly, 50 bucks. Okay, $50. That's less than 1,000 Rand. You could get a gastroscopy done. This, folks, is prosumerization, not commoditization, not patient care. Okay, so as you deliberate over the next 2 days, think about this. Think about how you're going to radically rethink healthcare. Okay, I always say current healthcare systems is where innovation goes to die. You want to kill something, put it in a hospital. Okay, it will never have the impact that it should. Look at this. Around 70% of all cancer deaths come from cancers without recommended screening. This is the scientific profession that we claim to populate. And there is, by the way, no logic in terms of the screening protocols. Okay, why should you get a colonoscopy when you're over 50? Why should you get a mammogram when you're over 40? There's no logic because, that's based on the average patient. There is no average patient. Some of you here have a very high risk of breast cancer. You need a mammogram every month or every year. Some of you here have a very high risk of colon cancer. You need a colonoscopy every year, not 10 years. So the logic and rationale of our current approach is screwed up, okay? But so the way to do this is you move it home. You put the power in the patient's arm. This device is called a dot plot, actually designed by students, and enables them to do their own mammograms, okay? And, wouldn't you rather have this, especially if you're high profile or high risk profile, to be doing mammograms monthly instead of 4 or 5 yearly? Okay, so this is prosumerization, okay? A key trend that's going to shape the future of healthcare and leverage artificial intelligence. The next is what I call platform-based care models. This is Uberization of healthcare, connecting providers with services, not owned by the health system, okay? This would be the largest healthcare systems of the future will employ no physicians and have no beds. It's going to be pure platform-based models connecting physicians with demand wherever that demand may be. This is a powerful model because it scales very fast and cheap. This is why Airbnb is cheap and Uber is pretty convenient because of this model, okay? Now in healthcare, we have the potential to be far better than Airbnb and Uber because we can take away the beds and the rooms and the cars and replace it with AI, which means that we can start delivering care at marginal costs approaching zero. Okay. Now there's some examples of this. You see a host of different chatbots. This is an old one, Babylon, that's not in business anymore. But they launched in Rwanda a few years ago as Babil. And with a switch of a button, they made primary care services available to 2 million people. It's a platform, okay? AI, no cost, zero, okay? And then, of course, we have other solutions. You can try this, by the way. It's MyMate. If you got an image, you upload the image, and you get a free interpretation. AI. What's the cost of this? Zero. Okay? And the advantage is the more images it gets, the better it gets. This, by the way, I've been saying this for 5 or 6 years about platforms. The largest hospital is going to hire no doctors and have no beds. And they just won the Guinness Book of Records. This is a Saudi Arabian hospital, and essentially is a platform-based model. The Siha Virtual Hospital, not a true platform, but it kind of makes the point that I was telling you. Okay, so that's two. Medical automation is going to be enabled by AI. Automation is exactly what it says, fully automated. Look at this. This is a little, the new generation ATM, a little solution device that you could put in a mall or wherever. And essentially you look in there and it does a host of assessments and evaluations. You really don't need a physician, okay? And the veracity of this is improving with time. By the way, that's FDA approved. You don't have to go to a lab to get your bloods done or see a pathologist for interpretation. That's automated as well, okay? There's an automated phlebotomist, pulls the blood, does the analysis, and gives you the interpretation as well, okay? This is another example of full automation. This is a dental implant. There's no surgeon there. They're just observing, by the way. Essentially, it's the software. They send you a software code. You feed it into the robot. It does your dental implants, okay? 30 minutes each, more accurate than a dental surgeon. This new solution, Perceptive, is just launched. There's no dentist, but it's turnkey dental care, okay? Fully roboticized, fully automated medical care. Johns Hopkins University just recently released this. They trained this robot just with videos, okay? And the robot is able to conduct surgery more accurately than human surgeons, okay? So you'll question this, but what about, the human input, et cetera, et cetera? We can discuss that, but there's a lot of opportunities. Robotics is already used extensively for patient experience. I can tell you within 10 years, you're going to be able to purchase robots the way you buy a car today. Okay, so you're going to drive down the street and go into different stores selling robots. I can tell you that within a decade, you'll have your personal robot at under $20,000. It's 400,000 rands, okay? And perform pretty much any task that you want it to do. So, the advent of personalized robotics is here as well. This is the world's first fully robotic hotel. There's no human employees here. Now, look at patient satisfaction scores in hospitals. A lot of those low patient experience scores are because of humans, and one of the things we seriously have to consider is to improve the patient experience, do we have to get rid of the human employees, okay, and have it fully roboticized? So, these are issues we have to think about. Okay, from a payment point of view, we're going to kind of move towards a system where we pay people for health as opposed to them paying in to mitigate against ill health. We can see a lot of the car industry doing this already. If you have a Tesla, by the way, and you use the self-driving, your insurance rate drops in real time, okay? So the whole current insurance model is also based on aggregating risk amongst populations, We don't really have to do that now with processing capability and data at an individual level. We can price risk at an individual level. So that same kind of modality we're moving in healthcare. I know Discovery is here. They're arguably one of the world leaders in what I call pay as you heal insurance, okay, where we start rewarding people to stay healthy. In the US, we're piloting the world's first literal pay as you heal, where we're actually paying people in US dollars to maintain certain health outcomes, okay? This is also going to see a move to what I call insure tech. This is a company called Beam Technologies, and they started off with toothbrushes that have sensors in them. They realized they had a whole lot of data about dental hygiene. They launched an insurance company, and essentially they pegged their premium based on your dental hygiene. Makes sense, isn't it? Okay, so that's the one. Earn as you heal. Remote patient monitoring is pretty big in the US. UAB launched a company called Incenti Health. We pay patients $30 a month to send us 16 readings, blood pressure and glucose, okay? We're paying them to deliver a service that we would, okay? Now, by the way, you may not know this, but what does it cost the public health for an outpatient visit in South Africa? What's the cost? I don't want to know what you bill. I want to know what's the cost. Anybody? You see, that's another flaw in our health system. We don't know what it costs. You can't run any business sustainably without understanding your cost. Well, we ran the numbers. An outpatient visit in South Africa costs 400 Rand, the cost to the government, okay? Now, you can see that this technology poses tremendous opportunity to actually replace that. The world's first futures market in healthcare is going to be launched by UAB soon. You'll be able to come to UAB and buy services that you can access later on. If you don't use it because you maintained a healthy lifestyle, bring it back to the secondary market, sell it, and make a profit. Okay? The world's first futures market. This is what I talk about by being unreasonable in trying to configure how you deliver care and how you pay for care. Okay? You can actually, using our futures market, make a profit by staying healthy. It's always been the holy grail in healthcare, by the way. Your health is an investment. Okay? But we were never able to explain it. Futures markets can do that. We're going to see a major pivot to what I call well care. I don't mean wellness. Well care is a science-based approach. Essentially, if you look at the current way that we look at disease today, people are well. Biomarkers appear, the disease progresses, early clinical signs. This is when they come to the doctor, actions taken, and reduce wellness. Okay, when does a diabetic patient manifest clinically? How many years after the first biomarker? How many years? 5, 10 years? That's the science of medicine we practice today. Okay? When we identify these patients, no matter what we do and how robust the treatment is, the damage is already caused. Nobody can actually go back to 100% wellness. Science-based well care means, people are well. We're tracking from birth. We're looking for biomarkers and digital markers from birth. The first time it manifests, we take action. They return to 100% wellness. We continue tracking. So the new well care model is science-based. It begins from birth and it ends when you die, okay? What I want to show you now is the world's first science-based well care model. It's called Polyome. And essentially what Polyome does, it uses your genetic profile, it uses all phenomic data, imaging, blood, saliva, all of those tests, environmental data and behavioral data, and we generate a digital twin of yourself, and we use the digital twin to give you 5 real-time risk scores, okay? You can get a polycog, your brain health, polywell, your health, polybeat, your cardiovascular risk, polyonc, your cancer risk scores. 5 real-time scores, okay? And based on your risk profile, we actually give you recommendations. High risk, the app actually makes an appointment for you with a physician and connects you with Uber immediately. Okay, medium risk, you get an appointment made, and we offer you transportation. Low risk, you use our resources, okay? So Polyome, this is the world's first science-based, and it's all powered by artificial intelligence using all data points that we have about you, okay? So that's coming to the market in 2025. Okay, I'm going to end with this. You know, one of the big things that we really have to think about is sustainable medicine. How do we deploy AI and digital technology responsibly? To me, this is going to be the key differentiator of the future. If healthcare was a country, it would be the 5th largest contributor to the carbon footprint. Okay, it's pretty scary. What you may not know is, how many of you prescribe these asthma inhalers? We all did. I'm guilty. You know, one inhaler, the contribution of one inhaler to the carbon footprint is the equivalent of driving 200 miles in a car because of CFCs, okay? One flask of desflurane in an operating room is the equivalent of burning 500 kilograms of coal. So we, you know, as we embrace digital technology and AI, we really have to be cognizant about how do we do that responsibly and in a sustainable manner, okay? It really is important. I have a book that just came out, and it's to do with actually sustainable leveraging of AI and digital technology. This is a hospital in Belgium, and it uses biophilic design, okay, because they're pretty sensitive to the carbon footprint. Okay, all of those things I talked about seem disconnected, but they're all kind of connected. All of these vectors that I spoke about, prosumerization, well care, you know, platform-based models, outsurance, all of them actually come together, but it all begins with prosumerization. The only way you can transform healthcare is not from healthcare itself. The way you change healthcare is by empowering patients. When you drive prosumerization, you're going to force the change in healthcare systems because it's going to lead to reduced demand, increased surplus capacity. And when you have that, then of course you drive that change. So, you know, really important to see the connection. I kind of call this the Copernican shift. You know, moving patients to the center of the universe as opposed to you occupying that center, okay? That's the Copernican shift. Anyway, so that's the final message. I've pretty much have all of this in different books. Some of you are going to get some copies of this, but they're all out there. So thank you very much. If you have any questions, I don't know whether we have time to take it. Yeah.
Thank you so much, Professor Ruben Pillay. You know, this was actually such a good overview of the potential, the huge potential of AI in revolutionizing healthcare. I'm sure there's going to be lots of questions, and I'm going to allow for question time, even if we move into the next session. You know, because we really, in a country with such huge divides, need that robust discussion on equitable access. And I'm just wondering how the Goko from maybe Nkandla is going to get that pull to diagnose herself.
Yeah, absolutely. You know, the Gokos in Kenya are using what do you call that? M-Pesa. You know, so they're able to do that. We shouldn't underestimate people's, you know, propensity to use technology if you're solving a problem that they have. A lot of issues of adoption is based on the fact that we try to solve problems that don't exist. Okay, so if you solve a real pain point for the Goko in a rural part of Africa, they'll use the technology. Okay, now the Goko will not be able to access the technology via traditional healthcare systems. I've always said that. You want to kill an innovation, offer it in the hospital. Okay, whenever, you know, I run an innovation center, one of the biggest in the world. Everybody who comes to me knows one thing about me. Don't come to me with an idea where the hospital is going to buy, okay? Because I don't work with that. Come to me with an idea that was going to make the service directly accessible to patients. Okay, so, if Telkom controlled your smartphone, you wouldn't be sitting with two phones each. The reason that technology is commoditized is because we didn't go through Telkom. We went directly to you, okay? So this is what I talk about when I say progress comes from unreasonableness. Unreasonable thinking is making care accessible, but not through current healthcare channels. So, that's in principle.
Thank you. So there are two burning questions right in front. Let's start off with the chair of SAMA.
Thank you so much, Robin, for this presentation. It's actually very, very interesting. I see that most of the issues that are being solved now, for now, by AI are mostly physical. I'm not sure if the psychiatrists are safe in terms of
Yeah.
diagnosis.
No. There's a lot of work being done on mental health, by the way. And one of the reasons it has not progressed as much is we just don't understand the brain. Okay, to be honest with you, but the brain initiative, which started a few years ago under President Obama, the data is starting to come out now. And when we understand the brain in ones and zeros, AI is going to be a pretty powerful resource for that. So it's a matter of time. In all of the other conditions, it's because we have a solid understanding of how the organ system works. We'll be able to convert that to ones and zeros and use AI. I think the brain, we're just starting to understand how it happens. Yeah.
Thanks. I think we'll have to wait for all the neuroethics issues that arise with AI. CEO, you've got a question?
Yeah. Right. You mean in the building of the solutions, or? Yeah. Mm-hmm. Two different things, yeah. You're right. 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 Yeah. Right. Yes. Right.
Oh, okay. Thank you very much. So that's AI. So I was trying to say, Richard, Ruben, that you don't have a universal health record in South Africa. So if I go to the public health system, I'll have 20 records because they would have lost the paper that
Right.
I had that time.
Yeah.
So how do we as a country, how do we bring it home?
Right.
Firstly, deal with the issue of ethics. If the pill bursts inside,
Mhm.
I'm sure it's designed that it shouldn't burst, by the way. Yeah.
Right.
So if it bursts inside, who takes responsibility? Is it Amazon or is it the person
Yeah.
who actually designed the thing?
Right.
And how much of that is clinically led and
Right.
it's got ethics?
Okay, so let's take the ethics part first, because obviously it's very important. One thing I can tell you is the current ethics frameworks that we use, when do they come from? From when? From Hippocrates. Okay, Hippocrates didn't live in a technological time. If you read the Hippocratic Oath, it doesn't do justice to the current context of medicine. Okay, so firstly, we have to radically rethink that. And how do you program an algorithm to make decisions? And by the way, ethics varies from society to society. You know, how would you program an autonomous car? You know, if you go straight, you kill yourself. If you turn left, you kill a young person. If you turn right, you kill an old person. How will you program that? Okay? So the kinds of ethics are going to have that are going to apply in a technological in this have to be radically rethought. I mean, so we have to shed our current ethics frameworks aside and rethink it. I'm 100% serious. I mean, I know, but I mean, who better to be a voice of of a rethinking ethics than the ethics expert? Okay, so one of the things it's not like we're not thinking through this. We're thinking through this. Okay, is this concept of real-time swarm intelligence for ethics. That ethics is real time. It's not locked in frameworks developed 2,000 years ago. Okay, that as we're faced with situations, we kind of get consensus. That's the swarm part. With using AI, we can instantly get to a consensus and make a decision based on that. That's one idea. But my point is, ethics frameworks today are not sufficient for this. We need to rethink. The other point, Zoo, in terms of data, you can't do this without digital infrastructure. I mean, that's simple as that. And then, so you need that. It's pointless even having the discussion if you don't have that. The other point you made is really valid. If I give you a solution, an AI solution designed and developed at UAB, you can't use that at Barra, okay? Because the kind of data inputs change. And remember, algorithms also degenerate. They kind of lose their veracity with time. So we have to constantly retrain the algorithms. One, the algorithm degenerates. Two, the population changes. Okay, no hospital population remains static for 5 years or 10 years. The population changes around you, which means the algorithm designed with population A is irrelevant in population B. So there's a lot of moving parts that you have to understand, in terms of the issues you raised. Yeah.
Thanks. And I'm just standing here thinking, AI Ubuntology. So I am who I am because of Prof. Rubin's AI. I mean, are we going to reach that stage in maybe 3,000?
No.
In 10 years? Okay. All right. So is there another question? There's a question out here.
Thank you. So really intriguing, right? I'm a firm believer in it. I come from a clinical trials background, and I think the biggest issue we saw was the ethics of AI used in clinical trials. But for me, the big thing is two-part, right? So yes, we are thinking about it because I do work with some of the national and provincial structures in terms of healthcare. So we're thinking about it, right? We're commoditizing. How do we connect the patients? How do we get the hospitals in our public settings working? HPRS is now addressing some of that unique patient identifier. So we'll see that coming forward. But I think the biggest challenge that I see as a technologist in healthcare, and maybe the question is imposed, is when do we start changing the way we teach our students at medical school to adopt this stuff? We keep pushing back to the textbook, but we're all walking around with this. And my comment to a couple of the professors at UKZN is, do you realize that student is going to be operating on you through this? And their decision making is through this. So as technologists and clinicians, when do we start adopting the methodology of how do we change the way we teach and empower the way we teach ethically, but logically knowing that that's where the future model is going?
I agree with you. I mean, when I think back to my medical training and spending, late nights memorizing stuff, the whole model doesn't work. We don't have to be, because now we have instant access to knowledge, okay? The reality also is a lot of physicians in the future may never ever interact with a patient in person. Because one of the big developments, I think, of the next decade, the concept of digital twins. So physicians of the future will not be physicians. They'll be physicianeers, combination of engineers, data scientists, and doctors. And they're going to operate And your treatment will essentially be in the form of software uploads and downloads. It's you know, that's the way it's going to be. So it's going to take a radical rethink of medical education. The problem with medical education currently is we can't scale it. You know, we talk about shortages of doctors, but nobody has looked at, well, you know, the current system of training a doctor does not allow it to be scaled. So we're locked in on the supply side. And you know, once again, I have some radical thoughts on that and questioning, do we really need physicians? Because the concept of prosumerization will usher in deprofessionalization, okay? You know, all of you here are beneficiaries of the fact that, you know, these tourism guys, what do you call them, used to book air tickets? Travel agents. All of you are beneficiaries of the deprofessionalization of that industry. You can travel much easier. You can customize your trips. All of you are beneficiaries of deprofessionalizing of the banking industry. You can do your online banking, okay? Medicine is going to go down the same route. Whether you like it or not, these conversations need to be had. We can't on the one hand say, foster prosumerization, but keep doctors at the epicenter. Those two things don't go together. Okay?
Thanks so much. And I think at this stage, I want to say thank you again. We hope to harness the potential of AI, but at the same time, unpack the ethical, legal, and social issues. And this is the start for us at the South African Medical Association. Maybe a little bit behind in terms of where you are, but that's the way science and technology is. There's huge progress, and ethics and the law and social issues lag behind. So I think Sama's taken quite a lead in that, and we hope to see how we can actually go further in terms of possibly even influencing policy direction in that. Thanks so much.
Just remember the one slide, you know, when cats dream of becoming lions, just remember that, okay? Thank you. Bye-bye.
And we move into our next session now, which is the current state of AI and technology in healthcare, and that's in our current context. I'm going to hand over to Mr. Atihome Lanjana, who is a senior digital and technology specialist, and he heads the IT unit at SAMA. He will be moderator for this session.
Thank you so much, Professor Dai, and thank you to Professor Pillay for the brilliant presentation. The AI 101 took me 20 years to my varsity lecture. Starting to get a bit anxious there, thinking there'd be a test afterwards. But thank you so much. Ladies and gentlemen, distinguished guests and esteemed colleagues, we wish to welcome you once again, and good morning from myself, Atihome Lanjana, as previously introduced. It is my pleasure to facilitate part one of this new session we're getting into, where we then lay the foundation for the next 1.5 days. And just to quote a wise man, Theodore Roosevelt, the 26th president of the United States of America, he once said, "Do what you can with what you have where you are." So in line with those words, this first session will then look at the current state of AI and technology in healthcare. We shall briefly examine what we currently have and where we are at this very moment. So without further ado, let me introduce our first speaker, Ms. Rizwana Mia. She will speak on the topic, an overview of existing AI applications in South African healthcare. And a bit of a bio, please be patient with me. I'll try to go through the bio is written here. She's the senior program manager for precision medicine. She is a leader in health innovation with 16 years of experience, combining scientific expertise and strategic thinking with her educational background, including genetics and business administration. She directs and develops programmatic research and innovation in precision medicine. She is also the vice chair of the International Consortium for Personalized Medicine. Her work there focuses on inclusive development of research and innovation in personalized and precision medicine. All right, we still continue. Her achievements include establishing the South African Precision Medicine Program, the SAMRC Genomics Center, and she's currently coordinating the South African 110,000 Human Genome Program. She is pivotal as the South African lead in the CSA EU Africa Consortium, fostering collaboration in personalized medicine research and innovation. Ladies and gentlemen, distinguished guests and esteemed colleagues, please give a warm welcome to Ms. Rizwana Mia, who will present next for the next few minutes, and then we'll take a short Q&A session afterwards. Thank you.
Thank you so much. Very extensive introductions. Thank you very much for that. And thank you for having me here today to speak to you about an overview of existing AI applications in South Africa. I don't know if it's all moving. Okay. There we go. So Ruben gave you a very extensive education and understanding about the applications of AI in healthcare. So I'm not even going to labor that, but I want to say that, in the various avenues, AI on the premise requires data. And where are we standing with the AI industry in Africa? Well, apparently, and this is from the Global Report, the AI industry across Africa is growing extensively. There are about 2,400 companies specializing in AI, mainly startups, and they're estimated to contribute about 1.5 billion US dollars to Africa's GDP by 2030. So, in terms of the context on implementation of AI in South Africa, we must understand the stark reality. We have a very robust private healthcare sector that is implementing AI, and we have a public sector that is really needing a lot of help, and we will talk about that in briefly toward the end of my presentation. But I will focus on this private healthcare initiative in South Africa and an overview of what's happening there. So in the private sector, South Africa's AI healthcare market is projected to reach close to $1 billion US dollars by 2030. And this would register approximately 45% growth for this period. Just to give you an understanding, in February, Envision IT Deep AI saw an investment of about 1.65 million US dollars to expand access to medical imaging. And just to give you an understanding of what's been going on, I found a very interesting publication, and this was the Philips Future Health Index report for 2024, which was titled Better Health for More People. And they conducted a survey which included healthcare leaders from South Africa, mainly private healthcare leaders. And this survey basically looked at 14 countries and about 3,000 healthcare leaders across the globe. Now, taking from here what's been happening in terms of, just on the offset of where South Africa measures, you will find that in areas that South Africa leads and is above the global average in implementing remote patient monitoring, for example, for virtual care, in easing staffing shortages, we find that this is happening extensively in mental health care, post-operative monitoring, pre-operative care, chronic disease management, and elderly care. And automation for repetitive tasks and processing to address these staff shortages. We found that healthcare leaders, the potential of automation to support staff, people believe that automation will allow healthcare professionals to perform their highest skills levels. About close to 100% say that automation on repetitive tasks will help alleviate crucial day-to-day activities and reduce it. But in any way, overall, even though people believe in automation, a lot of people or a lot of the leaders and the healthcare professionals believed and are skeptical about the use of automation in healthcare overall. So that's very interesting. And if you look at improving patient care, obviously you are taking disparate data sets and you translating this into actionable insights. And the potential for this is obviously to optimize patient care pathways, forecast and manage patient demands, and identify best practices, the need to aggregate and harmonize data sets and bring data together. However, there are inherent barriers, and these barriers need to be understood. Data integration challenges affecting data quality and accuracy of algorithm outputs, resulting in reduced quality of care. In South Africa, the fall of an integrated health information exchange also impacts the broad interoperable electronic health record of patients utilizing different private care facilities. And patients being able to access their own data still remains a challenge. And how did healthcare leaders believe data-driven insights can improve their organizations? And this was roughly borderline in terms of optimization of plans and care pathways, forecasting and managing patient demands, identifying evidence-based best practices, and predicting and reducing adverse patient effects. And so if you look at the use of AI in clinical decision support in South Africa, again, so it's interesting that South Africa and its private sector is somewhat seen above the global average and already implementing AI for clinical decision support. And in fact, I think Nedcare won an award for this. Mediclinic as well is very, very astute in this. And obviously Discovery being the global leader in terms of wearables and tracking. But here we saw that, in terms of treatment planning, in hospital patient monitoring, preventative care, medication management, clinical command centers, and pathology, as well as remote patient monitoring and radiology, they were roughly above average. So the role of data in addressing health disparities, I mean, one of the key interesting things that was observed, and we found that obviously in my research, I also saw that social determinants of health seem to be a missing sort of data piece. And roughly even for public health sector, we often don't understand this well enough, and we haven't done enough work around this. And furthermore, the lack of data on all aspects in disease management within the South African patient populations are also a key factor. For example, genomic data, we don't have enough patient population data to actually drive the omics technology workflows that other countries are using in data-driven healthcare. And 74% reported a lack of data on social determinants, whilst 82% saw more comprehensive data on social determinants being needed, and 78% understood that without more local or regional data sets, it's quite difficult to overcome health disparities. So if you look at the exploration to implementation of AI in the South African private healthcare sector, they obviously are now looking at moving towards generative AI, and Ruben gave you a very nice understanding of what that means. Unlocking insights from patient data. Here, there were concerns about data bias, and data bias is a very big thing. Data bias causing disparities in health outcomes, but there are ways to mitigate the risks. And this is to develop, obviously, policies and ethical use of data and AI, and ensure staff diversity in data and AI are crucially addressed. And obviously, 90% of healthcare leaders are concerned about the possibility of data bias in AI, widening health disparities. So the public sector, the current success in the investment and implementation of AI and data-driven healthcare is largely, we understood, in the private healthcare sector. So how transferable are these efforts towards the public sector? If we have to address this in the public sector, we've got a lot of gaps. There are infrastructure gaps in terms of digitizing healthcare, electronic health records in public sector, and it's moving very slow. There are limited expertise as well. There are social determinants of health in terms of the public health agenda is also missing. And obviously costs and investments, where would that financial investment come from? And most importantly, the ethical barriers and the regulatory barriers in terms of data security, algorithm bias, and guidelines, etc., in terms of ethical use. So with that, I'd like to end on a call to action. And I feel that, the gap in the public versus private healthcare delivery and the quality of care will widen as AI is implemented more and more within the private healthcare sector. We should actively build partnerships for sustainable, transferable implementation as the rollout of the NHI occurs, and embrace AI while addressing those challenges proactively. So we don't do it, separate, and we don't wait for it, but we do it in parallel. And obviously, to address data bias, we have to create investment models to finance the evolution of AI in the public sector. And this is mutually beneficial to the private sector. The development of interoperability as we develop more data sets in the current research agenda, and then bringing the private healthcare sector into programs like the South African 110K National Human Genome Program will obviously see us transform towards precision healthcare. And with that, I'd like to say thank you so much for your time and listening to me.
Thank you. Thank you so much, Ms. Rizwana. Mayor, please don't go away. We'll take a few questions. Do we have any questions from the floor and maybe online? We've got our esteemed guests joining us online who may have a question or two. But maybe if I may start, since I do have the privilege of being on the floor. You did mention, as it was previously mentioned, that this is a data-driven exercise. We then identified the infrastructure gaps as well, particularly in the public sector. How do we, it's probably unfair to ask you this, how do we bridge that gap? Because there was a slide you showed there where the private sector seems to have advanced quite a lot on some of the initiatives, even to a point of being above the global average. So you would then expect that to translate on the ground, on the experience of the day-to-day average patient. I know we don't have an average patient. So why is that not happening fast enough? Is it maybe because private sector doesn't have as much reach? How can we bridge the gap?
I think we must understand that private sector is paid for healthcare, and it's driven by medical insurance, and they've actually got a very nice mechanism and how they work together in terms of reimbursement and reimbursement strategies. Whilst the public healthcare sector has been ailing and It's become a crisis over the years, and so now you're at a point where you can't prevent the private healthcare sector from evolving and offering first world treatment to people in South Africa, but at the same time, there needs to be sort of a middle ground where the fiscus has to be addressing these pertinent aspects. If we can digitize, the public health sector and spend time in doing that, it would not be as costly, because then you would have better management of care facilities. You would then employ similar guidelines and strategies that the private healthcare has evolved over the years. And so this could be a learning curve for the public healthcare sector. The big question is, how do you get that to happen? Because I think we've been trying to do that. Everybody's been trying to do that. But at the same time, our private healthcare sector was going on a very nice pathway where they amalgamated all of their electronic health records on health information exchange. And then very recently, we saw that actually dissolved. So that's actually a shame, because I just feel that in terms of us reaching the goal of precision medicine or personalized medicine and evolving towards what the rest of the globe is doing, we would only be able to do that together, and we would only be able to do that if we share information and if we share processes, etc. And I think that they would be even more competitive if they were able to maybe revive that. So
Thank you so much. And I think it's a good thing this is being recorded. These are excellent insights. I believe we do have a hand there. Can we get a mic?
Yeah, I've got the mic.
All right, thank you.
I just wanted to find out the data that you collected on AI use in healthcare. Where specifically did you collect that data? In the public sector versus the private sector, and over how long from a period point of view? And then were you certain discipline specific? I just wanted to know. And then I also saw that there were some areas where we are above international standards. So specifically, which countries did you compare us against? Or it was, yeah, so that's the information I just needed.
So I think the information that I have given you today is based on the Philips Future Health Index report. And I left a reference there, and I don't know if the presentation is shareable, so you could get a copy of it. But in that report, you will see that they looked at 14 different countries around the world, and they looked at different levels in terms of economic status in these countries, and then compared them. And mainly OECD countries, low middle income countries were included, and as well as some of the first world countries. So I think that it would be nice if you want to read more about this, to look at that report, because that's kind of what guided my understanding as well in my research, to come and present to you an overview of what's happening in the South African healthcare space.
Thank you so much. We actually also do have a copy of that report. Sama, you can contact Sama as well. We'll make that available. Thank you so much. Any other questions? And just maybe going back to the other question, I think also the issue of accessibility, given the vast landscape in our country from rural, etc. If we have all of these digitized initiatives, how is the network in a remote area, for instance? Will they be even able to use? So it would need a collaborative approach, even from beyond the health sector, I would imagine. I believe there's another hand.
Thank you. Thank you for an interesting presentation. Mine is on the slide that was referring to the challenges in the public sector with regards to implementation of AI. And I'm actually asking myself if there is a significant difference between the public and the private sector if we take away the finance and the expertise. So I'm looking at bias, at information regarding social determinants of health, etc. Is there a real difference between the information that's available or being collected in the private and the public sector?
So I want to just make a comment here about the private and public sector, that you must understand that although the public sector is an ailing sector, we are training doctors in the sector. We have very good, strong tertiary hospitals, and we have very good academic groups that are working on disease research across the disease, the disease burden in South Africa, and addressing this disease burden in terms of research and innovation. And so what happens is all of them are conglomerating data, right? And then these data sets are obviously residing in sort of siloed servers across the country, in terms of making research data available. So the private healthcare sector, you can see, are good at utilizing existing tools and solutions, but they are not innovating, and they are not robustly innovating like you would expect based on the actual issues within the context of the healthcare system in the country. And so, what would make sense is that if we could amalgamate disease research data, and if we could also, and I think that in the private sector, that a lot still has to happen in terms of moving towards, sort of evidence-based healthcare, because it's still largely not evidence based as such, and bringing research into the private healthcare sector. For one thing, the private healthcare sector is not allowed to actually train doctors, yet they actually have the accessibility to cutting edge technology. And so, when you are dealing with training specialists, especially if you look at oncology, for example, they're not exposed to what you can do within the private sector, and that is all based on a business plan, a business model, etc., as opposed to a research-based institution kind of model. So I hope that answers your question.
All right, thank you so much. And I believe we have our gift handing over session. If we have any more questions, let's ask them over lunch, over tea, as we continue to network.
Thank you so much, Rizwana, for actually sharing your insights and experiences with us. And I'm sure Sama is going to call on you as we start developing our policy briefs on AI in healthcare. Thanks.
Thank you so much.
Thank you so much. And we are moving along to our next speaker, Dr. Ntuthuko Pengu. As I introduce him, he is the founder of Alchemy Health Technologies, a planning commissioner and a director of companies. So Planning Commissioner of South Africa, he's a member there. He was a panelist of the Health Market Inquiry, which was set up by the Competition Commission to probe the private health sector holistically to determine factors that restrict, prevent, or distort competition and underlie increases in private healthcare prices and expenditure. Very important work that Dr. Pengu obtained his MB-CHB degree from KwaZulu-Natal University and the diploma in anesthetics from the College of Medicine of South Africa. His business management qualifications include an MBA from Wales, Cardiff, and MPH Healthcare Management from Harvard. And then the Harvard degree gave him an in-depth understanding of the global health policy and management of corporations in pharmaceutical, biotechnology, hospital, and health insurance sectors. Dr. Pengu has operated as a clinician in South Africa and in England, and as a senior executive within the South African healthcare sector. And lastly, and definitely not least, Dr. Pengu is also a fellow of the Africa Leadership Initiative. Ladies and gentlemen, guests and colleagues, please give your warm welcome to Dr. Pengu.
Good afternoon, colleagues. Thanks, Ati, for
the kind introduction. Thank you very much to Sama for inviting me to be part of discussions today. There are just 5 quick areas that I hope to cover. And obviously, based on the request, the focus will be a little bit more on what I understand to be available in South Africa today. Having said so, there isn't enough time to cover what one hears about, but the focus has been to, one, try and limit it to more the practitioner side of things. We do know that other stakeholders within the health system also have the system, but we just don't have enough time to get there. But I've also tried to limit it to, what can I say, solutions that I know for a fact exist, in the sense that it's very easy to have a PowerPoint which doesn't match what's on the ground. So I have taken time to make sure that what I hopefully am going to quote here get today. Just broadly, there obviously are quite a few definitions out there, but the one I like is the one that basically says AI refers to the capability of computer systems or algorithms to perform tasks that typically require human intelligence. This includes activities such as reasoning, learning, problem solving, perception, and language understanding. Who thought we would be saying this about health systems? Now, there are obviously many ways to categorize what's out there, but I basically just think it's 3 main categories: administrative, clinical, and product development. Having said that, there are many subcategories that fall in within these, but they typically tend to also straddle these main categories. I mean, one would, for example, if you talk about telemedicine, it probably covers a few of those main categories. The Policy Action Network, around 2020, they basically looked at the following different domains regarding the use of AI in relation to data: population health, individual health and wellness, health systems in general, and of course, biomedical, pharmaceutical, and therapeutic services. So this is really just another way of looking, but more practical in explaining what is already out there. But I do believe that a lot, certainly all of these categories, there are players in the industry that have started touching on these from an AI perspective. The question is how far, how deep, but there is a lot that we've had already in terms of what we have. I won't spend too much time in trying to go into detail. But in terms of the examples that I use here, one basically takes a patient perspective, also on the practitioner side, and then the case study itself that I was asked to also have a case study, and based on what I've come across in the market, I've chosen a University of Cape Town model that we came across in wearing my other hat in the Planning Commission. And when one looks at the example here on AI application from a patient perspective, one here, in terms of health docs, it's one of the products that are out there, and patients can book this one. Yeah, patient can book appointments, disclose their symptoms, and I think the model actually starts prompting in terms of what other symptoms you may have. obviously based on what is self-reported, and this would actually then be presented to the practitioner on the other side. And this example here looks at multiple aspects of a medical practice and clinical management and web-based applications. And of course, then you do get, if you like, based on this, possible diagnoses. And one of the reasons I'm actually flagging this, there are obviously many examples that we know, but one of the reasons I'm flagging these in particular is because I am aware of some practitioners who are actually not necessarily happy with AI going so far as to propose diagnoses. But the systems are there. So the question is, obviously, I hope that part of the discussion would actually go there. How far? Do you actually need the diagnosis, or it should be on the basis of probabilities that it could be a condition like this? Those are all the issues, of course, that are up in the air. And the next example is that I have to acknowledge Dr. Onben Pillay. We do know that he's very much into technology. And it turns out that there are quite a lot of tools that on a regular basis he's testing in his own practice. And the examples here, it's the digital stethoscope, which obviously as you listen for whatever you're listening for on the app, you get, again, the diagnosis, the interpretation of what murmurs you could be listening to. And of course, same thing on the ear examination. And of the questions again, Prof. Pillay has actually stolen my thunder because I thought I would be building up to a question of scope of practice issues here, as to at which point maybe is it a general practitioner issue or a specialist issue, and then he just hit it out the park and he said it's actually the patient. We're not even talking about scope of practice between two professionals. And again, on the other examples, these, as I said, are already in the country and out there. But again, the point that I actually want to make here is that the Genie Health one, for example, is very much, I would imagine, is the same principle. I think, Prof. Ruben, you were touching on the one that prevents falls, but I think that has to be the same technology. If one thinks that it refers to basically as you exercise, it seems to be worse than those gym instructors. It actually tells you to keep your back straight as you are actually exercising. And so yeah, again, we move because we really don't have time. This was certainly presented at a GEMS conference by CDE. And basically the first FDA cleared handheld AI fundus camera. And I think these slides, sorry, what I want to show here is that, of course, it reports within 30 seconds, even giving indication if there is retinopathy, glaucoma, blood pressure, reading, obviously, all of this really just straight in aimed at your eye, and right up to cholesterol readings, everything. We've also seen this, of course, in practice. It's no longer as novel as it was a few years ago, if one looks at it. All of this, almost the complete screening, just through the fundoscopy. I think then they just take it further and says to suggest that a lot of these does away with the need for drawing blood, because this is obviously shown here. But there is I just want to go back. There is one point I noticed. Yeah, right at the top. I think this leads to, as I round up, I want to talk about regulation. I hadn't seen this, but right at the very top, caution. You remember I did indicate that this is was introduced as obviously the first FDA approved. So I think the issue here is federal US law restricts the device to investigational use only, fine, but not for the US. Now, this obviously in my mind, without trying to explain what it means, but at the very least, it flags the issues regarding regulation. What does this mean? And what does it mean about our regulators being ready to basically look at the tools that we are discussing here? Now, finally, the case study I'm referring to, the tool is known as Aisha, which is AI-supported healthcare assistance. And I asked UCT Professor Farrell to basically help with slides that I'm going to use. But again, in coming across this was in the context of just doing work for the Planning Commission, and it was just impressive what could be achieved. The problem statement here is that there is a lot of information, but the link between the information that's there and actually what's happening at patient level is missing. I suspect, again, that's where are we scientific? If percent of information that's out. And I suspect this goes some way to start closing that gap. If you look at that picture on the left, just looking at WHO as the only producer of the specific guidelines on just one level of care, primary health care, for adults only, you're not talking geriatrics or pediatrics, there's still more than 24,000 pages to be accessed, distilled, and get the information out there to those at the front line. And so in basically moving from having the knowledge to basically applying it at patient level, this is, as we know, the knowledge to action sort of approach. And the upside down triangle here speaks specifically about the model where you start with your first generation information, your primary studies, synthesized knowledge, and then in the form of this Aisha tool is then packaged for easier use for decision aids and algorithms, obviously enabling different practitioners to be able to be more impactful, which partly also addresses the issue of urban rural. Now, just to also show you the type or the volume of information that's available there, the technology is capable of doing synthesis more than just identifying the sources. And this could be very well guidelines and policies that's local and regional level, or even at facility level. This is what the frontline worker would typically see based on symptoms as they present. Already there is a little bit of algorithm that kicks in to provide guidance, whether you're talking about a symptom level or as an established chronic patient. And this is obviously all mapped. And PEG here refers to practical approach to care kit, which is what this is referred to. I think the point, if one looks at those dots at the left, on the left there, each one represents entry into the database containing recommendations, sources, and any notes that will have been checked out. And one just marvels in looking at volumes that are volumes of information that's distilled in a short space of time, starting to kick out recommendations, 3,500 in this case, having gone through 100,000 or so sources. The point really here is about the volume of information and capability of AI to not only find it, but synthesize it in a manner that's obviously useful to those who deliver service. It's not so much that all of this volume is delivered with 3,500 recommendations to the healthcare practitioner on the floor, but obviously there is background editing that's done by more senior people, so that of all of those recommendations that are considered, it's only the relevant ones. Again, to just go back, that it's source library that looks at so much more information that enables standardized and quality care. Okay, let me just say potentially, because there's obviously still the human factor that's involved. But the issue here is that within a click of a button, you can go back to the actual source document if you so wish. And this is information on further query. It seems like even if the source document is deleted from the internet, if it ever, at the time that the study was done, at least you would still have it. You decide to use it or not. So it's got quite a lot in terms of capabilities. But as I say, no tool is perfect. And I think at the stage we are at the time where we should issue a warning to be careful. But what I'm getting is that at least from the medical perspective, there is some protection developing regarding these large language models, in the sense that the training isn't being done openly, but more and more players are really restricting this to medical information, teach their models. Now, this is the last slide regarding regulation. I definitely am one of those who aren't too hard to regulators at the beginning, because if one thinks of what innovation is, innovation really, true innovation means that if that tool that qualifies as innovation means that you could not have had a regulation for it simply because it hasn't existed before. So there is that period where regulation will lag behind. I suppose the question is how much time, or however you measure that, is enough for regulation to need to step in. A lot of these excellent tools that we seek here, what is the level of protection for patients from, let's just say, from a calibration perspective? So the question is, we do need to work with regulators, and actually those who are at the forefront of innovation should avail themselves to make this possible. The capability to integrate diverse health data sources into a single platform is a priority. I do not know if in South Africa we have a good record of this. In the health marketing inquiry, one of the issues, for example, was that there is no standardization in terms of quality of care. Industry responded, everybody started measuring and publishing quality. I'm talking at least from the hospital side, but the reality is it's still not standard. What hospital group A feels its quality is not really comparable to B. So I think the issue of us coming together to define these is important. I do think there's a very strong case to use AI to improve patient engagement and operational efficiency as well from the practitioner side by really working on the administrative tasks. I was reminded by this again when one of our speakers flashed, is it Mediscribe, I think, because this goes back to a presentation I did maybe 5 years ago based on the issue of practitioner burnout, where the biggest problem was that you either have an option with all of these electronic records, which are obviously in advance, but I believe earlier the difficulty was that you literally had an option of capturing your notes as you are consulting, meaning you are really not looking at your patient half the time, or else you continue to consult, and when you get home at night, then you start capturing your records. But then that's also now time, additional time of what is supposed to be your rest time. So the issue of transcripts that are getting developed using AI based on really just speaking and getting more and more fluent in capturing, especially our South African, very different South African, what's this way of speaking, is critical. And of course, Microsoft has got a study that shows how AI, at least the administrative part, will start to show a reduction in the cost of running practice. Thank you very much, Chair. I don't know if there are any questions.
Thank you so much to Dr. Bengu. Do we have any questions at this stage, particularly on the case study? I see our table here, and do we have any questions on the right-hand side? We have not had any questions from the right-hand side. Please, right-hand side, may we have some questions? Thank you very much. I'll hand over to the chair.
Oh, thank you so much, Dr. Pengu, for the presentation. Just in your view, where do you think the regulation of the AI and stuff like that? To me, I think I'm thinking about SAPRA and stuff like. Where do you think it falls?
Yes, certainly SAPRA bears a responsibility. I don't think there is a collaboration of regulators that needs to happen, but SAPRA certainly on the basis of devices in very much the same way that SAPRA has to regulate ECGs. But I also suspect that there has to be very much the mutual recognition of different regulators, because you probably can't really test each one, but which regulators do we have reciprocity with? Obviously, the question where, well, the one example says, well, the FDA passes this, but you can't use it in the US. What does it mean if you are not in the US, but you actually have a reciprocal relationship with the US as a regulator? It's a bit tricky, but I know as well that at Council for Medical Scheme level, this is a question as to how do they get involved in starting to look at regulating this? Because again, it goes straight to the benefit design. And as they track, for example, chronic diseases and all other conditions, if they are pulled through by all of these tools, there is obligation for them as well to satisfy themselves that these are legit and reliable. And of course, the council, HPCSA and other professional regulators also have an interest and also need to stay interested.
All right, thank you so much, Dr. Bengu. I believe we've got a few online as well, but before we go online, I will ask our host, Renee, to assist us. There's a hand in the middle. May we get a mic there, please?
Thank you. Dr. Bengu, hi. Thank you so much. My name is Vianney from a company called Cure Medical. I've been reflecting on, I guess it's part comment, part question, but I've been reflecting on some of the conversation that's been taking place. And there's an assumption that we've somehow figured out things with respect to kind of the status quo, right? Whatever technologies we have, whatever practices we have, they're basically the best that we can do. But that's not fact, right? One of the things we realized, for example, during COVID, was that there was occult hypoxemia that was missed amongst kind of Black patients because, pulse oximetry was underestimating their levels amongst those patients. So we understand that even with standard tools we have, they were not good. We're having to do race adjustments as far as renal functions are concerned, again, amongst these populations, right? So what I'm looking at, what I'm basically trying to find out is, to what extent do we basically use this as an opportunity to actually do a review now that we've got better technology, now that we've got a better understanding of the status quo, to find out, is it the case that what we have right now actually works, right? As opposed to, for example, applying too great a scrutiny on potential new technologies, and which is what we're doing, for example, from an AI perspective and other new technologies, comparing them to the status quo. And I ask this because often regulators compare whatever's new to whatever exists. But if fundamentally the baseline assessment is incorrect, we are going to run into a lot of trouble. Very keen to hear about your reviews on that. Thanks.
No, thank you very much. But I would be very interested to know who thinks that we are set. We don't need any more. Yeah. Uh, Yeah, I agree that it certainly is an opportunity to basically start from zero base, but I don't think it's really just AI. I think any new technology requires us to sort of go back in terms of validating what is there or what is new. So I agree with you in that regard, but you're right that it's mainly a comment, but I don't know how far I could go in saying what should be done, except that clinicians should not be invited at the end when it's about regulating, but right at the beginning as well, to make sure that the principles, I'm obviously assuming that the clinicians themselves, of course, would be very much sort of up to date. One of the most interesting presentations I've ever heard, it was a personal health conference, I've forgotten, but I used to attend it regularly. The association at the time, where he was addressing the issue of practitioners resisting technology. And he basically was saying it's a new day. As the AMA, they are encouraging practitioners to work with technology companies. And I'm reminded by your question because the analogy he used is that you wouldn't want to get in an aeroplane where either the pilot or the technology is missing. You want to have both. And I think that's exactly where we should be in terms of your question, with that emphasis that let's not assume that what we've always known is the baseline. It's a long answer, but it's the best I can do, but also hopefully it means I won't take it.
Thank you so much, Dr. Bengu. Can we take one last question before we go for tea? I think we need to take one last question online. and then we'll take a quick one. And when we come back, we have one question that is burning online. I think we can unmute and then we can go for it. All right. While the volume is fine. Yeah. All right. No, that's fine. We will then read the questions that have been typed, but we have one last question here in the room.
Thank you, Doc. So I guess you stimulated something as you're talking. When we think of medical technology, right, all of the devices that come into the country are regulated through SAPRA and all of the processes that follow there. But now we've introduced this new concept of software-based technology apps that we can just consume, and we have the ability to download and go to Amazon and purchase. What are the thoughts around regulatory compliance with all the new startups that are going out there, with everything happening in the software and AI space? And have we not indirectly created an unregulated environment where healthcare practitioners are not being seen or heard, but we have all these apps and tools diagnosing patients without taking our localized context in play? Just your thoughts on that.
Oh, we certainly have done that because these, as we know, but I think the point I'm making is that to a point, it's unavoidable simply because it hasn't existed before. But it cannot go too long unchecked, otherwise the patient risk then starts to creep in the longer. But what it means is that our regulators have to just think differently about how they're structured, the types of skills they bring into their companies, sorry, in the organizations. Are they able to then deal with the software based technologies that are facing us now?
All right, thank you so much, Dr. Bengu. And before we go for our 15-minute tea break, I will hand over to Prof. Dai.
Thank you so much, Dr. Bengu. That was quite, how should I say, a presentation that was for some of us an eye-opener as well in terms of where we are and where we should be. And definitely we're going to call on you from SAMA for assistance. Thank you so much. So we're really sorry for the delayed tea break, a strict 15 minutes tea, and then we come back and we're really going to try to catch up with some time during the next session. So enjoy your tea. Tea is served outside.
Guys, I've got a question. The laptop. I've asked for refresh code and what they're
Ask because because you know why we are in a manufacturing. Be safe, Muslim.
I think so, yes.
Yeah.
Because he says I'm wearing a jacket. Almost did it English. You just gotta know the keyword. Seven is not enough.
Not saying next year, so they're not going to be.
Always took a tea with you.
Everybody else. You'll join. Oh, no. I got the first slap.
Yeah, he didn't win overall. Five.
Oh, he's next.
No, he.
Okay. Perfect. All right. Thank you.
Thank you so much. My leader, haven't seen you in so long. Once at the office.
How are you?
Good? I'm always in a hurry. Good you? Thank you. Good to see you too. Finally made it.
It's a good event.
Yeah.
I've raised up the temperature, so you won't feel.
Oh, it's quite chilly in here in comparison to outside.
I need to talk to you. I need to talk to you.
Thank you so much. And like we're going to resume now because you said strict 15 minutes. But there's other spaces. Oh, is Oh, really?
Yeah, exactly. It was not like that.
How are your campaigns going?
My work is piling up.
You won't believe it. I left Tuesday afternoon. And since then, hours of connectivity.
No, I wanted to get coffee, but they were such a queue. Maybe I should quickly run now.
With NK.
Oh, okay, yeah.
Please.
Okay.
Subcompany. A company.
Yeah.
For the last couple of years. Homegrown, localized.
That's interesting.
To replace the ice.
But then coverage is horrible. Apparently there's Vodacom there.
You see,
There's Vodacom in Lesotho.
I couldn't get my roaming on
Mm.
the airport. I was banking on Incolis NK.
Yeah.
They don't assist.
In Lesotho.
Yeah, unless you make agreement.
But he also
Yeah, you
struggles.
can only roll up to.
This is your number.
So that brings everyone.
Sorted.
Baby, ngiyajabula dad. Ngifuna ubiza abantu.
Oh.
I'm not winning that one.
Never. Okay, cool. So I'll let you.
Now I'll enjoy it. So you can't just when you haven't spoken.
Yeah.
It means I'm gonna wait tonight.
So, welcome back, everyone. And I hope you enjoyed your tea. We now move to the second half of session one. And I call on my moderator for this, Professor Mfundo Mbenge, who is the president of the South African Medical Association. So you can see the commitment from the association in terms of this project, whereby the leadership of the association has come to engage with our very, very important stakeholders, which is you. Prof is the academic head of obstetrics and gynecology at Nelson Mandela University. He's a gynecological oncologist. So I'm sure AI in healthcare is close to his heart. He's involved with research and training of undergraduates and postgraduates, both at Walter Sisulu University and at NMU. He's a member of the South African HPV Society, and he's a board member of the Medical and Dental Board of Health Professions Council. And of course, he's our very own president of the South African Medical Association. Over to you, Prof.
Thanks, Prof. Tayako. Good morning, ladies and gentlemen. And we still continue with our session, which is we're looking at the current state of AI and technology in healthcare. And our next speaker will be talking on the bridging the gap in rural and underserviced area through AI-enabled solution. And that speaker is none other than Mr. Lubabalo Mnyaka. Mr. Mnyaka is an award-winning healthcare entrepreneur and managing director of Aflu Medical Healthcare. He is recognized for advancing healthcare through technology. With a background in medical microbiology, Mr. Mnyaka has dedicated his career to addressing lifestyle diseases like diabetes and hypertension that mainly affect economically active Africans. His company, AfluMed Healthcare, is celebrated for its pioneering cloud-based healthcare record solution, which have won accolades not only locally but internationally as well. Mr. Mnyaka is skilled in sales management
in project management, and in entrepreneurship with specialized knowledge in designing as well as implementing healthcare technology system. His experience include leading sales initiatives, cultivating client relationship, and developing innovative solution in healthcare. I want to say this profile encapsulates Mr. Mnyaka's ongoing commitment to, as well as leveraging healthcare technology to improve the lives across South Africans, positioning him as the leading figure in Africa's health technology landscape. Ladies and gentlemen, let's welcome Mr. Mnyaka. Over to you, sir.
Thanks. Thank you so much, Prof. I was shocked, Prof, that you're actually talking about me then. You know, it's always nice and good to write good things on paper, and it's different in reality. Ladies and gentlemen, all protocol observed. I come from a very rural background, and now that it's December holidays, I will have at least 30 to 50 locals that I've always tried to tell them I'm not a doctor, but they're having none of that. When I get home, my mother already has a list. Mom so and so is having a problem with her feet. There's a sore that's not healing. So and so is reacting to his hypertension medication, and the list goes long, and you get to wonder what is really happening. And then when I engage the locals to find out what is the problem, because you find that indeed they are on medication, they do consult. Most of the time, it's always almost too late. And one of the key challenges they have is access to healthcare. So this kind of gives an introduction to the topic at hand. So as I've just mentioned, they have to travel quite long distances just for primary healthcare. As you would know that our public clinics are already heavily burdened to a point that it makes no sense to them to actually wake up at 3 a.m., get to the clinic at 6, wait, they get served at 2 o'clock, and then they're told only a Panado is available. To a point that there is actually one doctor in Ezingolweni that's about 3 hours from home. Patients actually higher quantums in numbers. The quantum is a 15, 16 seater, leave home at around 1 a.m. and they get there 3 hours later and they queue. You would find quantums queuing. So this tells you once again that finances are not really an issue. The issue is deeper than finances. There's always that assumption that people in rurals cannot afford quality healthcare. Now it brings back to the point that I made earlier on, that it seems that the first problem is access. How do we make healthcare accessible? As I've given this context in the rural background, as I've said that there's limited healthcare facilities. We're not going to build more clinics anytime soon. There's a shortage of skilled professionals. We know that we have a problem even with student doctors that have just graduated, need to do ComServe. We know that there's a push against being deployed in the deep rurals. So it means, once again, that as much as nationally there is that shortage, but it's even worse in rural areas. And then there's also lack of real-time medical resources. One patient has about 10 to 20 files. They'll go to this doctor, and then they're not happy. They're never going to return. And then they go to the next one, and then they're not happy. Then they start sharing medication. And then one would say, I think mine works. This is the medication I got. And then they start using that very same prescription. You know, it is a mess. I can't really paint the picture more than one having to experience and engaging with women and children in rurals, the elderly, and those living with disabilities that they're highly affected. So basically the talk today is really how do we use AI, you know, transform it as a transformation tool in making sure that healthcare is accessible, affordable, and of quality. This paints the picture. At this point, most of the time, it's almost too late. I mean, if clinical studies say that, for example, with diabetes, at a point of diagnosis in South Africa, already about 20% organ damage has already occurred. So now you can imagine when you take it back now to the rurals, and the only time when they really start to consult is when someone is in their deathbed and it doesn't actually help, you know. And that's the only time as well you see them changing, you know, the lifestyle, starting to cook a specific meal for this person, you know, starting to buy certain things for this person. And that time, it's almost too late. So patients are not empowered. They're not involved. They're not informed in their healthcare. How do we do this? Because we will not be multiplying doctors. This is where healthcare, AI in healthcare comes in. How do you actually tap into that? I really applaud these guys. They're called MedE Screen. So basically, they have this bag that they've invented. It runs about 20 common tests and results. They get results within like 20 minutes. And they have actually tested this against empath reference testing, and they got, I think, 99.8 accuracy. These are these are some of the innovations that we really need in rural areas. You know, this allows preventative care, you know, an opportunity to actually pick issues as early as possible. And this also breaks down healthcare to more affordable means. For example, this doesn't need a GP. A nurse can run this, and then it's sent through, you know, developing those clinical pathways that what can be handled by a nurse, let it be handled by a nurse, what can be handled by a GP, etc. So at the moment we clear those referral pathways, we're actually clearing the load as well. So this is these are some of the innovations that are out there. And then there's another one by Telecare SA. So basically, their model is to distribute these at chief houses or compounds and at schools and churches. So basically, one would get in and it does your normal vital screening and also offers virtual care opportunities. Going back once again to trying to access primary health care, you find that one has to wait for so long to see a specialist because the list is just so long. And this now breaks down the geographical barriers, because if a specialist is not available in Mthatha, then they can actually consult with a specialist in Joburg or in Cape Town. So once again, AI opening opportunities to improve healthcare. And obviously, no solution comes without challenges. We know that there's challenges such as connectivity. This is where actually I think we're really blessed to have the challenges that we have in South Africa, because they push innovation. You don't have to think out of the box or scratch your head. What can we do? What innovations, what inventions we need? We have so many problems that need immediate solutions. For example, we're building so many applications that need internet, web-based applications, etc. But in the rurals, almost everyone has a WhatsApp. Have you thought of actually using WhatsApp more than just, you know, chatting, where one can actually do a symptom checker, where one can actually load their records, or that will be stored centrally or whichever platform? You know, there's just so much that can be done just via WhatsApp. And I mean, even grannies these days, they're all on WhatsApp, and they understand how it works. Some that are on Facebook. So it's not a matter of not being exposed to technology, but how do we use what they have to actually cater for healthcare instead of introducing something new? Because when these were introduced initially, WhatsApp was, they would even say, we am WhatsApp, as in, do you play WhatsApp? because they took it as something for kids, not really something that would add value. But as it progressed, they actually got to see, actually, there's something here. So now imagine if we keep on introducing new things, at what point are we going to get to the wheel really turning fast? Let's look at what we already have. How do we tap into that? Like I've said, WhatsApp is the best platform that we can actually integrate a lot of solutions in there. Okay. And once again, I've said that there's no solution that doesn't come with challenges. How reliable and diverse, are these data sources? Affordability, once again, internet affordability. ICASA has actually done some strides in making the broadband, I've just forgotten the frequency, where it was on tender and service providers were bidding for that. So the goal is to make internet access as affordable as possible. Once again, going back, with WhatsApp, you can actually buy for 7 rands a 7-day pass versus buying gigs of data. So once again, now you see, if you actually channel solutions to what is already used, and they would actually not see it as a separate expense because they also get to chat. So you're not actually adding more expense into their lives. You're actually adding more value. Now they get to access more things via the platforms that they already consume. And then obviously with training for healthcare professionals on AI tools, I must say, in the journey of our company, we do a centralized healthcare information systems. I would say that we've worked, in fact, with over 300 doctors from different specialties, just engaging, finding out what matters to them. What the biggest highlight for me was the fact that there's a lot of great solutions that are developed by great developers, but they are not clinicians. So in practice, there's often challenges. You find that, yes, this solution is great, but it doesn't align with my clinical flows. Now there is that gap. You find them that they only now get to use only the billing part of that system because the clinical part doesn't really flow. As Dr. Bengo said as well, in that you find that now with the systems, you're required to basically take time from focusing on a patient, you're capturing your notes, and you find that it is not as practical as well. When you have to take this home, you would have had to make notes somewhere as well to remember. So now there's a duplication as well. So we need involvement of clinicians in developing solutions for clinicians. And there's often resistance the moment you mention EHR, because that's what most have been exposed to. So I would request that, clinicians have hang in there and have some, a listening, I would say, grace to these tech companies that are bringing in solutions. Listen, have your inputs. At times, it's not really about buying, but it's about engaging and getting that feedback so that we can have informed solutions, Yeah, there's an issue of ethics, equity, and community engagement. There's no way you will build a solution for a community, whether it's a community as a community of patients or a community as a community of clinicians, without involving the end user. Otherwise, we'll have great systems that never work. Government has invested so much in tenders, for example, for EHRs, practice management, etc. But still, government is still heavily paper-based because none of those worked. Once again, we see wastage there. So there is a need to actually involve all stakeholders in developing these solutions. And the issue of ethics as well, we know that data privacy is big, and there is a need to secure data. One argument would say that it's much actually easier to access a file that's in a cabinet or stored somewhere in the practice versus one online. We have developed so much technologies and security to actually secure files online. Most of the time, the hacking happens from the end user side versus directly onto company servers. So you find that there's phishing emails and other tools that allow the user to disclose their login. It's no longer a case where the hacker is actually accessing the database directly. So that once again, patients, doctors, and other end users need to be empowered in cybersecurity. And there's many ways to effectively put this together. The benefits really outweigh the risks involved. And then another issue is systems not talking to each other. That speaks to equity. You find that certain patients or clinicians that use a certain product have more information versus those that use a different product. So once again, this leads to another type of fragmentation of care, moving from paper-based now to tech-based. If these systems don't talk to each other, at the point of care, the clinician still doesn't have the most accurate and up-to-date patient information. So we're adding another problem again if these systems don't talk to each other. And as I've said, I cannot overemphasize the importance of community involvement. Community needs to be involved. You need to know what are their struggles. As I've just said initially, that when I get home, I have so much to deal with. And these are the opportunities, in fact, where you're supposed to be getting more information. And then after that, we sit together. Okay, this is the information that we have. How do we move forward? And as I've said, AI is not just about developing solutions. Yes, we've developed a great solution, but how practical is it? It's all about creating equity. It's a basic human right to have access to healthcare, but how do we make sure that we empower patients in the rurals? Women and children, they mostly need care, elderly, and those living with disabilities. So that is a highly neglected area of primary health care that I believe any innovation should look into. If you can make it in the deep rurals where there's no running water, where there's issues with electricity, where there's minimal or no signal, then trust me, you would have solved a major problem. Then it's much easier to replicate that solution to the greater country. With that said, ladies and gentlemen, I thank you and I look forward to your engagements.
Thank you. You've touched important issues about resource and as well as accessibility to healthcare. I think those are important when it comes to AI, and you've given us quite an important insight on that. I will welcome any questions that are and it's loud and clear. It means that you've really made it correct. I don't see anyone online with a question, and therefore it remains me to thank you. And when you go home this December, we'll be there to ask you questions. You'll be a doctor now. Thank you.
Thank you so much, Prof.
Prof. Tai.
Thank you so much, Doctor. It was such a good talk. And in fact, it brought us down to earth, and communities come first and foremost. AI in healthcare is not going to work if we don't get the communities involved. Thank you for reminding us about that.
Thank you so much.
Thank you. Our next speaker on this session is Mr. Wayne Chaneka. Mr. Wayne Chaneka is an information technology executive with a career in every facet of IT, spanning over 20 years. He holds an international diploma in computer science, and he has held senior management position over a period of 15 years in the corporate sector. Wayne is equally passionate about dynamic leadership that underpins the development of cohesive teams and innovative, robust IT operations that can function in synergy with an organization's local as well as strategic position. As an ICT innovator with various industry, Wayne's expertise is an integral part to the operations and the strategic trust within research of organizations, enabling them to create global footprints. We are fortunate to be placed in the most exciting times in IT. Now, I want to say is the time for business to take full advantage of the best technology, and with cloud, as well as premise and hybrid environments. Now is the time that we have, and it's the best time for diverse skills as well as diversified skill sets, as well as your disposal that is there. Ladies and gentlemen, this time I want to give you Mr. Wayne Janika, who will be talking to us on using AI technology in healthcare. Over to you. Thank you.
Hey, good afternoon. So there's been a lot of chat in the room around how do we improvise technology, how do we use technology better, public versus private, private versus public. And I think I'm really proud to stand here because I've seen a lot of innovation in the public sector recently. I was sharing with some of the colleagues during the tea break that as Telkom BCX, we're one of the first that have taken the step in empowering KZN Department of Health in building a electronic health network. Very specific. We termed it the e-health network. And the reason we've done that is because we wanted the clinicians, the management, the CEOs of the hospitals to start to look at this and go, this is going to be used for the betterment of healthcare through technology. And through that, we start enabling some of the things we hear in the room, this AI, this big data, and all of this stuff. And, we call it the plumbing effect. We need to lay that infrastructure, get the plumbing, so that the water can flow through it. And we all know water is life. And I think that's the way we need to start looking and treating data right now. Data is life to us. And how we use data is essentially going to change the way we work and live. So, as said, I'm Wayne Janika. I am the technology thought leader around healthcare within the Telkom BCX group. And, for me, it's really passionate to be able to stand up here and speak about this stuff because, one, we know what the pandemic done to us, right? And we talk about the pandemic as if it happened not too long ago, but I think we're still reeling from the effects of the pandemic. But one of the great things about the pandemic, it forced us to innovate. It forced us to strategize, and it forced us to relook the way we deliver healthcare. And the real positive side out of it is we had something for the first time in history being developed in 4 days called Electronic Vaccine Distribution System, EVDS. And that call was made at 4 o'clock in the morning by the president to say, we're going to distribute vaccines electronically. So if you think about that, right, the highest person in the nation is now sitting there thinking, how do we take something life-changing, a global commodity called vaccines for a pandemic called COVID, and we're going to do this digitally? If that doesn't set the precedence for the way we need to start thinking as healthcare thought leaders, as healthcare advisors, then we really need to start challenging ourselves as to what are we doing here in these positions we hold. And it should force us to start thinking about the way we look at healthcare, the way we envisage healthcare, and the way we want healthcare to be delivered. It's all good and well. We see all these great technologies from abroad. We see US technologies, European technologies. But as South Africans, we need to be proud to be delivering technologies fit for the soil of Africa. So if we look at the market, right, it's an untapped market right now. It's a 360 billion rand market that we're talking about. And for the clinicians in the room, you're probably thinking, wow, okay, how do we start utilizing this so that I can run my practice better, so that I can be more profitable and all of that stuff. But for me, that number tells me that is the potential global investment we need to start making in healthcare. And that number should empower us to work and think a lot more strategically around how then do we take it forward and use that kind of investment to start leveraging what we need to do. Sorry, I think the guys are having a slight technical challenge. And when we start thinking about that kind of investment, we need to think about that investment in our localized setting in South Africa, in Africa, right? How do we start using the data and information that we generate in order to become more strategic, in order to become more articulate in what we're trying to do? And I think that's why I raised the question, at what stage do we start looking at it and also start, as South Africans, saying the kind of technology that we are importing through all of these software apps and all of these AI tools, how do we start to regulate it, but also give our local environment a fair chance at playing in that space and having the ability to compete at a global scale? If we think about it, right, artificial intelligence, AI, big data, it's very compounded. It's a lot for us to process. Electronic medical records. There's currently a team going across the whole of South Africa, which compromises of all the group CIOs within healthcare in public sector that have been tasked to go and look at that electronic medical record for a national level. So again, when we start saying public sector isn't doing enough, they're actually doing a lot. It's just not out there. It's not been vocalized. But that is the level and that is the integrity of what's been done in order to ensure that when we start thinking about this stuff, right, we think about it from the correct lens, we look at it and we adapt it from the correct lens, but we also look at how others have done it. And China for us is a really good example, who's now taken the leap and has been doing a lot of this stuff around electronic medical records, innovating in healthcare, delivering healthcare at scale, delivering healthcare at speed, delivering healthcare to a population group that's kind of the forgotten people, our older folks. How do we get them to start using healthcare? How do we get them to empower them through mobile devices to acquire healthcare? And how do we empower them to be part of the healthcare ecosystem? And I think our learning we can take from that is, as our brother spoke before, he leaves home and he comes into the big city. He leaves Ugoko sitting there, who now has to fend for herself. So how do we empower Ugoko to access healthcare through the mobile device that he gifted as a present over Christmas? I hope you're going to take a new iPhone 16 for her, brother. So if we look at where the big spend and where the big focus is right now, electronic medical records, right? Fundus imaging, CDS, radiographic imaging, pathological imaging, and ultrasound imaging, right? So imaging, a really sensitive part of the healthcare system, but such an easy part for us to think about as to how then do we adopt all of the technologies that we have and how do we improvise the technologies we have back into the public healthcare system? How do we leverage what the guys have done in the private sector and start to use it? And I think that's where a lot of people get confused around the concepts of NHI. NHI is not this big, scary beast. It's about equitable healthcare access. How do we start forcing equitable healthcare access? And unfortunately, the demon in the room is the technology. How do we force public sector to start adopting technology at scale, at pace? How do we as clinicians, as professionals, start improvising solutions that makes public sector approve budgets faster for that kind of stuff? And I think what we need to do is also learn from our counterparts across the world. How have they done it and not try and reinvent the wheel continuously? So when we look at healthcare in South Africa, we know our major pain points, right? Inadequate staffing, inadequate funding, inadequate facilities, inadequate access to the facilities, no ability to know where stockouts are of medication. So when we think about this, right, that is all data, and that data starts to guide us. So what we need to start thinking about is how do we take hospitals and make hospitals a digital ecosystem and a digital economy that allows patients to see, I've got an appointment here, they might not have my medication, so I can alternate to a new clinic. We're also a nomadic society. Yesterday I was in KZN, today I'm in Joburg. If I fall ill in Joburg, do I now need to go back to KZN to access my care? How do we start creating that ecosystem? How do we harness some of the stuff? One of the previous speakers spoke about Care Connect, which unfortunately was shut down. How do we revitalize programs like that, which create the digital data exchange to allow us to exchange data? How then do we empower us to own our data and put us back in charge of our healthcare? So how do we then move prevention to cure and the typical AI process, right? So when we start thinking about it, we need to start focusing on that entry point. When that call is placed to the clinic, how do we, or to the contact center, how do we empower that contact center to be able to speak in all official 11 languages? Because we now live in a nomadic society, so you might not have a Zulu person in KZN, you might have a Sutu person who only knows how to speak Sutu. How do we empower the contact center to be able to translate his problem in order to get him access to healthcare? How do we then convert that into a clinic visit? How do we convert the clinic visit into a hospital visit? How do we ensure that the data that started at the contact center ends up at the hospital so we don't miss the primary causes of his illness that's been lost in translation because he lost consciousness between the clinic and the hospital? So when we create our systems, when we start empowering our systems, how do we take all of this information, use generative AI to then also diagnose the patient over the phone and preempt the clinic so they know what they're dealing with, to reduce the amount of man hours asking the same repetitive questions that the paramedic or the clinician on the telephone could have possibly asked, right? And when we start thinking of these modalities of care, how do we infuse all of this technology into a working ecosystem that is not governed by somebody who's looking at it from a profit perspective? And I think that's the important part. Healthcare, yes, it's a profitable industry. There's a lot of money in it. But how do we empower the patients to become the profit of their own healthcare? So when we look at it, right, in a public healthcare setting, We've seen a couple instances of applications being used from policy planning, public health, population health, hospitals, and insurance, right? And what the guys in China have now done is they've taken that entire software ecosystem layer, but made it interoperable so that one system has to talk to another. That creates fairness in the ecosystem, but it actually creates a legacy of patient data fairness, where the patient now owns his data from the time it was in a policy planning or all the way to his insurance claim. And he can now see and transact his data throughout that whole ecosystem and throughout that whole layer. But we then use data models and data rules to start creating healthier environments for him. We can say, we know you a diabetic patient. We see you've got hypertension. If you change your lifestyle in this area, it will improve your health outcomes, and that way your insurance will now be lowered. How do we lower those barriers of care? And how do we make it now equitable and equitable for our patients? So another scenario is within the pharmaceutical space, right? Where we all know big pharma love data. They want data, they want access to data. They use data for good, they use data for profit, they use data for everything they need to do. But when we start taking that data and converting that data into actual science and using that data to become transactional, we now see a situation where we can create sequences for African DNA and start creating pharmaceutical products specifically designed for the continent of Africa. One of the things that we don't really see within our space right now is the use of traditional medicine. During the pandemic, one of the things we saw in Vulindlela district, more patients were accessing traditional medicine before they transferred to hospitals for COVID treatment. When they ended up in hospitals, they were having adverse events because nobody knows what they took in the traditional medicine space. So how do we use that kind of data and integrate that data back into the pharma space and then convert that data science into a science for Africa? The breakthroughs that we're now seeing is purely been driven through some of our modalities, right? And some of these breakthroughs we're now seeing are based on the genome sequencing we're able to deliver, but a lot of data is missed in those sequences. How then do we start linking all of that information through our EMR, through our CT images, our pathology data, and all the other pieces of information? And the only way we can do it is now leveraging of the cloud and using the cloud successfully to bring that ecosystem in play that allows us to start really thinking about the transparency of data for patients, but letting the patient own the data and give the patient the ability to decide how he shares that data. And the only way we can do this, again, is through technology. So without the cloud, without this big data, without the wearable technology, without our medical devices, we are losing a lot of data in our context, and we're also losing the storyline of our patients. So by enabling this and enabling the ecosystem for our patients, we're now enabling the ability for us to treat our patients better. Precision care becomes a reality based on the information we know, not on the statistic that was given to us earlier. In a consult, we only use 3% of the data provided to us. By demonstrating all of these stuff, we now create a national medical AI public platform. Think about that, right? A national medical AI platform. And China's successfully done this. And they've done it through some of the products with Huawei. And what that means for us is we now have the ability to also control the way we use AI successfully by not allowing players into the ecosystem that abuse the data for wrong reasons. And in doing that, we create a policy that puts trust back into the end user, the patient, you and I, that we know how our data has been consumed, we know how data has been used, and it gives us the ability to also use our data to work for our own good. In doing all of this, right, the medical record has been the one untapped piece that South Africa has lost. It's the one piece of data. And, coming from a public healthcare background, one of the things that I've seen, and I've seen happen time and time again, we have a patient walk into the clinic. He's initiated on art. He doesn't like the way the nurse spoke to him. He leaves that clinic. He goes to the next clinic. He has the same test. He's initiated on art. He then realizes, oh, my auntie works at the clinic. I go to the next clinic. How many times have we placed burden on state purse because we don't have a transactional layer that says the patient started there, you can continue his care? We don't have a continuum of care system. So when we start thinking about this and when we start building this out, we need to think about realistically, what are we dealing with? The people we're dealing with, the people coming over our borders that we're dealing with, and then how do we create the billing models to also recover some of that money back from our neighboring countries? Medical records creates quality care, but it also creates the foundation of AI. And we can only really start having that real deep conversation about AI in medicine once we start getting electronic medical records. But now let's take a step back. We assume we've got all this wonderful data on medical records, we've got all this wonderful information. How then do we use that information to start making real in-depth solutions and putting power in clinicians' hands that give them the ability to treat more patients more quickly, but without putting heavy strain on them because they're already burdened, right? We have the highest patient to clinician burden ratio. So if we think about AI and we think about all these things we do, there's solutions that we have in our stable that allow us to connect to our high key units, connect to our ICU units, that allow us to monitor our flow control through intravenous, allow us to monitor the patient's movement on the connected bed, allow us to see the patient's movement, facial recognition, using camera technology, using information that then gives us the ability to see that this patient's on a certain dietary regime. And then how do we translate that information into a better outcome for the patient? If we discharge this patient, would he readmit? You know, we start thinking about all those things. And fortunately, in the organization we sit in, we have these tools that allow us to do it. We do it in the field through our medical diagnostics cards. We do it directly at the patient's bed through our medical cards. And if we start bringing all of these things together, we now create an ecosystem that harnesses possible diagnostics that we could have missed, that harnesses energy of other patients in the same race groups, in the same age groups, in the same biographic groups, that then allows us to think about, oh, I don't need to remember that patient that I dealt with 6 months ago. No, the information will translate immediately and give us possible diagnostics that we can use, implement, and create better outcomes for our patients. You know, imaging, I think, is the one area that we've been really successful with. We've done some work with some of our customers where we started integrating into their AI imaging space. And we are now able to tell them that that patient has a broken bone, there's a tib fib fracture, you can proceed. If we look at the public sector environment, currently, that could take up to 7 days. So imagine a patient laying in a hospital waiting for 7 days just for an image to say, please fix his bone. That's a painful experience, right? If we can translate that in 7 seconds and have a radiologist sign it off or have a locum sign it off, that creates a more pleasant healthcare environment. We now change the perception of public healthcare because all of a sudden that 7 days down to 7 seconds makes a better experience. And how do we create that better experience through technology? How do we infuse technology that allows the patient to see, I am a person, I am a human? And I think that's the one approach we've lost within our public healthcare sector, that everybody looks at public healthcare and go, oh, you're going there to die. You know, it's no good. It's actually not a nice environment. I spend most of my days in public hospitals, not because I want to make money out of them, because I want to understand their ecosystem so that I know how to help them and guide them towards solutions that will better prepare their outcomes. Pathology, massive space, right? How many blood tests go through the system? How many blood tests go through the system and have a long delay? There's a massive transport delay involved. There's logistics, there's chaos, there's bags sitting waiting. You don't know if they were managed at the right temperature controls. You don't know the chain of custody of those samples, right? I know there's an instance about 5 years ago where one of the Department of Transports had a roadside clinic who were testing for drunken drivers. They're drawing blood. Of the 25,000 samples, only 200 made it to the lab because they didn't have the ability to manage that kind of volume of samples. If we can do in-field testing through connectivity, through Wi-Fi, through data, through our cloud solutions, and deliver the pathology result there and then, not only do we create a safer road environment, but we also lessen the burden, but we create this area that reduces our medical legal liability claims. So in all of this stuff, we also need to think about the medical legal liability issues that we sit with. Labeling of data, you know, again, these are spaces that we're really proud of. Our high performance computing environment allows us to see images and detect problems a lot faster. We no longer rely on a clinician to detect an issue. We back the clinicians up. We give them the confidence in their diagnostics. We give them the ability to create a very strong professional environment that reduces this very expensive cost of treating patients through technology and delivering quicker results through AI, allowing patients to get better access to care and faster access to care. Dynamic medical imaging is not an unknown, right? There's lots of companies doing it in South Africa. But when we start thinking about it, how then do we start sharing all of this information? How do we start sharing this data with other clinicians through patient access records, where the patient says, yes, I give you the rights to see my data because I wasn't quite happy with the diagnosis I received from Dr. One, but I'd like a second opinion. Remember, second opinions become costly. So when we think about the burden of care and the reason why healthcare is stigmatized as the most expensive commodity you have in your life. It's because sometimes we also add to the burden. We're not happy with the answer we got you. We're going to get a second answer. But if we start sharing this data and use technology to drive it, not only do we create a better outcome for clinicians, but we also create a safer environment and a safer space for our patients to start working with. And again, through our portable devices, and some of it is on display in the room next door, through our technology landscape, we now create the ability to deliver a better patient experience and a better patient outcome. But it all comes back to that health management, right? And creating that single point of a medical record, creating that single check, creating a single expectation of what the patients are going to see. And again, if we think about what Huawei's been doing in China with some of the hospitals in China, they have successfully delivered this technology at scale in under 3 months. In South Africa, we'd go to a tender process, we'd go through an extensive list of checks in order to get that. And I think one of the things we're really not doing successfully as a country, and something we need to think about, how do we leverage technologies on what the others have got right? And how do we adopt that technologies into our ecosystem and use our partners in the ecosystem in order to deliver this technology and not be afraid of using it? Because sometimes we just get stuck in the mindset of reinventing the wheel. And last but not least, when we start thinking of extracting this data, how do we create the disease assessments, the guidelines, and how do we create the plans for our patients that talk into our context, that talk into our country? How do we create our solutions that look at what is the guy eating? What is his staple diet? What is his work environment? What is the biological environment that he works in? One of the studies that I participated in when I was back in KZN was looking at why is there such a high risk or a high increase of TB patients coming in Durban South Basin. And we found the answer by looking at the municipal air quality data. There was a pollution issue. We could see it, right? So lungs were under strain. We then went to the Department of Agriculture and we asked, what plants can we introduce to reduce that pollution level? What can we bring into this environment to start doing things better? But all of that was found out through big data, and then using that big data to analyze that environment over time, and then we started to notice the drop in TB admissions. So I think what we're saying here, right, is how do we create the vision? And as a collective in the room, I don't see it as a BCX problem, a Huawei problem, a summer problem. As a collective in the room, how do we start solving these problems? How do we articulate these problems? Think about what we're trying to do, and then use the AI. Or are we going to rely on another country to bring their models, bring their methodology, bring their thinking? Yet we've got the greatest minds in the room. So I think it's really important for us as an organization, us as a community, us as a collective, to really think about this and come up with the solutions and be brave and be bold and say, we are going to do this. We are going to try that. We are going to go to the ethics and challenge them because we know this is for the good of the country. How do we reimagine healthcare? Thank you.
Thank you. That was clear. That was beautiful. Any questions? I see that there's a hand there.
Okay, no, thank you for a very interesting and engaging presentation, I must say. And also wanting to commend what you've just mentioned with regards to, you know, coming up with local AI solutions versus importing and localizing. I think that's what we need to echo a lot. But thank you so much. And then I just wanted to ask a question. Now they say data is the new oil. Obviously, we know big data we need for AI solutions, etc. But in our context, I mean, if data is the new oil, it means it's a lootable resource and it can also be exploited. I mean, we have history to look at and the genetic material that is outside of the country. And, you know, the individuals and their families have no control over that. So what would be your suggestions as to how we look at, you know, trust building with what I've just mentioned as a background to my question? Thank you.
That's a great question. And fortunately, South Africa is at the forefront of that, right? So we've just created a new data AI policy, which governs how we use data, how we use information. I think the challenge that we have, and this is where I think for SAMA, for instance, it's a really good place to step in. that policy is written so broad that it speaks from data, from how do you deal with data in the way a retail store deals with your data versus how do we deal with medical data. And what it now allows us to do, again, as a collective, is come up with the policy and the framework that says, how do we want to use this data? You know, one of the issues that we foresee, and I think I asked the question and maybe I didn't expand on it earlier, is medical data in South Africa technically can't leave the borders of South Africa. So when we import all of these apps and we are not localizing, how do we know our data is not being exploited on the other side of the continent? How do we know what the data is being used for? So where we need to start challenging it is we need to start looking at those policies and guidelines that have been created and start influencing those policies to say medical data needs to be stored like this, in this format, in these locations, and can only be used for ABC, beyond that with the consent of the patient. And that's one of the things I don't see in the policy, is how do we consent from a medical perspective? In trials, you consent the use of your information for the purpose of a trial. The same now within medical. How do we start building out these big data models and these big data lakes? We need data. But have we as individuals consented our data for the use of that? And I guess that's where the policy needs to be challenged. And again, I'm hopeful that somebody in the room will put their hand up and do that.
I see two more hands.
Hi. I just want to find out, in terms of South Africa's spend on healthcare, currently we spend about 12.2% of our overall budget, which is higher than the global average. And that seems to be an issue that needs to be addressed. And is it not simply a matter of reallocating some of those resources to unblocking the system, identifying areas where things can be streamlined, and using some of that budget wisely in developing these systems in things like radiology, as you pointed out, and so on? What is stopping that from going ahead? Why isn't that happening at the moment?
Okay, cool. That's could be a bit of a controversial question, but I'll take a stab at it. So I think one of the issues that we also need to be able to articulate in and do it as responsible citizens is how much of that budget that you've just mentioned is allocated to medical legal liability claims, right? And how much money is the department putting aside as medical legal liability claims? If you speak to some of the CFOs in the public health setting, they actually tell you there's a budget, there's a line item, medical legal liability claims. And I'm not gonna, you can go Google it. And yeah, we'll see how you sleep tonight when you look at how much money is spent, right? But in doing that, that's the challenge and that's the problem statement that we solved in KZN Health. We know that a big chunk of your medical legal liability claims, 57% of it, sits in the fact that paper is lost. So we are now digitizing that environment in the hope that we bring that paper into a digital space, we record that information, and we can now translate that information when court orders come to say, but hang on, here's the medical file. Nothing's lost, right? The information's there, it's transactionable. And so when we think about it, if we are able to digitize the environments, push electronic medical records, push storing the CT images into a vendor neutral archive, and also translating that information, because remember, again, we're in a nomadic society. So if you treat it for something in KZN, you go to Eastern Cape, you get care there, and the care is botched, and you come back, not saying that Eastern Cape botches care, but as an example, and you come back to KZN, you then go and sue the KZN department, and they have no clue about your treatment that you just had, unless somebody comes forward as an honest citizen and says, yes, he did go to the Eastern Cape for that care. So by creating that data exchange and creating that sort of space where information can be shared, I think, yes, again, data technology will really reduce the amount of money we spend and we waste, but it will also improve what we see going out the back door into medical legal liability claims.
No, it's not to CEO. Yes, but we have one person that will give.
Yes. Hi. Thank you so much, Wayne, for your presentation. I'd like to know your thoughts about how we are going about the socialization of AI, and whether you think that our approach is correct. The reason I ask is I don't remember as extensive an engagement when CT scans were introduced, but we trusted them to work as intended. Unilever doesn't go around making a whole lot of noise when they release a new soap, but when we use them, we trust that they work as intended. When the phone was introduced, the same was true. Do we not run the risk here of trying to make everyone an expert in AI? And before we can make a decision around that, because we don't trust the technology custodians in introducing a technology specifically for healthcare that can be used as intended.
Great question. And I think I asked a similar question earlier, which is how do, so we know that SAPRA is in charge of regulating medical devices, but there's no body that's regulating how we use AI. There's no body that's regulating how do we create these learning models, and we just trusting the system. So I think there is actually a big problem statement in the room that says, who is the body that then regulates this? Who looks at it from an ethics perspective? Who looks at it from a data governance perspective? But who also checks it from a clinical perspective, right? So yes, we rely on many models. We import models from India, from China. We bring all of this technology from the US in, but at no stage has any one of us actually questioned it. We just go, yeah, it works. And I think that that is the real foundation of what we're trying to achieve here. Is we know AI is important. We know the uptake of AI is important. You know, I did a talk for Afri Tech 2 years ago, and the title of the talk was "Paging Dr. Google." When you feel ill, what is the first thing you do? You Google your symptoms, right? And we trust what Google says, and then only afterwards, when you really feel bad, you go to your clinician. So when do we start stepping into the room and creating a body that says, right, we will be tasked with looking at how do we regulate this? And I think that's really important for South Africa. There is no body that's doing that. We just trust what is given to us. And like you said, when you buy a new bar of soap, it smells good, it looks good, hey, I'm going to continue with it. But you don't actually know the components that go into that soap and whether it's doing any harm to you or to the environment. So by introducing regulatory bodies, we're not trying to stifle AI, we're trying to hold AI honest.
Just two questions online. One is Care Connect, the private sector health data exchange, was discontinued as it was not financially sustainable. What can we learn and share across private and public sectors to adjust for the future models? The second one is on localization and opportunities for Africa. Who owns the information and how transparent are these policies? And when AI learns and generates more code, and when there's collaboration across different entities, who owns this?
Sure. So the first one, I think it's a bit of a personal one because I was involved in part of the Care Connect journey. Care Connect was an awesome application stack. It was essentially a health data exchange, right? And it allowed the private sector to exchange data between themselves. I think the biggest learning we got out of this is it was run by the private sector. Public sector didn't have much involvement in it, and yet that could be the tool that solves the issues between how do we share data between Eastern Cape, Northern Cape, and KZN. And the big thing that I think I've personally learned from this is how do, at what stage do we involve public sector, right? Remember, we still have a Department of Health that is responsible for both public and private. And at what stage does the Department of Health put their hand up and say, we want to be part of this journey, and then also become part of the funding model that equates to it's not financially sustainable. No, it's not financially sustainable. It's the fact that the use of it cannot be used for the private sector and what they intended it to do, but it's a great tool that will solve a massive issue within the public sector, with the nomadic society. So I guess for me, the big thing is at some stage, we're going to find a point of collaboration where public and private need to collaborate better. And I hope I've satisfied that question. With regards to AI, the data journey and the African data, right? The African data is the biggest untapped data, which holds the most amount of answers from a genomics perspective. And it's the most intriguing amount of data right now that we all want our hands on. But now we need to be responsible citizens as to what we're going to do with that data. So again, it comes back to the AI policies, the data policies. How do we exchange data? How do we create an environment for exchanging data from a clinical trials perspective to medical health records that actually need to be shared because the patient is Zimbabwean, he was in South Africa and now finds himself back in Zimbabwe or Rwanda, and responsibly we need to share that data to better his health outcomes. I see this as an African collaboration approach. Maybe somebody like the CDC needs to step up and also take the reins here and say, we want to be part of the conversation. And if you think about that answer, think back to what I just said about the guys from Care Connect. Because there's no involvement from a public sector, from a governance perspective, it just became a pipe dream that ran its course and then unfortunately didn't succeed. When we start involving the role players that actually think about public healthcare, that think about healthcare, not just public healthcare, from a continent perspective, those are the role players that need to step up and say, we want to be part of this journey. Thank you.
Thank you, Wayne. There's a 2-minute video while Prof. Dai is going to be handing over. 2-minute video that Wayne
Thank
would
you.
like us to see. Thank you.
Yes, thank you so much. I think it gave us a lot of food for thought. And in terms of who owns the data, I think if we, in Africa, and we subscribe to Ubuntu, we all own the data. So there's no individual ownership. Definitely the South African AI digitalization policy, that's something SAMA's going to move on. Thanks for that too. Thanks. Okay, thank you.
Reimagine healthcare with technology that transforms patient care from first contact throughout their healthcare journey. Technology like cloud computing, which can ensure a patient record is securely accessible to authorized providers, enabling better decision-making and patient care. Technology like AI, which powers efficient resource allocation, ensuring facilities have enough people, beds, medication, and other essentials. Enterprise-level connectivity solutions, which seamlessly connect healthcare facilities and practitioners, facilitating in-hospital services like instant blood tests, scans, and teleradiology through the BCX platform, and services like telemedicine for rural communities or medicine dispensing using the BCX pharmacy solution. Warehousing and logistics technology ensures medication and supplies are available when and where they are needed. Hospital and practitioner systems keep patient records up to date, accurate, and available, including patient identification technology, to ensure that misidentification becomes a thing of the past. All of this is possible today. BCX offers healthcare solutions designed to address the industry's most critical needs. Solutions built on technology like cloud computing and high-speed secure internet connectivity, and powered by AI and robotic process automation technologies that free up healthcare practitioners to focus on their patients and not their paperwork. Reimagine healthcare with BCX. Our most important customer is yours.
Thank you. We're still continuing with the AI and the current state of AI and technology in healthcare. Our last speaker for this session will be virtual. And the last speaker will be talking about the responsible AI, an overview of what technology is and what it is not. And our speaker is none other than Tim Morris. Tim Morris is a VP of Commercial for International Markets at Elsevier, specializing in clinical decision support and hospital workflow solutions globally. With 35 years of healthcare experience, Tim began his career in the UK as a charge nurse, focusing on emergency medicine before transitioning to software industry. He holds a BSc degree in health sciences from the Surrey University in the UK. His career spans various roles, including direct patient care in London A&E department, research in management, and product development with the NHI and private healthcare companies. At Elsevier, he has demonstrated extensive expertise in decision support and knowledge management system, particularly in clinical decision support solution. Tim has met with clinicians across all continents, gaining a deep understanding of their needs and driving products innovation to reduce the friction that exists between systems and information. His effort aims to bring back the joy of being a clinician by making the work more efficient and less burdensome. Tim is working on the internationalization of the clinical key AI, a platform that provides clinicians with access to Elsevier trusted content through responsible AI. And ladies and gentlemen, we'll have Tim talking to us virtually. Thank you. Over to you, Tim.
Thank you very much for the introduction, and thank you very much for this wonderful session. I've been really enjoying every part of the discussion, from those early, really exciting developments to also the questions about trust and regulation as well. And I think when we think about our clinicians in today's practice, where they are and the patients in front of them, we can see the vision, but we also realize there's quite a gap between delivery of some of that vision into some of our clinics across the globe. We know that clinicians, and this comes out of many of the research that's been identified or surveys that go out there, see that AI can have a massive impact in the short term in society. And I think when Ruben was presenting, that impact is perhaps underestimated, as he indicated. We know that actually 96% of clinicians believe that it's going to accelerate knowledge discovery, and particularly in drug development, as he mentioned. We also know that there is quite a lot of skepticism as well. There's concerns about critical errors that might occur because of the use of artificial intelligence in practice. Now, Elsevier puts a study out and asks clinicians across the globe what their feelings are. And some of this data is what's presented in front of you. But you also look at the AMA within the United States and see this sentiment between excitement and concern. And actually, I love this graph because if you look at the numbers, more excited than concerned, 30%, more concerned than excited, nearly 30%. So really, there's this mismatch between, can we take this technology into practice? Concerns about whether the technology may actually provide us an answer. And that's one of the fundamental issues that we have as clinicians in today's society. So 1 in 4 clinicians use AI at work today. They're already using this technology in their practice. And this is actually quite exciting in terms of some of the technology they're using. But also it's slightly worrying because we don't necessarily know what those artificial intelligence solutions are. Some of them will be trusted. Some of them will be the developments, as you've seen just now in that example in rural healthcare. But others will be unvetted solutions which don't necessarily have the quality controls that you would expect. And actually, when we talk to respondents in these surveys, they say it's critical that we actually have trust within these. And we actually understand where the clinical evidence is coming from as one of the most important parts of this area. So this is one of the areas and one of the challenges that we were looking at as we were developing solutions around the information requirements. Now, we've already heard and we've discussed previously the challenges within South Africa and across the globe in terms of this changing population, non-communicable diseases now, which are making up a huge challenge across the globe. Patients are presenting with comorbidities at an earlier age. Polypharmacy becomes a major problem in terms of how do we manage these patients. And actually, a clinician, when they're trying to investigate how do I manage the patient in front of them, may spend around 32 minutes of their time trying to determine what is the best treatment option for these patients. If we ask patients themselves to be able to work out what the best treatment is, they won't necessarily know how to understand the evidence that's put in front of them. They won't necessarily know the quality of evidence that has been demonstrated in some of these studies is actually quite low. And where there's non-randomized controlled trials, is it biased? They need to have the understanding and the quality knowledge in terms of those studies. So when we ask clinicians to do this, they often describe they know what they know, but they don't know what they don't know. And that actually is a real challenge in determining the management of a patient. So they have to trust the content that is in front of them. If we're doing a drug-drug interaction, I want to know that the drug I'm going to prescribe for the patient is not going to cause more harm. If this is a patient with polypharmacy, I may have 6 or 7 drugs already on board for this patient. So how do I ensure that I'm not going to cause more problems with this? We then turn to the challenge of unvetted AI. Everybody's using ChatGPT, Gemini, Claude, all of these systems where we're actually using these tools to try and find answers. And this poses an interesting way that we can present information. We love artificial intelligence and Gen AI for being able to sift through massive amounts of information. But in a standard LLM response, we don't know where that information comes from. We don't necessarily know the quality of the study that was used to give that information. And actually, within this response that came from a standard LLM, the information is incorrect in terms of the testing within that situation. So how do we judge that information if we're providing this to a clinician? But even worse, how do we judge this information? We're providing it directly to patients. And that's one of the key challenges that we saw as we were trying to do this. Now, what we tried to do within the development was go to the large language models and say, give me a medical large language model that's going to answer my questions. In doing that, we came across the issues around hallucination of bias within the content that was being presented. So we teamed up with a third-party company that were looking at retrieval augmented generation by putting in the center of this story trusted knowledge, where we've actually put together evidence that has already been validated by peer review. We can actually say that this is the trusted source of information. We turn that into an embedded model in numbers. We can then ask the question in the same way and do a vector embedding search to find the closest pieces of text to the question we're asking. We augment that and put it through the large language models only using snippets of information. And then when we generate the response, we're able to validate the citations and ask the clinician specifically to validate the information they have in front of them. So retrieval augmented generation is the new paradigm in terms of trusted generative AI that people are using. At Elsevier, we were actually very keen to ensure that occurred. So when I look specifically at the management of the ACC guidelines and the management of AF in a male who's 76 with previous stroke, the system is able to go to that trusted source. And in this case, it's the full text from the ACC guidelines and bring back the recommendations specifically around the management of this patient. So generative AI tools that allow you to see where this information comes from, allows you to go to that reference, means that as a clinician now, I can go and validate and actually determine, do I trust that response? What is the level of evidence? Do I trust the ACC in developing guidelines and putting those in front of me? And can I manage the patient in this way? So developing tools within generative AI do mean that we can surface information really rapidly and ensure that we can get through to that question. And then when I move to more complex questions, we're able then to suggest, how do I manage patients within this complex environment with comorbidities? I've also got information specifically about lab tests. How do I take that information and determine if it's actually giving me the right answer? And within this question, you'll notice that we've expanded the words within my abbreviations, because one of the challenges in artificial intelligence is, has the system understood what I'm asking? If I speak to another clinician, I can challenge them and say, but in this situation, this patient is different. How do I determine how to manage that patient? So generative AI tools need to reflect clinical practice, which is evidence-based and available within the environments we work within. So when we look at the use of generative AI within these tools, we wanted to ensure that there was actually an iterative process of validation of the tools. We asked 2,000 questions that might be asked in clinical practice. We gave this to a panel of clinical experts and said to them, we're putting this through our tool. Can you give us your understanding of the quality of those responses that we're getting? Was it understood by the system? Can we test it for bias? Can we test it for hallucination? And can we challenge the system to ensure that we're actually getting a response which is qualified in that way? So having a human in the loop development process is essential when developing tools in medical generative AI tools. And in fact, what we've done to the system is we've actually challenged it with using adult drugs against a pediatric patient. Does the system recognize this drug should not be used in that way? We've looked at bias. How do we ensure that when we talk about the management of heart failure in a female patient, that we actually reflect the specific treatment options that are recommended by the ACC or other guidelines in that way? So it's essential that these tools actually have this process, but also when we look at the comprehension, whether it gives us a potential harm response. Now, we know in clinical practice that whenever you do something for a patient, there is that potential for harm. Now, if we're looking to, in the future to actually place this in front of patients, of course, systems are going to have to be very regulated to ensure that we're not only able to give them an accurate answer, but also we're able to ensure that the information is coming from a credible source that is evidence-based. That is complex when you look at the volume of information being generated in today's journals. This was made worse when we looked at COVID and the volume of information that was generated during COVID and the misinformation that was put out there. How does society or even our clinicians need to be able to sift through information to ensure it's real? So developing systems, it's essential that we not only have a human in the loop in the design process, in the continuing validation of those processes, we also need to ensure that we have the humans involved in the assessment and follow-up of those. So in our design, what we did was we asked our clinicians what was the appropriate content set to use. They used the 2,000 questions, they identified gaps in the knowledge, and they said, we're missing specialty knowledge. In that case, we added clinics series to add specialty knowledge. We then tested this in the community with our clinicians. They said we needed more pediatric, we needed more neonatal information. So we went back and we identified specific strong texts in terms of neonatal and pediatric medicine and added that to the content set as well. They said we need guidelines. We need to be able to determine what are the guidelines for the management of patients in this way. We then added in the ACC, we're now looking to add in potentially NICE guidelines or other bodies like the ESMO guidelines to put those in directly into the system in full text. All of this system is copyright cleared for use. And actually, we haven't spoken much around the ethics of copyright clearance and the use of content in large language models. A lot of systems scrape information from the internet, which is actually taking away people's intellectual property. We need to look at the way intellectual property is used in the development of systems as well. And then ultimately, we need feedback. We need our clinicians feeding back to us to say, was this helpful? Was it inaccurate, or was there something that was insufficient in that way? And that human feedback is really important. And this goes directly to our clinical panel to say, why did that clinician find this was inaccurate? Was it a lack of specialty knowledge? Was there a specific piece of text that was missing that they felt would be improved in the system? By having a human review process into the human responses we get back, that means we can validate that against the needs of the clinicians that we're serving. A lot of AI systems and generative AI systems are using electronic methods of trying to validate the responses from their end users. By having a human in the loop process, we're able to look at the quality of the evidence that's going into our system and improve it in that way as well. Clinician confidence and transparency is essential. So when we were developing this, we were asking them, what did they want to see specifically in the responses that were going to give them that level of trust to believe the answers they have in front of them? I know what I know, but I don't know what I don't know. I want to be able to guide that information, ensure I understand it. So taking my response in natural language and in local language potentially as well, giving me a response which is summarized that I can actually see those, and it's concise, which means I'm not reading thousands of pieces of information, providing me a summary of that text that it's taken from the trusted source. And this is the reason we have lower bias risk, because we're using very small little pieces of information rather than volumes of data where bias is potentially in them, and also hallucination is potentially in them as well. Being able to go to those full text references, as one of the other speakers said, being able to actually review those, but also having a conversation with the system and having follow-up questions is really essential, as we would in practice when we speak to a trusted clinician and get their responses as well and have the conversation with them. So when you're looking at potentially the information and making sure that you're actually being able to pull back this content and being able to see the information in that way, but also making sure that where it is relevant for the international markets or rural settings, being able to find information that is relevant to the populations we serve as well. This reduces the bias within systems as well. So we're able to go down to the rural settings where we support our patients. But you have to trust systems. And it's essential that when you look at systems that you're implementing, as has been mentioned, we understand the regulation in terms of medical device. Determining a system like this is a search tool. It is not a medical device. We have a human in the loop. That is the clinician who's evaluating the information that's being put back in front of them. We look at the rules around the AI and ensuring that actually where there's sovereignty of data, that we're not incorrectly using that data, that we maintain the privacy of our users in secure environments, and we give that level of trust to the end user is essential at the end of the day. So that is where we are today, implementing trusted generative AI systems at the point of care. We are quite a long way, we believe, from having patients being able to sift through these vast volumes of information in clinical knowledge. But we do believe that actually clinicians now have tools which are going to reduce the volume and noise within the research and allow them to hone in on the care that they need to provide for their patients to help them make their decisions. So thank you very much for your attention. It's been a great opportunity to speak to you, and I will be continuing to listen in and enjoy the rest of the sessions as well. Thank you.
Thank you, Tim. We will take questions for you. Are there any questions? Go ahead.
Thank you. Hi, Tim. I'm not sure if you'll be able to see me, but my name is Vuyani, and I'm with a company in South Africa called Curo Medical. Tim, notwithstanding the utility of kind of reference technologies, we know that doctors and even in the most remote places do use them. Guidance, for example, is one such platform that most of us turn to when we're stuck and looking for references. The challenge with platforms such as yours are that they are prohibitively expensive, even though they work, and very keen to understand from your side. But given the various disparities across healthcare systems, how do you ensure affordability of such solutions as a way of promoting access to healthcare? Thanks.
Thank you very much. And I agree with you that a lot of the systems that are developed in the Northern Hemisphere do tend to have a high price tag. At Elsevier, we are actually trying to determine how we deliver cost-effective care in rural communities at lower cost to make this an affordable tool for clinicians across the globe. Now, we make a lot of our research available through Research for Life at very or no cost in many of the countries where we are. But when it comes to generative AI, one of the challenges that you have with these systems is the cost of the compute power that and goes into them. And this is one of the factors in terms of reducing price across the globe. We do look at how much does it cost to run these massive systems, and how do we ensure that we spread that cost equitably across the globe. And I am part of a team of people who are looking at that pricing structure, specifically now in our markets, to ensure that we actually do deliver prices that are going to be working within South Africa, but also other areas with very low levels of funding for these tools to make them available to clinicians. And we look forward to actually working with communities to actually price them in a way that is cost effective. We believe that actually it's safer to use tools that are vetted, that are tested in these environments and give you this trusted environment than using tools which are untrusted and then potentially cause potential risks. So I look forward to actually having this discussion further with you in terms of price and also delivery. And we are looking to ensure that this is cost effective.
Thank you, Tim. Thank you once more for the clear and concise way that you've presented to us. I think it's been a fruitful morning. It's been a very robust morning. We've been discussing. And do you have a question online? Yes. Okay.
So Akon Nazim is saying, hi, in SA is the POPI Act not supposed to regulate patient data and doctor-patient confidentiality?
I can talk from the perspective of where we are within Elsevier. Sorry, my camera has decided to drop on me. The way that we treat data is that we actually ask the end user not to put any patient-specific data into the system. We use small amounts of demographic information, i.e. age and gender, to support the contextualization of the response, but we don't collect patient identifiable data, and that's a really important part of the way that we capture information. We secure the information responses directly into an ISO 27001 database anyway, but we never use the responses or the content provided by the end user in the question development or in the AI development. And that's really important to us as well. Responsible AI is not using the end user's information to further develop the artificial intelligence. We use a human in the loop process to evaluate answers and come back and actually give us advice on that. I think patient privacy is essential. We need to trust what companies like ourselves and others are doing with patient data. And I'm sure that's the same for other providers who are speaking on platforms today. It is absolutely fundamental to the way we believe use of data.
Thanks a lot, Tim. I'm sure tomorrow we'll touch on that as well. We will discuss it further. But thanks a lot. Thank you very much. It's 2:00. I think it's time for us to go for lunch. We can be back at 2:20. We'll have a 20-minute lunch so that we can come back and discuss. These are quite interesting topics that we cannot miss. Thank you.
Ach, that's so small. Fine for her. She's having an awesome sleep. It's just both of you aren't coming tomorrow. Half a day tomorrow. So I would have only come today, but I think based on the fact that it's just half a day, trying to move my morning things. Manga was going to come. He initially said he could make today, but not
Today,
Friday.
I don't think I'll
But then he didn't register because, I mean, we thought there would be like higher attendance. Like, Shamanga decided he's going to exclude himself and have you guys.
at the University of the Western Cape since 2023. In his role, he promotes and supports the use of advanced information technologies to enable better, faster, and higher impact research at the University of the Western Cape. Professor Nyirenda has got extensive international experience and various accolades. So I'm not going to read the whole of his bio. I'm going to just ask you to please put your hands together and welcome him to the stage. Professor Nyirenda.
Okay, so thank you for inviting me to this event. I am not a medical person, so when I make mistakes, bear with me. I am from the University of the Western Cape. I have been working there for the past 6 years. I was in the Department of Computer Engineering, computer science rather. My background is electrical engineering, but with time, I have moved into a space between computer engineering and computer science. So from last year, I started serving in this role. So when I came to UWC, I forgot some stuff in Namibia where I was working. So a friend from Nigeria who was to send them to me traveled to Germany for something that he was attending together with a colleague from the Faculty of Dentistry in UWC. So he just passed the stuff to the colleague from UWC, whom I did not know at that time. So when she brought the stuff to me, she told me that there is a student who is interested in MATLAB, who is a dentistry student. And that student was working on something that I had to learn with time. They call it cephalometric landmark detection. So she was trying to use AI and she wanted MATLAB. And that's how I started getting involved in medical issues. So from there, a number of things have happened. So, but in this case, I will not go into what I do because I was given a specific topic. So I'm talking about AI and cybersecurity. Okay. It went faster. Okay, so I'll talk about the definitions of AI, cybersecurity. I'll be skipping some of the things because I think they have already been touched on, and how AI is used to enhance healthcare operations, challenges and ethical issues, and then cybersecurity challenges. I put it separately because it's part of the title, and some techniques for securing AI and data in healthcare, and also how to enhance AI and cybersecurity in healthcare in South Africa. So definitions. AI has many definitions, but I like this one, that it is basically developing methods to solve problems that are usually associated with human intelligence. And along with that, I found this kind of Venn diagram, if I may put it like that, interesting. Because today, many people have been awakened to AI because of ChatGPT. And many people think that when you talk of AI, then it's ChatGPT. But it is actually, yeah. So AI has been around for talks about many things that are AI, from natural language processing, automatic programming, intelligent robots, visual perception, and those dots are telling us there is many more. And inside that, we see that there is machine learning on for a long time. So and logistics, support vector machine, and many others. And then inside there is what we call neural networks. So much of what we see today as AI is coming from the neural network, an artificial neural network per se, which I think people in this room are very familiar with. So that neural network has gone on to what we call deep learning. And deep learning is basically many layers of neurons, while an artificial neural network by itself is one layer, one hidden layer, so they call it. But when you say deep learning, it's like you put in many layers. That's why it becomes deep. And within that, you can see inside there, that's where you see deep learning, generative AI inside there. So you have things like GPT, variation autoencoder, generative adversarial neural networks inside there. So the generative AI is just that thing inside there. So there is a lot more in AI. So basically, people have called the rest traditional AI versus generative AI, or discriminative AI versus generative AI. So this is the neuron that we all know. I think even me, I remember this from biology. And when I studied artificial intelligence, this is the thing that they explained to us, the dendrites, the axon, the outputs, that for each neuron, the inputs will come in on the left side, and then the nucleus there, that's where the processing takes place. And the axon, then the outputs will come out through this, I think it's synapses on the other side. So for us in computer science, this is what we know. From here, the first thing that they did, they modeled this structure to create that artificial neuron, which you see on the other side there. So it has inputs, it has some weights in between, and it has the node there, which is like an aggregation point, and then an output. And you have those neurons in layers like that. And then the data comes in and the data will come out. So it's a linear function because the weights multiply the inputs and the Z there aggregates everything. So this is a cartoon image of how the brain works. So the whole of AI is basically a cartoon, like a smallest version of what happens here. So there is still much more that can be done because you are from the head side, you know the things that happen in the nucleus, you know the things that happen in the axon. The only thing that happens there is the summation and the nonlinear function. So now, cybersecurity. This one is the practice of protecting systems, software, and data against unauthorized access linked to things like hacking, malware, ransomware. In that diagram there, which I found to be interesting, lists the 8 key cybersecurity threats that are common today. And I will not have time to go through each one of them, but I hope that these slides will be shared with everybody. You can just click on the link that I put there. You will have an explanation for each one of them. So, for instance, ransomware is where somebody just comes and encrypts your data on your system and then asks you for money to decrypt it. And people are making a lot of money, especially now with this, what do we call it? Cyber blockchain stuff. Bitcoin, because they ask you to pay in Bitcoin so that you don't even know who you are paying. So, yeah. So, enhancing AI in healthcare, I think I will skip most of these slides because people have touched on them already in so many ways. But I can just share one piece of app that is being developed at UWC. I'm not involved, but some colleagues from the School of Pharmacy have developed this thing they call Mzansi app. It's a chat GPT based tool, basically to allow translation of medicine issues for people that are not very good at English. So there is all South African languages, I think the official ones there. So it can allow you to translate things from English to whatever language. So there is a link there. You can try it, and they would be good. They would be welcoming your feedback. So yeah, so that is like so many other applications generally for generative, for AI in general in healthcare, different ones. I think many of them have been touched on here already. And continuing from there is challenges and ethical issues. So somebody said, all of these AI systems we see, none of them is real AI. And this guy's name is Josh Tannenbaugh. And I think he's right, because I showed you the image at the beginning that is just a cartoon representation of what happens here. So because of that, all what we are seeing and we are saying, wow, is not really it. Maybe if we can do a bit more to model what happens in the neuron beyond what we have done so far, maybe there would be more functionalities. So the first challenge that I know is that these tools, they generate a lot of false information, especially these ChatGPT, Cloud, Gemini. They have the capacity to generate false information. If you have used them regularly, I think on professional staff, sometimes you will have seen that this thing that it is saying is not correct. But they put a disclaimer there that I'm just an AI model. So the things that I tell you, they might not be true. So it's up to us to actually make sure that what came out is something that maybe we can believe. So we can check it with other sources. So garbage in, garbage out. If you trend it on wrong information, it will give wrong information. And the other thing is, when you generate data using these tools and you put online, and then those data is used again to train this model, it's like you have this loop. So if what it produced was wrong, then it will keep on being used in producing wrong information. So basically, you go about this by using diverse representative data sets to avoid perpetuating these kind of biases. That is to say, much of the data that is used in these tools is from the global north. And most of the things that we have here are not represented in the training. So this is one big problem. And then the other thing that I can say is that generally all these AI models, they lack explainability and transparency. They are like black box tools, which are difficult for people to understand how they work. I think one guy is an expert who developed some of these tools. He himself is shocked as to how these things produce their results. So there is a field that they call explainable AI, which is trying to increase transparency, but it's still gonna take some time. So from here, about cybersecurity challenges, I think I would maybe dwell more on this because I feel like maybe there are things that have not been touched on. I will go faster. So in here, I will maybe mention 9 cybersecurity challenges of AI in healthcare. The first one has been touched on, I think, by many speakers, is the issue of data privacy and confidentiality, which are big problems in health systems. So in healthcare, you process large amounts of personal health information, and this can be a target of data breaches. So patient data can be exposed to attacks as you work on the data. So this is an ongoing problem, a big one. Then this data that we use in healthcare, there are many ways in which you have to read it in. One of the ways is through medical Internet of Things devices. So they will read the data on a person, and then it has to be transmitted wirelessly or otherwise to some place where it is kept. Now, these devices are manufactured by different vendors. And in some cases, the security protocols are weak. And that is the point where data can be compromised, either at the source or along the way. So that is a problem. Then there is what we call adversarial machine learning attacks. So when you are training the model on this data, there is a potential that somebody can inject malicious data in the training, such that the data that is actually being used for training is not the real one, because it's huge amounts of data. So when somebody injects that kind of data, this model will have been trained in a wrong way. So when you use it for maybe diagnosis, it will give wrong results, misdiagnosis, and all that. And it can lead to legal consequences at times. So then regulatory compliance challenges. In the US, there is the HIPAA. In the Europe, I think is GDPR. Of course, in South Africa, we have the POPIA. So there is a need to comply with all these regulatory frameworks, especially because AI is a global thing. So if you are developing a tool, you need to make sure that you comply to all these, because many times it's not a tool that you can use only in one country. So to balance compliance and innovation is a problem. Algorithm bias and security vulnerabilities, I think I touched on that one already. Then the fragmented security ecosystem. Some places, maybe they might use outdated tools. Maybe in the tool that you yourself you created, you made sure that the security is top notch, but someone in the pipeline is not doing their job. And the one weak point opens up the door to attacks that will affect even your side, which is up to date. And then limited cybersecurity expertise. So there are not many professionals that are experts in this. And even if they are experts, there is a need to continuously upgrade oneself because things keep on changing. And to keep pace with what happens is a big, big problem. Then cross-system data transmission risks. I think I touched on that one already, that when you're moving from one system to another, there might be loopholes there. And then the rapid AI advancements. So here it's tricky. The development in AI is happening very, very fast, while the developments in cybersecurity, in general, they are a bit slow. So cybersecurity for the internet, for data, has been there for a while. It's a bit slow, but AI is faster. So how do you make the two run together? So, so the techniques that I know that are being used, of course, historically, data encryption is what we know, that the data is encrypted, put in a form that is unreadable to others, only readable to you when you do decryption. So EHR systems like Epic and Cerner, they use these tools. And then the other one is access control and authentication. So this is where you have maybe things like multi-factor, kind of like access control systems where you use a password or a fingerprint to access a service, or role-based access control where only people that are in a certain role can access. Because with these two systems, a normal user for a system can open up the door to attackers without knowing. So you only let those people that are in the know to come on board. So Mayo Clinic uses MFA for this purpose. And audit trails and monitoring. Because as I mentioned that AI tools, generative AI can go through hallucination and all that kind of stuff. So you have to write other pieces of code to kind of like do audit trails and check if what was produced was correct. And Mount Sinai Hospital uses these techniques to monitor AI-driven patient care decisions in order to align with medical standards. Then differential privacy, this one is interesting, is that they add noise. So noise is like you corrupt the data intentionally to hide it from malicious users. But you know yourself that if you remove the noise in this way so that you get access to the real data. So this helps also against to protect the data and to make sure that it is private. So Google and Apple, their apps are already using differential privacy in training. Then federated learning, very interesting, came up in recent years. So this one is whereby originally they would collect data from all over the place to a central place to train a model. Now, the models are trained in their local places, so the data doesn't have to be transmitted. So you train, you send the aggregated model to the center without sending the data to the central place. So the Ethereum project is actually being used for this purpose. I think there is a link on the internet. And then adversarial AI systems. So this one is like you detect and mitigate the kind of manipulations that would happen. So once you detect, then you know how to evade those kind of attacks. And IBM has an AI adversarial robustness toolbox that is available on GitHub as open source. Then the techniques that you can use to enhance AI and cybersecurity in South Africa. So I'll just share my views here. I have three items there, but there are some sub-bullets. So the first one is on addressing skills gap in healthcare, AI, and cybersecurity. I feel like our curriculum it takes time to change it, and we're lagging behind. So universities could build like some cutting edge educational tools to build a pipeline of skilled researchers. It will be good. And I feel like between the medical school and computer science and data science, there is a very thin line nowadays. So I believe that students in the medical school are supposed to be taught how AI works, to focus on medical applications, diagnostics, and the like, and some training on AI tools, and to look at this as an interdisciplinary kind of like field, because there are some medical doctors that are actually maybe even better than computer scientists or data scientists at this kind of stuff. So I think we need to break the walls and make things fluid so that people should be able to move into areas that they are passionate about. And then cybersecurity, very important to teach it. There is very little content on cybersecurity in South Africa, and it is something that we need to push. Then also when a security problem has happened, how do we respond to it? These are things that I think should be taught, that when there is a security breach, how do we go about it? How do we do damage control and the like? And continuous professional development initiatives, trainings, I think must be taking place regularly. And incentives for people that are engaging in this kind of work, because there are other people who are trying to attract our youngsters to do AI in other fields. For instance, in South Africa, astronomy is big. And especially in the Western Cape there, astronomy is very big, and they have got massive funding. So students would want to go there and not come to do healthcare stuff and look at Pluto and study at how Pluto looks like, where people are dying here. So I believe that healthcare is something we need to put more money in than Pluto, of course, with due respect to my friends in astronomy. But them too, they get sick, so they also need these tools. So then this other thing that I want to say is that software and hardware tools, that are developed, there is a need for the developers, especially if it's public software, public hardware, like someone has done something for the government, to make sure that these things are open source. They should provide all the detailed guidelines on how these things were developed so that those ones who want to build on that to improve should find it easy. There was a case a few months ago where I was involved in a project, and this person was working on it for 10 years, and he just kept the source code to himself. He was just sharing the user code. And when they needed to upgrade it, he didn't want to release the source code, because you need that to improve. I refused to get it on board because it means that I'll have to develop everything from scratch. But these are the things that we need. So when we talk about data, we must also be talking about open source software. For students that come from historically disadvantaged backgrounds, it's very easy when you show them the open source and for them to develop from there. So talking about that, historically disadvantaged backgrounds, I think we need to have inclusive and equitable AI, especially in South Africa. Looking at the disparities that we have and the gap between those who have and those who do not have. If we just leave it to be like a commercial thing, the gap will grow bigger and bigger. But I think through an organization like this one, and us in the academia, we should be able to push and lobby for resources to be targeted to those people that are in those places where they are historically disadvantaged. So things like AI powered translational services like Mzansi made that I shared, bias mitigation and medical diagnosis tools, they are things that we need to work on. And decolonization of the curriculum in science, I believe in science, I feel like decolonization of the curriculum is actually to give those universities more programming abilities, high performance computing facilities, research data management facilities. Because if you pick a university like Walter Sisulu University, you see what they have and you compare with UCT, it's like a whole world of difference. But I have worked with students that come from those backgrounds that are super smart, but because they don't have access, then it limits them. But if there is openings like that, some students might be in Zululand, Walter Sisulu, Venda, they might end up remaining there and developing really nice entrepreneurial ventures in those places. Then Internet of Things, investment in Internet of Things. In rural places, as somebody presented here, there are very few doctors. But if health data is taken from there and taken to a central place where it can be analyzed by AI or by individuals, it will really help. And then local data sets. In South Africa, it's extremely difficult to get data. Many times with my students, we have resorted to using data from the US because it's available. So, but we work on stuff because as we want the students to finish their master's, their PhD, and we want them to finish in record time. But the results that we get are of value and benefit to them because we publish online. So, but if we can work together to make these data sets available, it will really help us. And these data sets will also help us to fine tune these large language models because they come with a bias. So if we use local data to fine tune them, then they will be of great value to us here. And to put up these data sets, it's, I think, my duty and your duty. Okay, and finally, regulatory frameworks. I think to deal with security issues, there is need to adhere to these things like POPI Act, constitutional privacy rights, and have clear data governance guidelines and incident response mechanisms. Because AI, as I said, as it is just a cartoon thing of image of what happens in the brain. So much as it looks exciting, there is still so many things that have to be done. If you leave it like that by itself, it can lead to all sorts of problems. So these are my references. Thank you very much.
Thank you, Prof. That was quite a refreshing perspective from an engineer. So thank you very much. Are there any questions, ladies and gentlemen? Yes, one question.
Hi, thank you, Prof. What are your thoughts of using AI to prevent cybersecurity and detect like intruders? Because I've been trying to get sold on that idea where we use AI to sort of catch up with the cybersecurity products that we have.
I think it is one area of research that is also growing in a big way. But in my presentation, I did not touch on it. I just focused on cybersecurity in the healthcare context. I thought if I would include that, it would become too long. But there are a number of techniques that are being used using AI to detect security breaches, either dynamically or using data that has been collected over time. So yeah, it's happening, and it's happening in a big way already. Yeah.
Thank you. Are there any other questions from the online platform, CEO?
Nozipo Sangweni is asking, I hope this is not delayed, that the processing power energy required for these LLMs is massive. How is this being mitigated in the resource-constrained African context?
That's a good question. I think in my presentation, I did not touch on it in more detail. It's a big problem, to say the truth. But the only maybe nice thing is that at the moment, most of the LLM stuff that happens in many countries in Africa is that we are just using these already trained model, like maybe ChatGPT, Gemini, Cloud, just feed it our information, then it gives us answers. But what I believe that will have to happen, actually, to make these large language models to be of greater benefit to our context and our data, it means we have to be fine-tuning them based on our data. And this aspect, I haven't seen it happening a lot. It might be happening, but not a lot. But when we go that way, it means that we'll need massive computation. And one company that produces an LLM that is open source that we can easily start tuning is Meta, Facebook. Their LLM is called Llama. I think Llama. It's open source. It's open to fine tuning. And for institutions to kind of like have maybe the high performance computing that they can use to fine tune those models, one institution, I think it will be a problem because the costs are so massive. But what I would suggest that should be the way to go is for institutions to come together and pull together resources. And then for that facility to be accessible to all those people that have put in resources. And we have a model that is working really well, as I mentioned, for astronomy data at UCT, UWC, UP, and another university. They came up together and came up with a unit, and they put together money where they have this Ilifu cloud facility. So for health, because as I said, I find health to be super important, I feel like I think we need also to be pushing in that direction. And finally, when we pull together like that, if we are coming up with a proposal that we want to submit to a funding institution, it becomes easier to get money when we come together like that. So I think that should be the direction that we should be taking. Thank you.
Thank you very much, Prof. There is a gift for you as a token of thanks for your brilliant presentation.
Yes, and this is what opposite. So you've spoken very well. Thank you very much. We really appreciate you. And we hope to work with your university going forward.
Definitely.
Yes, thank you very much.
Thank you very much. We continue in this session entitled Digitalization of Healthcare and AI. And our next speaker is going to be talking about the application of data science, artificial intelligence, and digital solutions in personalized care delivery. And the speaker is Mr. Darren Swaden, who is the head of the head of the health professional unit at Discovery Health. He is a physiotherapist by profession, and currently, as he heads up the unit at Discovery, he's busy with engagements with medical professionals. In addition to the Discovery Health value-based care, professional billing intelligence, health quality, and auditing risk management units. So welcome. Thank you.
Thank you so much, and congratulations to SAMA for being leaders in bringing this type of information and knowledge to our environment. I trust our click is going to work, gents. So we'll see how that goes. I have to start though with a full disclosure that I'm a techie. I love tech. For many, many years, I've tracked it and I've been very excited by it. I'm that guy that's on the internet watching the new trends. But as we get deep into the trends, and what you've seen, I think, a lot of today is that there's so many exciting things out there. There's so many things that you can do right now, today. When I talk to doctors, and sadly, I haven't been a physiotherapist for a very long time. Unfortunately, post my business training, I went into commerce and I intended to be there for a few months, and it sort of stayed. But as I talk to doctors then every day in this role, what the doctors say is that all this is out there, but there's so much, it's overwhelming. There's almost too much of it. The other thing is that they always say to us, well, what do I do? How do I press the buttons in the right order to actually bring this all to life? And a lot of what I'm hopefully going to talk about today is about that. What's available right here today? How do you actually bring this into practice today so that we can actually use some of this brilliance that exists? So to the previous speaker, yes, we've got so many brilliant people who are also excited about this. They just need a little bit of direction. And as I say, a meeting like this organized by SAMA starts to provide some of that. So let's kick off. Hopefully, if I shoot this off, there we go. Now I've got to take it backwards. Right, so what we'll hopefully talk about now is how to leverage this functionality. How do you choose digital tools? How do you provide access to patients, and how do you encourage patients to actually use these tools and incorporate them into their daily activities? How do we trigger communication? How do we use the information to the best impact for the patients? And how do we review and adjust patient actions? Okay, because ultimately that's what you want to do, right? Especially in an environment with this massive burden of disease. You need to get the patients to engage in different ways in order to change their trajectory and health behavior. So we'll talk a little bit about the value of the GP, but healthcare professionals more broadly in terms of what are the tools available to them, and how do you strengthen practice, both specialist and GP, to achieve better outcomes using all these tools that are available. Many of them have been shown today, and no doubt you're quite excited about that. So let's move forward on that basis. Okay, so the initial piece about this is, how do you get people to do something different? Well, firstly, you've got to know who the people are. And one of the problems that doctors have is knowing who their broader patient base is. You know, who are the patients that are absolutely affiliated to my practice? How do you put the healthcare professional back in the center of the healthcare system with all the stuff happening around us? So one of the initiatives that we've been driving hard, and some of our competitor schemes did as well, but what we've been driving hard at Discovery Health is this idea of a primary care provider. The patient must hook themselves to a medical practice. We think it's absolutely crucial. And the question is, how do you do that? Okay. From time to time, I've engaged with doctors and we've said to them, who's your population? And certainly doctors in the private sector have said, I'm not 100% sure, they send us the age analysis of the patients that they've treated from their claim system. That's not ideal. We want a list of patients that ultimately will feed a full medical record. And to do that, we need this affiliation, and we try and encourage that. How do you do that? In the discovery, well, literally, there's a 3-step process, okay? And interestingly, it is doctors who are leading the charge in actually building up this database for their own practices. Our most well-used channel for getting that interaction is our Health ID channel. And it's the Health ID channel that's mostly used by doctors where we are achieving this. So there are doctors who are starting to use these tools more frequently to achieve this very important outcome. So it's literally a 3-step process. And I've shown you here that the doctor literally sends a request, the patient gets a one-time PIN, and that patient is then selected, that doctor, to say, this is my primary healthcare provider. So the doctor can now build out their database. We get permission and consent to be able to share certain pieces of information between that patient and that doctor. And what we start to do is help coordinate the private healthcare sector. As we move forward then, just delay a little bit, I've just given some examples of how you can easily change if you need to. I mean, the world changes. So using digital systems, you can move and change and align patients using this. So it's a simple action, but the power of that database is profound. It's almost the bedrock of understanding and building out some of the other tools that I'll highlight now. Let's move to the next slide. So another important technology, and it's something, and I've been privileged to stand on platforms with Vianney and our colleagues and friends from Cura Health. Discovery also has a care at home and hospital at home business. But one of the very, very important functionalities in order to make our healthcare system sustainable, and this is true for public, private, any setting of care, is that we've got to make it more cost efficient. What is more cost efficient, with equal, in many instances, better care outcomes, is this care at home environment. And what underpins it is technology. Okay? Our ability to actually have sight of what's going on with patients when they're actually not in direct line of sight of patients. So it's super exciting. If you think about it, most of the patients that doctors see today are actually at home. The vast majority of care that you actually provide is home care. You know, not every patient you see, you admit and care for them in the hospital setting. So basically what this does is it expands your reach to another set of patients that can actually be cared for at home. And believe me, patients prefer, Yanni will tell you, the home care setting frequently over the hospital setting, because hospitals are very comfortable places for medical professionals because that's where you hang out. It's a very foreign place often for patients. So not a place where they're super comfortable. So hospital at home works, and it's a very easy process to get. But this is a view of what it might look like in terms of notification of what's happening. One of the speakers earlier spoke about symptom checkers and doing this digitally. There's a lot you can do virtually under symptom checkers, various measurements, education is quite possible because the patients are engaging also on these digital platforms. And crucially, this idea of a live view of what's happening to this patient remotely. And what's built into those live views is artificial intelligence. The ability to understand often what's happening to that patient before the patient even reports a symptom. And that's not that unusual anymore. We learned a lot around that during the COVID period, where you know that through the blood tests, you could see the inflammatory markers would move before the patients actually started to report symptoms of deterioration as a result of COVID. Now we realize and know that functionality or that understanding, that those data points actually do shift for many, many diseases. And what you can see that happen is in this type of care and live stream of patient outcomes. And what that means is we can intervene earlier. as medical professionals in helping patients get better before they even report their clinical symptoms. So it's quite an exciting environment. I mean, this is basically, I know we're short of time, so I won't go into this in detail, but how all these pieces actually hook together using smartphones and that's less important for the doctor. When I drive my car, I don't really understand what happens in that engine. It's I know the steering wheel, the brake, and the accelerator. Okay, and ultimately on either side of those processes, I think the important components for the medical professional is to apply your clinical knowledge to interpreting the data that you're receiving. Obviously, you've got to trust the sources, and a lot of what happened today spoke about data security and how that all works. But in terms of actually empowering the doctors to use these tools, I think our world has to really start on what it feels like on the doctor, where they are able to evaluate the outputs of these tools, as you do today, be it an ECG or a data monitor in an RCU or a pathology test that you get from a pathology lab or a radiological investigation. This is just another source of information to manage patients. It's available. We've just got to do it more often. And the more we do it, the more value we can unlock, be it through Curo, be it through the Discovery, or now many other vendors who are offering a care at home environment. Let's move to the next slide. So once we know these things, where are we going to pitch these particular tools? So we know increasingly from data that you can actually start to categorize patients and understand what it is that we need to do and what we could do to help them. But not all patients are created equal. There's people with various elements and in the life cycles and various elements of disease. So we'd have well patients, those with emerging risk, perhaps chronic disease, and complex patients. And what we're able to do with all these data sets is to create bespoke plans for each individual patient, very personalized, but also certainly for care categories. In which we can actually direct care and patients in different ways. So some of what I'll speak about also will talk to those points. So we know, for example, if we had to go into that chronic category, that it is all becoming more and more complicated. That when many of you started your healthcare journey, people had one chronic illness, and then there were two chronic illnesses, and then there were three chronic illnesses. And now often there's four. And if you think about the size of the problem, and we've got some numbers here from the Discovery Health Medical Scheme database, mental health, 17.2 billion rand. And, diabetes, 10 billion rand, 144 million, 144,000 patients. Really, hundreds of thousands of people spending millions to billions of rand. And making small adjustments here really does make a significant difference to the healthcare system. So if we're going to charge at something, and chronics is not the only place to work at, there's many, many of these categories, but there are areas of focus. We don't have to be too hard on ourselves. There's a lot that we've done. There's a lot, and I'll just keep going. Next slide. I don't know why that's crashing. I'll give you a memory stick, chaps, and you can just, is it working? Sorry, everybody. Okay, while the chaps get this up and running, essentially, the next slide will really show us that there are several programs and that we are already involved in. Chronic programs, acute management, member management programs, where we are already using data to focus care, energy, and resources on specific databases. Okay, apologies everybody. So we've got that up. I think we've solved the tech problem. So what we'll show quickly, that we will be able to show how what we are doing in the various disease management programs really is making a good dent. But there is so much more that we can do with the various tech scenarios. This is reflecting. Can you bring it up, chaps? Good stuff. Okay, excellent. So the problem though that we face with patients is that's what healthcare looks like today. It's just a very, very, very complicated space. So what we need to do is try to help patients to navigate this complex web, about giving them a pathway through the healthcare system to be able to understand what is their action and what to do next. This is what I was talking about. We've got various programs. We can actually target complex members, various types of conditions, be it high impact, non-communicable diseases, specific disease programs like HIV or end-stage renal failure. There's a number of programs that really help, but we've got to get the right patient to the right doctor at the right time to the best effect in the most cost-efficient mechanism possible. So the question is, how do we do that? One way is through the digital chassis, and this is our Health ID program. Okay, and with Health ID, what we're able to do is start to help people wayfind through the system. These are free programs and offers that we offer to the medical professions, and there's a whole range of different applications that are available to doctors to use these tools to be able to achieve what I'm suggesting in terms of the program. We spoke a little bit about it. I'm going to move quickly because we've lost a bit of time. I'm going to go one back though. So as we start to look at these tools that are available, there's three categories that when we talk to doctors that we start to range. There's a number of early functionality tools that are available. They've been available quite some time. A lot of people spoke today about medical records and so on. We've had one for quite some time on the health, and we encourage doctors to use it. So that's already almost old news. It's available. It makes a massive difference. Care coordination, various issues, avoiding duplication of services like pathology and radiology. It's available today. It's free with patient consent in medical grade secure environments. Those are all very important. There's then established functionality, things like digital booking. Okay, anybody who's using somebody to answer a telephone at a practice today is wasting a resource. That person can be used to much greater effect because people now, especially the newer generation, and even the older, my late grandmother was 90, she used to use these tools. So you can book online, it takes 30 seconds to book online. It will take a few minutes using a telephone to book with a practice. So those are available. We'll talk a bit more about that. But then there's all this new functionality around generative AI, and a lot's been said today in Ruben's presentation, the presentations that preceded mine, around artificial intelligence. But how do you use it? And here's just a quick demonstration of what you could do, and I'm going to set it off. So what we did here is we took a handwritten note. Okay, we just took basically one of my colleagues, I suppose that's quite good doctor handwriting. It was one of my doctor colleagues at work. Okay, but even bad handwriting works. And what we did is we took the note and we popped it into stock standard Microsoft Copilot. Like really nothing special. Most of you, if you've got a Microsoft subscription, you've got to pay a little bit more. You can have this afternoon if you wanted it. And we've popped it in there and we said, please take this image and create it into, create something, create it into a digital environment. And you'll start to see in there, off it goes. As it starts to now translate those written words, you'll see that in top left hand, you see it's protected, that green bar. This is within a virtual private network. So it's safe, it's secure, it will be in your own space. So nobody else can hack into this, it's yours. Okay, so you're not sharing information, you're just using the tool. And what it's done there is it's taken this information and it's taken that note, made it a digital note. So we've spoken a lot today about how this all works in the background, lots of exciting stuff, but this is how you could use it today. Very simple examination. Whenever I go into a room, there's already a number of doctors who are already doing this and they already say, but I've been doing this for 2 years. And then there's some doctors who don't even know it exists. So there's this wide group, and it's important that doctors know. What we then did is we said, we'll take that digital information and just write a referral note to a hospital. And it just did that. Okay. That took 1 minute and 40 seconds. I've timed it exactly. If you're already digital in your practice, that would have taken less than a minute. Okay, so one of the doctors in one of these sessions said, how do I make time? Well, that's how you make time. Okay, it's about productivity and using the tools. Okay, and what I think we've been seeing today is very, very sophisticated tools about how to do, but this is how you could do something quite simply in your practice today that can change your world tomorrow. And I'm saying not tomorrow, 10 years time, I'm saying tomorrow. Okay, quite simple stuff. Okay, simple in terms of application. Obviously, there's a huge amount of science behind that. I'm going to move forward. We've spoken a little bit hospital at home. I'm going to gloss over that. Here's another example of what we can do that's quite exciting. This is virtual physical therapy. Okay, and what we're doing is we've taken all those data points and what the computer, and this is just on a stand itself, and this is available today. Okay, you can measure if you can set up a range if you're an orthopedic surgeon or a therapist. And the issue with this is the problem with patients is compliance. Often patients, when they leave, they get instructions from their doctors. This could have application in cardiology, in geriatrics, in the various therapies, neurology, a whole range. And you can get all these scores and you can actually make sure that the patient's safe when they're at home, but also that they're compliant with the CAPE, because often patients will come back and say, I did X, Y, and Z, and sometimes it wasn't absolutely true. Or they thought they did it. There's that famous scenario of the patient who was an asthmatic and they said they took their pump and they were just squirting the pump all around the room instead of actually nailing it. So here's an example of improving compliance in terms of things that are prescribed. And it's super accurate. There's a number of vendors who actually offer this service. I'm going to go one back. Moving now just into the final piece, and I know that I've run, and I suppose we should also leave time for questions. We've been speaking through the day about using data and data sets. Okay, there's an issue here with using data to actually make it meaningful and useful, and this discussion was about the application of these tools. So what do we know? We can take claims data, clinical metrics, pre-auth data, remote data, member surveys, and we can actually make predictions. We can actually predict the patients who aren't going to go get their medicine. We know who they are. We can predict diabetes. We can identify pre-diabetic states. We can, with a degree of certainty, predict patients who are going to need a back operation. We can use the data to do these types of predictions. Okay, and what the question is now, how, if we've got all these data, okay, how can we then use it to great effect, to help people actually understand what they should be doing? And more than that, how can we encourage them to, if we know the information, how can we encourage people to actually take those steps to improve their health outcomes? So what we know, sorry, the click has got a bit of a delay. So what we know is if the patients actually do what they should be doing, we can have a massive impact on their health. And this is a study, and I won't spend time on it, but we know if we can increase physical activity, mortality drops dramatically. Okay, we all know this. If you ask your patients, they even know it. There's a small problem. We just don't do it. Okay. And the issue with that really is behavioral. There's this massive chasm between action and intention. Okay, and how do we breach or bridge that chasm to help people? It's science. It's behavioral science that has helped us actually understand these points. To say, what is it about people that actually doesn't, on a Sunday or a Saturday afternoon, you don't get off the couch and go for a run? Look, why don't you do that? There are various issues why that's the case. One is knowledge. You just don't know exactly what you should be doing. There's a few other issues around. You've got to know exactly how to do it. So sometimes people are confused. And we spoke, for example, in the medical industry, if you've got a headache, what do? Do you go to the pharmacy and get a tablet? Do you go to the neurologist, the neurosurgeon? Do you go to the physician? Do you go to the physiotherapist? Do you go to the psychologist? Like, how do you? So people don't know what to do. And that's why we need to help them, identify that there's a problem, and then help them actually identify what to do in terms of helping them solve their problem. So what we've done is we've taken 60 million life years of data for every single member in our various client medical schemes. And what we're able to do is use data science and advanced machine learning to identify the next best medical action for that individual. Okay? Independently. So that's for 3.7 million people. There's data scientists around the world helping work on this in our various locations, from the US, UK, Europe, Australia, and our local team in South Africa have been working on this now for several years. But we are excited that we are in a position now to start to bring this to life. So what would it look like? For those of you who happen to be Discovery members, not many of you won't, you might be familiar with this picture because it's a picture that we've used in our wellness products and our Vitality program for many years. There's this wellness ring, and I can tell you that that ring is very, very powerful. Okay? That ring encourages people to do things that you'd never believe. Because when that ring closes, the patient gets a reward. And what's the problem with all of us? Data science teaches us that we don't really have a relationship with our future selves. Okay? If you tell a patient, you guys as medical professionals done this often. You've told the patient, if you stop smoking in 10 years' time, you're going to be much better. Or if you do this, you can avoid diabetes or your disease of lifestyle. Or even in a shorter term, a more acute issue, if you do this rehab, your outcome of your care is going to be that much better. The problem is people don't know that person that you're advising. Okay, behavioral science teaches us that you don't have a relationship with that future self. So what we do know, though, if you reward that person for an action now, they're much more likely to do it. And that's what the reward in the middle of the ring does. So if you say, go visit your GP, and you get rewarded for that, your likelihood of doing it is dramatically increased. I can tell you we've seen this in wellness and fitness for many years. What we've now done is taken all that behavioral science knowledge and technology, and we've started to apply it to healthcare using data science and artificial intelligence. So what we'll do is we're looking at the activity, the speed of activity, the cadence by which we do, if a member chooses to do something that takes a long time to do, we allow for that. We also consider that in terms of encouraging people, what we need to do is create positive habits. And it takes a while to create a positive habit. And also, if you make something too difficult, you won't create that habit. So if you tell somebody, for example, that they should walk 10,000 steps, and they've never walked 10,000 steps before, 10,000 steps feels like they're climbing Everest. And it's just a bridge too far, they'll never do it. If you tell them walk 2,500 steps and then incrementally go to 10,000, the likelihood of doing that is greater. And those types of algorithms are built into our processes. The key thing, though, at the bottom is the instant reward. If you give somebody an instant reward, the likelihood of doing it is that much greater. And that's the premise for what we've created. So introducing you to personal health pathways. There's various other rings. Remember, the fund isn't taking over medical care. So you'll see, for example, the nature of the next best action will be go see your doctor or go get your medicine or do various preventative actions that are important. So it's about joining hands with the profession to help you with a tool to be able to encourage people to do these things using data science, artificial intelligence, and behavioral science to make this all hang together. So you'll see there's an empty ring. There's the patient had to go see their primary care doctor because they hadn't had a checkup. Maybe they were chronic. Maybe they just hadn't seen the doctor for a while, and the data algorithm picked that up. You then go, you'll see at the bottom there, visit your primary GP, complete a mental well-being assessment could be another one, or walk 2,500 steps could be another action. If they complete any of those steps, they'll get a reward, and that reward will be available in their cell phone. And I did this the other day because I'm on the beta plan. I'm testing this tool, and I went to Woolworths and I had a 100 Rand gift voucher because I did my healthcare behaviors. And I'm telling you, that's super powerful. People will do things for a cup of coffee. Let me tell you what they'll do for a 100 Rand gift voucher at Woolworths. Or Pick and Pay or wherever you shop. So lots of activity going on around this. From the doctor perspective, we won't go into this in too much detail because let's rather, being this is a roundtable and it's more around questions. And we had a bit of a hiccup with the tech. But this is the doctor health ID. The doctor will have their particular view of what the patients are doing. Remember, I started the talk with a piece saying, we started with personal care pathways and getting patients and doctors to connect. So that's critical. So if you've connected with your patient, what we'll do is we'll have your information on the health ID so you can see your whole database. You'll see there's various pieces where the doctor will know the personal healthcare pathways. We'll have other pieces where we're going to curate who the doctor should focus on more than others, dependent on their healthcare behaviors and their risk factors. So certain people need more care, others need less so if they're relatively well. If you think about the continuum of diabetics in a patient, you can have a very brittle diabetic who needs lots of care, or you need a very well diabetic who could be running marathons and they need less care. So there's a way to curate and make sure that you're focusing your attention and your resources on the most effective places. So that's what it's going to look like in terms of the doctor interface. Lots of different data points. It looks a bit complicated here, but once the doctors have got used to it, they will be able to navigate quite quickly to the areas of the tools and the dashboards that we provide quite quickly. They'll be able to pick up the next best action for a patient. Importantly, they'll be able to endorse the various care pathways and encourage patients. We know also that the patients pay attention to their doctors. So if the doctor endorses a message, the patient will get a message from their doctor saying, I've recommended that you do this. Okay, and we know that that's also a very powerful intervention in addition to the reward. So let me move then. That's what the endorsements look like. Okay, and those are early examples of what a message might look like. Dr. X has recommended your next best action for you. Importantly, and it came up several times during the day, in terms of the patient interface, WhatsApp is a very, very important channel. So we've created channels in different places through mechanisms that patients use. Okay, moving on to the next slide. I've spoken a little bit about what the impacts of these. These are just examples from other care delivery systems around the world, or where we've been able to have massive impact using some of these ideas, and these are the ideas that are being imported into the product that we've identified. One of the ways that doctors can get involved right now is through digital booking. Just lifting out of the slide, this middle panel. Most patients, when they've got access to digital booking, make appointments on weekends or evenings when doctors are typically not in their practices, nor are they practice receptionists. Patients want to do it at a time that's convenient to them. And as more and more doctors join the digital booking environment, okay, you'll find that compliance increases because patients are doing it when they want to do it. So very patient-centered. So any of you who are interested who aren't involved or don't have digital booking capabilities, Discovery offers it through Health ID. We've also got a partnership with a group called Recomed, and Recomed is the biggest provider of digital booking in South Africa. And they also integrate into our systems and others, and we convince them to offer doctors free trials to be able to try digital booking to see if it works for their practices. We're also going to hook digital booking into our personal healthcare pathways journey, simply because if you identify a personal healthcare pathway and the patient has the opportunity there and then to book an appointment, they have the likelihood of them completing that action will be that much higher. So in conclusion, our world is going to look different. That your practice day could look more like that than it does today, where this in-person versus digital versus looking at data versus hospital at home versus virtual consults will all be mixed up in a whole different world, okay, in terms of care delivery. In closing, I mean, my point that I made at the beginning is that doctors often just don't know what is the first step to take in terms of doing this. So what I hope to have done today is shown you a couple of options about how you can actually get your feet wet in this digital. Start with primary care providers, start with virtual consults, start with digital booking, and increasingly look out for our personal healthcare pathways, because that's going to be hopefully a massive boost both to patients but also to medical practice. Thank you for your time.
Thank you, Darren. I'm going to take one question, colleagues, in the interest of time. Is there a hand? Nothing in the room. Thank you very much.
Thank you very much, Darren, for your insightful presentation. I know that you guys support practitioners on the ground. Each practice is allocated a person to look after the practice. Thank you so much. I appreciate that.
Thank you.
Thank you.
For organizing the meeting.
Thanks a lot.
Thank you.
Thank you very much. Our last speaker for this session is Dr. Vuyo Gola, who is a medical doctor with several years in the managed care industry. She was recently appointed as the GEMS Chief Operations Officer on the 1st of September 2024, and she currently oversees the scheme's operations function, which includes healthcare management, administration and transaction services, member services, and information and communication technology. Welcome, Dr. Vuyogola colleagues.
Good afternoon, and thank you to Sama for the invite. I have to say, it's been a very interesting day. I've really enjoyed the talks, and I think congratulations, Sama, for putting this roundtable together. I may have been recently appointed as the COO, but I'm part of the GEMS furniture. I've been at GEMS in charge of healthcare for almost 10 years now. So I've been asked to talk about the digitization of healthcare. And, oh, there's a bit of a delay. I'm without wasting time, and I'm going to be very brief in the interest of time. I'm going to share with you how we use AI and how we use digitization of healthcare to improve the way we really fund certain programs and how we come up with innovative benefit design. So I think Mr. Mnyaka earlier spoke about the disparities in our healthcare system that we all know about. Is this not supposed to be on? So that I don't on the... I'll carry on while you try to fix that. I think we all know about the disparities in our country, and really all the more reasons why we need to find innovative solutions in terms of trying to bridge the gaps between those that really don't have access to healthcare, and also bridge the gap in terms of addressing the issues that... Not coming on. Okay, sorry. Addressing the healthcare needs of our members, and really within the private sector as well as the public sector. So we are the largest closed medical scheme in South Africa. We currently cover over 2.3 million members. What has been interesting about the growth that we've experienced in the past 5 years is that we are growing in membership of people that have not been medically covered before, so they've never had healthcare funding before. So you can imagine the complexities of having quite a significant percentage of a member base that it's still not on. A significant percentage of our membership base that has never been covered before. They come up with, especially in the older population, there's a whole lot of risk there. So really, in terms of using digitization in healthcare and artificial intelligence, this really helps us in terms of making sure that the service offering that we provide to our members really speaks to their needs. One of the examples is making sure that we fund digitalized healthcare services, which I will speak a little bit more about, using algorithms and machine learning to determine the clinical needs of our patients, to do clinical and financial analysis, and be effective in terms of how we deliver healthcare, as well as being efficient. And also creating solutions that will enable members to actually navigate the healthcare system a lot easier. And also help providers to interact and navigate the funding system. Okay, that's much better. Thank you. So in terms of access, we find that if you look at the GEMS membership base, and Mr. Mnyaka also spoke about this, there's a large population of our members that do not have access to healthcare services. So we've used Northern Cape as an example. So if you look at Northern Cape, and you look at the fact that 73% of GEMS members are in the Northern Cape, actually reside more than 50 kilometers from a specialist. And this would be physicians. We've used an example of a psychiatrist and a pediatrician, but physicians are also the same. So how do these people then get access to healthcare services? It's also a problem with other healthcare professionals like psychologists and psychiatrists, where you see that with Northern Cape being worse, but with the exception of Gauteng, all the other provinces actually have some deficiencies in terms of access, where members do not have any access to healthcare services within a specific or a reasonable distance. So what has helped us is the fact that through teleconsultations and virtual consultations, we've been able to then create access for these members. I do have to say, and someone did mention it earlier, that COVID changed the way we work. We've seen a significant uptake in teleconsults on GPs as well as specialists since COVID. And of course, I think a lot of people were more comfortable, or practitioners rather, were more comfortable once the HPCSA issued the guidelines in 2020 with regards to teleconsultations. So these numbers keep growing. And members and providers are actually embracing teleconsultations. So in terms of GPs, the increase in the last 5 years has been 25-fold. And for specialists, it's been sevenfold. So that is significant. That is a significant improvement, and really does bridge that gap in terms of people that don't have access to healthcare services that they need. We have seen, and this is just one example, and I'm not going to spend too much time on it, that the teleconsults and virtual consults actually form a broader part of a broader continuum of care. In our value-based care programs, like the one I've got on the screen now, is a multidisciplinary team that takes care of patients at the end of life. It's a palliative care program. The patient, and these are the patients that have opted that in the last year or few months of their lives, they don't want to go the aggressive route, they will be treated at home. Teleconsult and virtual consults play a very significant role in terms of the care of these patients. From a cost perspective, what we have seen is that one back. From a cost perspective, what we have seen is that the costs are significantly less in palliative care patients that choose to opt for the palliative program. And I think what's even more important and what's really, I think, rewarding for us is the fact that the patient experience is a lot better. So the patient satisfaction, the reported, patient outcomes and experience score a lot higher with the program, on the patients that are on the program versus the patients that are not on the program. Now, this is not to say, by the way, that the teleconsults now should be the only focus. They, our view of this is they have to be part of a broader continuum. And of course, the patient satisfaction is not only because of the teleconsults, it's also because of, I think, the overall experience that they gain from really being comfortable and dying with dignity, or being taken care of through their last months of their lives. But definitely the fact that there is accessibility to virtual and teleconsults, this makes a huge difference. I'm going to cruise through the next few slides. Okay, there's definitely a delay. Apologies for that. I have just mentioned only two of some of the digitalized healthcare services that we use. Healthcare funders, I don't think have a good reputation in terms of embracing technology. The costs are very prohibitive. I'm seeing Vuyani nodding his head. The costs are prohibitive, but we've come a long way in terms of embracing and finding ways of funding digitalized services like, for example, robotic surgeries, and we are continuing to do so. This is another example in terms of the continuous glucose monitors and insulin pumps for type 1 diabetics. And of course, these devices are also available for type 2 diabetics that are high risk and are poorly managed. And we've seen really good results on that. How do we use machine learning in terms of what we do on our day-to-day, when we run our day-to-day business? So by using these clinical algorithms, which are informed by healthcare learnings, and artificial intelligence, we actually are able to enrich our capabilities. And we are able to really cater to the needs of our members because we understand, we are able to stratify them from a risk perspective, and we are able to understand their needs. But I think even more importantly, we are able to come up with a benefit design structure that speaks to their need. So I'm gonna give two examples, DRGs. I think everybody's aware of DRGs. How have DRGs helped us? They've helped us in terms of developing ARMs. They've helped us in terms of monitoring and developing clinical pathways for our value-based care programs, as well as monitoring the matrix and the performance, because the value-based care programs, the focus is really on incentivizing the providers for improved outcomes. We're able to monitor our contracted networks providers to monitor their efficiency and address those efficiencies that we find. Patient episode groupers are also helpful in terms of looking at a patient event, identifying certain medical practitioners that really would benefit from getting a report that benchmarks them in regards to, in comparison to their peers, to make sure that at least they try and adjust and provide better care, quality care. It also assists us in terms of our population medicine and other value-based care programs, as I mentioned. In terms of the solutions and applications that we have, I'm really not going to spend time on this. We do have an interactive provider platform that we launched last year. We used to have an old platform and we launched a new one that is more interactive, and it really helps the healthcare providers in terms of engaging with the scheme. Darren spoke about, how long it takes to actually pick up the phone and call. Doctors don't have time to call centers, but it's easy to use this interactive app or digital platform where they can actually get information that they need at a much quicker rate. We also have a member app where our members are empowered with the information that they need. And this helps us a lot in terms of chronic disease management, as well as in terms of just health prevention, screening, and encouraging members to go for screening and preventative care. So in closing, really, I think it's exciting for us to be part of these platforms because we are able to network and engage, and we're able to talk about how we can move forward together and collaborate in various ways to try and embrace all these technologies. Thank you very much.
Thank you very much, Dr. Gola. Are there any questions, colleagues? No questions on the floor? Are there any questions online, Ati? Oh, your presentation was just brilliant, you know. I think we can ask questions during the tea break as well. So I'm going to invite Prof. Dai to hand over our token of appreciation. Thank you very much.
Thank you so much, Vuyo, for sharing the GEMS experience initiatives with us. It's really heartening to see how the funders have actually harnessed the technology and moved forward towards equitable access to healthcare. So thank you. And this is just a small token of our appreciation to you. Thanks. So we now move into what is the final graveyard shift. And we have with us two presenters from outside the country. You will see in the program we have UK and followed by US, but we're actually going to be swapping the order. And we'll start off with Dr. Jess Ehrenfeld, who is going to talk to us on AI and its application in health in the US. Dr. Jess Ehrenfeld was inaugurated as the 178th president of the American Medical Association in June 2023. He is a senior associate dean, tenured professor of anesthesiology, and director of Advancing a Healthier Wisconsin Endowment at the Medical College of Wisconsin. He divides his time among clinical practice, teaching, research, and directing a multi-million-dollar statewide health philanthropy. He is also consultant to the World Health Organization Digital Health Technology Advisory Group, and he previously served as co-chair of the Navy Surgeon General's Task Force on Personalized and Digital Medicine. His research focuses on understanding how information technology can improve surgical safety and patients' outcomes. And of course, the list goes on and on and on. But in the interests of time, I will stop here and hand over digitally, virtually, to Dr. Jess Ehrenfeld to take us through AI and its application in the US. Over to you, Jess.
Wonderful. Thank you so much. I hope everybody can hear me okay. And it looks like you've got the slides presented. This has been a really fascinating program, and I'm so happy to present on behalf of the American Medical Association. I really appreciate the entire organization inviting me here today. You know, all of us understand that the landscape of medicine is always changing. It's changing for patients, it's changing for physicians. And so it's essential that we take the opportunity to share ideas, renew the bonds of international cooperation as we're building a common framework for medical practice and ethics that can be duplicated around the world. And that's especially true as we enter into what is an uncertain era when it comes to AI development in healthcare. So I approach this issue from a very wide lens. My work at the AMA as immediate past president, as director of the largest public health philanthropy in my state, and I continue to see patients, obviously, as a physician. I was in the operating room 2 days this week. There's not a day that goes by where I don't see opportunities for technology to work better. And we all know that AI has incredible potential to transform healthcare for better or for worse. So we need to be careful about how it's designed, how it's used, how it's integrated into existing systems. This is an exciting time for medicine, but the stakes are high. When I look at the current development and implementation landscape for new digital tools, AI-enabled technologies, it can be a lot more difficult to understand when an algorithm is working as expected and when it is not. There are real concerns about liability for digital health tools and technology simply becoming another burden physicians have to bear. We've got to ensure that we do not lose trust and confidence of the public in the tools that are coming into the marketplace. Look, we all live in a fragile world. Trust in science, regulated products, advice from regulators, advice from government agencies is at risk of being ignored. We cannot allow openings in product development life cycles, the regulatory framework, to exacerbate this global problem. So I'll give you a little bit of perspective in my time this afternoon about how the AMA is approaching AI in healthcare, and I hope that some of these approaches can be useful to you all in South Africa. So on the slide here, I've got the 4 key drivers of adoption of any technology by physicians. And we spend a lot of time trying to understand how physicians are using and adopting tools. And the first question that physicians want to know, whether it's an AI-enabled device or not, is does it work? And this used to be relatively simple. You know, we would have a package insert, studies that went to the Medicines Regulatory Agency, the FDA in the US, to understand why a product should be approved. But what level of evidence ought to be required for a digital health tool or an algorithm? Nobody has an answer to this question right now. And so we're stuck wondering, how do we know when it is appropriate for us to bring an algorithm or a tool into clinical practice? The second issue is payment. If we go through the acquisition cost for a digital health tool, how to actually receive reimbursement for the cost of actually bringing these technologies into my practice in my health system. The third issue is liability. What happens when something goes wrong and a patient is harmed? Who is responsible? Is it the end user, the clinician? Is it the product developer? Is it the health system or the system implementer? What if it was an algorithm that had underlying poor data, that was biased, that led to harm caused for a patient? Is it still the clinician's responsibility if an outcome is poor? We don't have a framework for handling this in the United States. I think this is a global issue. Finally is the issue of, does it actually work in my practice? And I will admit, I have built technology as a AI tool developer, and I have made this mistake. I have turned on software in our children's hospital that we had validated, built, deployed in our adult hospital that did not work. Because I know, you all know, that children are not small adults. The workflows are different. We have to make sure that systems are validated appropriately in the care setting that they're actually used. And so the final question is, does it actually work in my practice, is a really, really important question. We can go to the next slide. So at the top of a lot of physicians' mind today is AI and about the uncertainties. What about the standards in the regulatory environment? We're trying to help physicians harness the power of AI in some specific ways, giving them a voice in the design and development of new technologies, providing training and resources and support, producing trends and analysis, and of course, guiding policies that will help application in healthcare. And it's really clear that physicians are excited. In our latest nationally representative sample of US physicians, 41% say that they're as excited as they are terrified about AI in medicine. They see the promise. They see the opportunity to make us better diagnosticians. They see the need for improved workflow efficiencies. But there's concern. What does AI mean for my relationship with my patients? What about privacy? How do we make sure that bias does not get incorporated into the design and development and deployment of these tools? 90% of US physicians want clear information about how these tools were developed. How do we make sure that they work? And how do we make sure that they don't actually make things worse for our patients? Go to the next slide. So our chief responsibility really is to make sure that when it comes to new health technology, that it's an asset, not a burden. There's so much riding on all of our shoulders as we're trying to get through our days, meet the demand that our patients and our systems are putting on us. There's too many burdens on our shoulders, and we can't allow technology to add more. How do we do this? Well, we're trying to elevate the physician perspective to the front end of healthcare technology development. We're doing this in a whole bunch of ways. We have a firm called Health 2047 right in the heart of California's Silicon Valley. It's a for-profit venture studio created by the American Medical Association. It's a subsidiary that brings together technology entrepreneurs, physicians, designers, stakeholders to produce innovative health technology companies that have products that actually work for physicians. The entire goal of this collaborative effort to return physicians' time and attention to their patients. Okay, next slide. We are clearly at the top of the hype curve. People are really excited. There's an incredible amount of capital and investment being put into AI, but I will tell you, it's going to be a bumpy ride as we go to the bottom of the trough of disillusionment and ultimately eke out towards that plateau of productivity. Next slide. There continues to be significant uncertainty about the regulatory approach in the US. The US FDA, the Food and Drug Administration, does not have a paradigm today to really deal with AI-enabled algorithms. And even if they had a paradigm, they could never hire enough product reviewers, regulators, software evaluators to look at every algorithm that is starting to flood the marketplace, let alone the software changes when those algorithms are updated. We have to make sure that only safe, high quality, clinically validated AI is brought into the marketplace. We have to make sure that AI does not introduce bias into the results. But globally, regulators across the globe are trying to sort out how do we make sure that we have a regulatory approach that works. Okay, you can go to the next slide. Thank you. Now, of course, liability is a major concern, and I mentioned this briefly. Liability resulting from an inaccurate AI model or the misuse of a model is an area of great interest in the medical legal field. So what happens if an AI tool recommends a prescription based on a patient's data? A physician prescribes that medicine and a patient has a bad reaction. Who bears the burden of responsibility? Is it the physician, the company that owns the AI algorithm, or the individual or the team that built and trained the AI tool? Last year, the AMA released our principles for AI development, deployment, and use, which I'll talk about in a second. Those principles specifically highlight issues of liability and transparency with AI, and our principles underscore that it's critical that physicians understand AI-driven technologies, have access to information about the tool or the system being considered, including how it was trained and validated. So we have some information about the quality, performance, equity, and utility of the tool. Transparency regarding the design development should be mandated by law, we believe, and potential sources of inequity and problem formation and inputs and implementation ought to be visible. We've got to understand as physicians that when we use an AI-enabled tool and there's no transparency, that our risk of liability for reliance on that AI is likely going to go up. The need for full transparency is greatest where AI-enabled systems have direct impact on patient care. An AI-enabled medical device, an AI tool providing clinical decision support, even interaction with an AI-driven chatbot. Given the vast range of AI's tools, applicability in healthcare, administrative use cases, where maybe there's less direct impact on clinical decision-making, to use cases that more directly support clinical decision-making, the question of liability is critically important. In a letter that we sent to every state medical licensing board across the United States, all 51 jurisdictions, we urge that the individuals or the entities best positioned to know the AI system risk and best positioned to avert or mitigate harm, they ought to be the ones that do so, and they ought to be the ones liable if there is a problem. That may be the developer. That may be the person using the tool. But we have to make sure that the liability is appropriately placed. If we do not place liability appropriately, then physicians will not use these tools. Okay, next slide. I get asked frequently about large language models, and I will tell you that even the most advanced algorithms or AI-enabled tools, they cannot diagnose and treat disease. That's the wrong approach. AI is very good for a textbook patient, solving a narrow clinical question, boosting my capabilities to see a disease that ought to be in a differential that maybe is not common. But AI tools can't substitute for judgment, nuance, thought, especially in the absence of clear evidence to make a prediction. But that's not to say that these tools and algorithms can't help physicians. Imagine a tool that seamlessly integrates into our electronic health records, that provides predictive text for our notes. These tools, large language models, ChatGPT, are only becoming more and more advanced, but even in their current form can be important tools to tackle burdensome administrative tasks like finishing my notes at the end of the day. All right, next slide. I mentioned our AI principles that the AMA has put out. These are not new. They go back to 2018. We've been thinking about this space for a long time. We did a major refresh a year ago in November of 2023. And the principle's purpose is to provide guidance to physicians on how to best engage with these new AI-enabled technologies. And the principles encourage a comprehensive government approach to governance to mitigate risks to patients. The QR screen on the code will take you to the principles on our website, but I've highlighted a couple that I think are worth mentioning. I can't get through all of it. It's a long document. Above all else, healthcare AI has got to be designed, developed, and deployed in a manner which is ethical, equitable, responsible, and transparent. And healthcare AI requires a risk-based approach where the level of scrutiny, validation, and oversight should be proportionate to the potential overall for disparate harm or consequences that the AI system might introduce. Next slide, please. So the AMA principles, there's a lot in there. And again, it's important that a clinical decision influenced by AI has to be made with specified human intervention points during the decision-making process. And as the potential for harm goes up, the point in time when a physician should utilize their clinical judgment to interpret or act on a recommendation, that's got to occur earlier in the care plan. And of course, to address some of the pain points that I mentioned earlier, all of the burdens rising on our shoulders, the implementation, the utilization cannot exacerbate clinical burden and should be designed and deployed in harmony with the clinical workflow. So to close, I'll say that AI and machine learning algorithms will transform how we work. It shouldn't be thought of as the human versus the machine. The sum is truly greater than the parts. There's enormous potential to scale capacity, telepresence, virtual monitoring, remote care delivery. But remember, AI won't replace physicians, but as the last slide shows, physicians who use AI will someday replace those who do not. I'm so appreciative of the time to be here. Thank you for having me, and best wishes for all of you for a wonderful conference.
Thank you so much, Dr. Ehrenfeld.
And I should just mention one thing. Of course, those are my beautiful children, and my husband on the left was born in Johannesburg.
Oh, wow. Yes, thank you for a very enlightening presentation and for emphasizing the human-centered healthcare approach, and more especially the principles of ethical, equitable, responsible, and transparent in the approach that you've taken in your part of the world. And I'm sure that ought to be the approach generally and globally. So it is the graveyard shift, but I'm looking at the audience. Are there any questions for Jesse? Okay, there is a question right out here. So someone is awake.
Hi, Jesse. I hope you can hear me. My name is Vuyani. I'm with a company here called Cure Medical. Thank you so much for a wonderful presentation. I think mine is, I guess, partly a comment and partly a question. From a comment perspective, I think what is exciting about us is that given the novelty of the technology, it is clear that we are all wrestling with the same issues. And I think for me, it's a very nice challenge to the South African Medical Association and various other, I guess, African organizations to not necessarily turn to the US for light in this regard, but to find ways to collaborate. Because sometimes what happens is that we tend to take a back seat and often have to wait many, many years before we get any form of direction in South Africa, waiting for a steer from the US. And so I'm keen to understand how we could, I guess, collaborate more meaningfully as countries as we all try and solve and grapple these very important problems. Thanks.
Thank you so much for that. Look, here's what's going on. We need to figure out a framework, and I know on tomorrow's program, there's going to be some conversation about this, to build local capacity to develop and deploy these tools. There will be things that are built in Silicon Valley that will be very helpful to you. There will also be a lot of things that will not work at all. We have seen examples of glorious failures of tools from large health systems, household name medical centers, when they were exported to another health system in the US, it did not work because of changes in systems, because of different ways that data and workflows, data are collected and workflows occur. You could imagine that problem is amplified when you're talking about trying to take tools and move them across global borders. That being said, my perspective in the US at least is that we need to create capacity in small clinics, in rural health systems, in regional medical centers to do their own development and validation of tools. We may have common problems and use cases, but the data are going to be unique to the clinical environment that one is working in. That kind of capacity building is something that we need to figure out how to do globally. I think there's a really easy opportunity to share some of those best practices between the US and South Africa.
Thanks. Thank you so much, Jesse, for that. And yes, whatever we do will have to be contextually relevant. And even if we are going to be building capacity within our local clinics and our rural healthcare facilities, it depends on who the we are. For whatever we do, we need positive political will. And I think that needs to be something that we as advocates for our patients will need to take forward. And I think Sama can lead this advocacy towards trying to get that positive political will implemented for the health of our nation. Thanks, Jesse. Is there any other question, comment? Nothing online, Attie? Okay, so if there's nothing else, thank you so much for accommodating us, Jesse. I know we've been running late and you've got another commitment to go to. Appreciate you stayed on a little longer. And I think we'll now move on to our speaker from the UK, just to hear what the UK perspectives are. And that is Mr. Dominic Norcliffe, Mr. Dominic Norcliffe Brown. And he's going to talk on AI and its application within the UK. So Dominic is a policy lead in medical ethics and human rights at the British Medical Association. He specializes in a number of areas of medical ethics, including moral distress, abortion, LGBTQ plus healthcare, research ethics, and artificial intelligence. He regularly gives talks and advises clinicians on these matters, and he's published extensively in these areas. Dominic sits on the World Medical Association's Medical Technology Work Group and is a member of its AI subgroup. He is an expert advisor in health-related human rights issues and has written extensively on contemporary issues in the field, including the report Health and Human Rights in the New World Disorder. Dominique has a degree in politics, philosophy, and economics from Oxford University and a master's from the London School of Economics and Political Science in comparative politics, specializing in ethnic politics and nationalism. And Dominique, thank you so much for accommodating us, especially the swap in the program as well. So over to you, Dominique.
Thank you, and thank you for that very kind introduction. You might call it the graveyard shift, but I would argue it's saving the best until last. Thank you. Real privilege to be addressing Sama on this incredibly important and salient topic. So as Professor Dye said, I'm a policy lead in medical ethics, human rights at the BMA, and the timing could not be more impeccable for us as we've just released quite a substantial report on AI and its application in healthcare in the UK. Let's move on to the next slide, please. Or have I got control? Next slide, please. Thank you. So just to give a quick overview of what I'm going to talk about today. So I'll just give a quick summary of the history of AI in healthcare in the UK, talk about some of the potential outcomes of AI in healthcare, some of the drawbacks, some of the potential benefits that could occur from the application of AI, and then how the BMA approaches this issue, and similar to Jesse, the principles the BMA has developed for engaging with the application of AI in the UK healthcare system. I think it's important to note, as some of the other speakers have, and indeed as that question to Jesse just talked about, is that AI, in its use in healthcare is going to be somewhat universal. It will not abide necessarily by the rules of borders. So do forgive me if I do cover some ground that's already been covered, but I will try to give it a UK spin, as it were. So moving on to the next slide, please. So AI in healthcare in the UK is not a new idea at all. In fact, it goes back to the 1940s, just Morley from the Oxford Internet Institute note that was the first time people started discussing the applicability of AI in healthcare in the UK. But started to gain real enthusiasm from the 60s with the development of Bayesian methods, pattern recognition methods, machine learning, natural learning processing, and of course, most recently, what are known as foundation models. And I think that is one of the key reasons why there is such interest in this field, that there is such an appetite to channel the potential of AI into healthcare, both for clinicians and indeed for healthcare systems in and of itself. So in 2019, who was then the National Health Service for England Chief Executive, Simon Stevens, set out a call for the NHS to become a world leader in the use of AI. Since then, there have been dedicated funding pots have been made available to foster and develop AI for use. And at the spring budget this year, before our general election, the then Chancellor announced further funding of over £1 billion to invest in AI in England. And simultaneously in Scotland and Wales, both their NHS systems are looking at AI. Nevertheless, despite all this enthusiasm and excitement, the genuine applicability of AI in real world settings remains quite limited in the UK at the moment. And a lot of the potential of AI remains theoretical. It's not actually known how many doctors in the UK use AI in their day-to-day working lives. Studies suggest that awareness of AI is not widespread amongst doctors and medical students. And although there are increasing opportunities for doctors to become involved with AI, there are still limited structured pathways for doctors to engage with AI. So despite all the noise, there's still some limited applicability, but is of course a source of great enthusiasm and concern for both clinicians and patients. And so from the BMA's perspective, we want to get on top of this, as it were, before its use becomes more widespread in our healthcare system. Next slide, please. So I suppose to get on top of AI, we actually need to know what we're talking about when we use the term artificial intelligence, and herein lies a lot of the problem. A lot of people cannot agree on what exactly is meant by AI. I think, historically, a lot of laymen, when they hear AI, they think of the sort of thing you see in certain science fiction films, the concept of, AGI, artificial general intelligence, something that could, fully mimic human cognitive abilities, be able to understand and learn any intellectual task that a human can do. But despite that being the concept behind a lot of brilliant films, it's not close to happening and frankly not really relevant to healthcare. So we often consider AI in quite a narrow prism where it's limited to quite specific tasks. And these are often the UK government has a working definition of AI, that machines that perform tasks normally performed by human intelligence, etc., etc. And you can see on the slide, I'm not going to read all of that out to you, but there is a problem in and of itself with this, which is that tasks normally performed by human intelligence is not well defined and may well change over time. For example, a pocket calculator can do maths, and it can do maths that we might argue is beyond the reach of many intelligent humans, but we do not tend to consider the average pocket calculator to be AI. And indeed, often AI researchers will argue that as soon as machines have conquered a task that previously it was thought only humans can do, it is no longer considered a mark of intelligence or AI. So with all that in mind, how do we, as the British Medical Association, look to define AI? And the kind of neat answer to that is that we don't necessarily think it's our job to provide a clean definition of what AI is. What is fundamental for the BMA is to understand what AI is understood to be in the healthcare context, and therefore its applicability to those who work in healthcare and those who use healthcare. In other words, the population at large. Next slide, please. So with that in mind, we focus on AI technologies that are either currently in use in the NHS or in other healthcare settings, or technologies that have been developed and may be used soon. And these can include machine learning, natural language processing, visual and image recognition. And that last one's quite fundamental, really. The use of AI in radiology has become huge and has been very well received. So the key use cases currently in healthcare are firstly around healthcare organization and administration. And this is, using AI, for example, natural language processing around staff rostering and appointment scheduling, to deal with repetitive administrative tasks such as note-taking, transcribing, and also the analysis of patient feedback to improve quality improvement. So example of this, at Imperial College Healthcare NHS Trust, there's been a pilot using a natural language processing system to analyze patient feedback in real time. And that's led to responses to said feedback to be implemented much faster than they would have been without the tool. A second example relating to diagnosis and treatment would be around clinical decision making, and that would of course be CT, MRI, or ultrasound scans using AI pattern recognition software. Around service delivery, AI-based apps, bots, personal smart devices that can provide health information and also support patients stick to prescribed interventions. And I think it was quite interesting to hear, forgive me, I can't remember the earlier speaker's name, but speaking about their personal health AI app. I think another example of those is a Sleepio, which is a 6-week tailored program that is delivered online and it's designed to help treat insomnia. And that therapy is personalized using AI that tailors the intervention to the individual patient's data. And of course, there's population health applications, which could be used to look at epidemics, disease spreads, drivers of illness, and individuals and groups at particular risks of developing particular diseases that could gain from proactive early intervention. And of course, finally, there's also biomedical research. I've got some examples of that, but I am terrible at sticking to time, so I'm just going to crack on ahead if that's okay. But those are the key uses in the UK where we see AI having major applicability within the healthcare system, though they are very broad categories, and I will delve into some of that a bit more. So next slide, thank you. Oh, you're well ahead of the game there, thank you. So firstly, in terms of the outcomes that we see from AI in healthcare, we see this operating through 3 primary mechanisms. The first is precision and personalization. We know that AI can outmatch humans at performing certain, and I emphasize the word certain, healthcare tasks with accuracy. And that the most obvious example of that is accuracy in imaging diagnostic processes around radiology and things like that. It can also provide much more personalized information, which can make medical interventions more accurate and precise. Secondly, there's efficiency and productivity. AI imaging and clinical decision making allow the possibility for quicker and more efficient healthcare interventions. And there's also the kind of quality and efficiency gains to be made to the healthcare system from applying AI technologies to more routine everyday tasks. It's estimated by McKinsey that routine administrative admin tasks can take up to 70% of a health practitioner's time, and any attempt to address that is surely a good thing. Thirdly is around prevention and early intervention, so looking at population demographics, disease prevalence, and geographical distribution to identify patients or patient groups at higher risks of certain conditions. And as we know, prevention can be a major way of reducing costs and burdens on healthcare systems as well. Next slide, please. So this map, I think, is quite a neat summary of the potential healthcare benefits outcomes resulting from AI. You can see from the final element of that map, there are kind of 3 main groups that we would expect to benefit. One is clinicians and healthcare staff in general, through better job quality, recruitment and retention. The second is better care quality for patients. And the third is the benefits to the healthcare system itself through increased efficiency and reduced costs and the like. So I think what I've kind of covered so far is the theoretical, if everything was great and glorious about AI, this is how we could see real positive impacts in healthcare in the UK. But as I started by talking about, a lot of this is quite hypothetical and quite theoretical at this point, while the applicability of it in a very large bureaucratic system such as the NHS remains somewhat abstract and not being utilized to the extent people may think it is. So there are also the risks that are attached to AI and its application in healthcare also. Can I have the next slide, please? And what's been really important for us at the BMA is to recognize that the implementation is what matters. And whereas AI could be very beneficial in one area, it could also negatively impact in that area if it is not implemented in the correct way. So there's several areas we've kind of identified where we can see where there could be pros, but there could be cons to its implementation. And, for example, starting with health outcomes, I've talked about how the greater precision of AI could lead to improvements in diagnosis and treatment, which could lead to better outcomes for patients. It could reduce the risk of errors. Excuse me, but alternatively, there are potential risks around this as well. A review from the Panel for the Future of Science and Technology has described three main patient safety risks from AI technologies in healthcare. One is false negatives in the form of misdiagnoses of disease. Second is unnecessary treatment from false positives. And the third is unsuitable interventions due to imprecise diagnoses or incorrect prioritization. Now, I'm sure some of you will have noticed, but all three of those things could occur already. There are already risks in healthcare, but the underlying reasons behind those risks could be unique to AI, due to, for instance, the using incomplete data sets, incorrect data sets, or indeed AI's blindness to the concept of a person as a person, viewing them as a whole as opposed to looking at particular areas. So the second area is inequalities. Again, potential benefits include the fact that some of the unfortunate societal biases which we know permeate through healthcare, such as evidence suggests that doctors can think women exaggerate the pain they're feeling. Doctors can also think that ethnic minorities can withstand more pain than those who aren't, and that can, of course, be extremely damaging to health outcomes. And AI could be designed in such a way to be immune to some of those biases. But again, on the risks, AI depends on the data you put into it. If the data put in is imbued with these biases, then AI could exacerbate that problem. There's also the risk of digital access and digital exclusion. And we know that the poorest in society are most likely to be excluded from access to technologies. 7% of the UK population do not have internet access in their homes. And if we were to prioritize AI usage, that could further disadvantage those who are already in a vulnerable position within society. Thirdly, the doctor-patient relationship. AI could improve the doctor-patient relationship by freeing up doctors' time, freeing them from an admin burden so they can spend more time with each patient. And that's a big problem we have in the UK, is that people do not feel they know their doctors well because their doctors seeing so many patients, have so many things to do. But conversely, AI could cause damage to the doctor-patient relationship. There's a lot of interest, for example, in using large language models in the consent-seeking process. But if you just use a bit of software to seek that consent, that could form a barrier between the doctor and the patient. The patient could feel alienated. That could lead to distrust, and that could be damaging to the relationship between the doctor and patient, and thus overall patient care. Fourth is around transforming the nature of work. There are some studies which estimate 35% of UK jobs could be displaced because of AI. It's extremely unlikely this will happen to doctors, as Jesse had already discussed. This doesn't look like it's going to happen. The nature of doctors' work means that while they won't lose their roles, there is a likelihood of the nature of that work being transformed. We've already seen that in radiology in the UK, and it's one of the reasons why radiologists are some of the least concerned about AI in the UK, because all that's happened is that what they do has changed to accommodate AI, and they found that to be quite beneficial. But again, this will depend, and the nature of that transformation will depend on the implementation of AI. And fifth is around job quality and work. Burnout is a huge problem in the UK. About 30% of NHS staff experience burnout. If we can reduce the workload for staff, then we can reduce the risk of burnout, either if they're doing simple clinical tasks or admin tasks on behalf of clinicians. But again, also AI could present new pressures here. If, for example, AI takes all the simple tasks and doctors are left with just the complex cases which put them at the limit of their skill set, then doctors could face an increased risk of burnout because they're constantly having to push themselves without any respite from very difficult tasks. And then finally, of course, there's efficiency and healthcare costs, which I've already talked about. But for example, the Topple review estimates that about 5.7 million hours of GP time could be saved annually by AI. But then, of course, it's not necessarily true that AI could reduce these costs and increase efficiency if implemented poorly and not in line with the healthcare system that it's found. It could be quite damaging if it's kind of thrust in without due consideration for the wider healthcare environment in which it finds itself in. And it's important to remember all of these factors, of course, do not exist in isolation. They are interrelated and they impact and have knock-on effects on one another. Next slide, please. So, the conundrum for the BMA, and I would argue for a lot of medical representative organizations, is how to ensure that the effects of AI in healthcare going forward are positive for members, for clinicians, and also for patients as well. And I think one of the things we keep in the forefront of our minds is that AI is neither a panacea nor a intrinsically destructive force. AI is a tool. And what I hope I've tried to draw out through a lot of what I've talked about already is that what AI's impact will depend on is how it is implemented, whether it has in the forefront of its mind clinicians, patients, and the healthcare system in and of itself, as opposed to short-term potential cost-saving measures or technology for technology's sake. And it needs to be symbiotic with the healthcare system that exists to help that healthcare system improve and further develop. So with all that in mind, with this greatly increased interest in healthcare, AI healthcare, in the next few years, the BMA has developed some principles which we'll be using to engage with the government, with the NHS, about how we believe AI should be utilized in healthcare to maximize its effectiveness for all involved. Next slide, please. So those principles are, firstly, as discussed, and as I would assume would be self-evident, is that it needs to be robustly assessed for safety and efficacy in clinical settings. This obviously cannot be rushed into healthcare systems because the impact could be catastrophic, not least to the patients and the risk to patients, but also to the healthcare system as well of introducing ineffective technology. And the old Silicon Valley slogan of move fast and break things really is the complete opposite of what we would like to see when it comes to healthcare. Bear in mind just how important that is, and one just needs to consider the case of Theranos to recognize what a dangerous approach that would be. So it needs to be well evidenced, be effective, safe, ethical, and equitable. And we need to make sure the risks and harmful consequences must be properly understood and accounted for, including the risk of bias and of the risk of widening inequalities. And we also need to make sure that vulnerable patient cohorts, such as those, for example, with reduced decision-making capabilities, should not be disadvantaged or suffer harm through AI healthcare technologies. Second is around governance and regulation, and that's to protect patient safety. We need to make sure regulation, standards, and guidance must be strengthened to safeguard patient safety, with regulators empowered to stay up to date with development and enforce legislation. Now, again, similar to what Jesse was talking about, we are in a quite similar position in the UK. The legal landscape to govern AI is something of a patchwork mess covering several things, and nothing is currently equipped well enough to deal with it in of itself. The Medicine and Health Products Regulatory Agency is supposed to cover this, but it's really not set up to do this at the moment, and neither are our regulations around UK medical device regulation. A lot of this is straddled between complex tapestry of laws involving medical device law, liability laws, data protection law. I could go on, but the point being, at the moment, there is not a kind of uniform or or clear understanding of exactly what regulation applies here, and that needs to be crucially developed. Third, again, staff and patient involvement throughout the development and implementation process is necessary. This needs buy-in from both staff and patients, or it's never going to work. They are the end users at the end of the day, and if they do not trust the technology will not work. It will not be used enough potentially, or patients must be able to opt out from using it as well. And that will require public communication, similar to other health messaging, and needs to target the right audience. When we also recognize certain communities are more distrustful of healthcare than others. And as part of that, this is also part of protecting the doctor-patient relationship, and AI should be used to complement rather than replace face-to-face care and human decision-making. The next point is that staff need to be trained on new technologies initially and continuously. Again, I think there's some self-evidence to this, but staff need to understand what it is they're dealing with and how it works, at least at a fundamental level, without needing to know all the nuts and bolts of exactly the technical aspects of the AI. And there would have to be an increase in digital literacy amongst healthcare professionals to handle this. But a further point to that is that doctors will still need to be trained in the skills that AI is covering. We do not want to see a de-skilling of doctors, because firstly, they may not be able to understand in future what the AI is doing. And secondly, if the AI is discontinued, then they will not be able to perform the tasks that are required. Another point is that the successful AI will require a robust and functioning NHS to be effective. Again, anyone who's familiar with the NHS will know it has some quite severe problems at the moment. And as I've already said, AI is not a panacea. It will not solve all the problems of the NHS. In fact, it may well exacerbate them. And without sufficient funding, without sufficient staffing, and without the suitable infrastructure in place, AI's impact in the NHS will not only potentially be negligible, it could be actively harmful. And leading on from that point from infrastructure, we need to look at the IT infrastructure of the NHS, which is a notoriously shoddy, I think it's fair to say. We can talk about a single NHS trust having tens, if not hundreds, of different sources, and then stored on systems with little or no interoperability. And then they're trying to capture and share high quality data. This is impossible. An AI system won't be able to handle that. So there needs to be a comprehensive overhaul of the NHS system in the UK to modernise it, the NHS IT system, to allow AI to operate effectively within that ecosystem. And then finally, but far from the least importantly, is legal liability. Jesse talked about this as well, and this is absolutely key. At the moment, under existing law, a doctor treating a patient has a legal duty to provide reasonable care, and when that care falls below that standard, then the doctor is liable and the patient can bring damages. However, when we've got a complicated AI system, where exactly should liability lie? If a doctor has been told this is safe by their trust, by the NHS, but then it turns out there's a problem, where does the AI developer sit in all of that, as they must share some responsibility, as indeed the people who okayed the use of this system as well. They almost must bear some of the burden here. And currently, this legal liability is not clear at all, and it's a key reason why our members are reticent about this, because as clinicians, there's always that risk, that legal risk here, and if they don't understand what they're using and could be liable for it, that's a great problem for them. So we need clear lines of legal liability to be established, and that must include the AI developers. And as part of that, doctors have to have the ability to challenge decisions made by AI. Next slide, please. So thank you all very much for listening, and that kind of quite brief whistle-stop tour of AI in healthcare in the UK. I've left a link there to our report, which covers a lot of what I've mentioned there in greater detail. And there's also my email address too. I'm very happy to exchange further with anyone on any of the issues I've discussed. I'd just like to finish by saying thank you very much for the invitation. It's been an absolute pleasure to address you all, and happy to take any questions. Thank you.
One, two, one, two.
Oh, yes, it's working. Thank you, Zianda. So thank you so much, Dominic, for sharing the UK experience with us and also the outcomes, both positive and negative, and stressing the principles of AI in healthcare being safe, effective, ethical, and equitable. And I think these principles would apply globally wherever AI in healthcare is used. I'm going to open the presentation to the floor. Should there be any questions or comments? Is there anyone that has a question or a comment for Dominic? I was going to say they've understood your presentation so well, but it seems like the chair of SAMA hasn't. Over to you, SAMA chair.
Hi, Dominic. Thank you so much for your presentation. The last time I met you, it was in Finland. Yeah, Dominic, I just want to know, what's the reason you are focusing on the NHS AI tools and not the others?
Well, thank you, my friend. Really good to see you again as well. Yeah, so that is more of a structural way in terms of the BMA and how healthcare in the UK works. So when we look at those more private elements around personal AI healthcare devices, like the excellent speaker earlier talked about, we don't generally consider that too much to be within our remit because we have limited ability to impact or necessarily influence that. So as the trade union and professional association for all doctors and medical students in the UK, we regularly speak to the UK government and the NHS about processes and tools that are used within that system, and we get to speak with one voice on that. And because of the nationalised healthcare system, that is where we have more of a voice, really. I'm very happy to privately talk about some of those things, but I think some other speakers might be better placed to do so.
Thanks. Thank you, Dominic. Is there any other question? Anyone online, Atty? So there isn't anyone online either. So it's just left for me to thank you, Dominic, for joining us, for agreeing to the swap and the lateness of presentation as well. We thoroughly enjoyed your presentation, and also what you shared with us in terms of what's happening in the UK. Thank you so much. So we've now reached that time in the afternoon where the CEO was going to give us a full summary of the day's proceedings. And honestly, we're all fast asleep at the moment. So I don't know whether I should say I've relieved him of those duties or I've been kind to the audience. So, so we'll do the summary tomorrow at closure. We'll summarize both days' proceedings. I just want to thank the presenters from today. I want to thank our delegates in the audience. You've been a very engaging audience. Also our technical support and our logistics support. Thank you so much for today. And we'll see you all tomorrow at 9 a.m. Okay, safe driving. And to our audience online, thank you for staying with us the entire time. And we hope you log in again tomorrow. Good night.